Here, we thought that we will pick up the topic of gallbladder cancer, which, though uncommon in the Western world, is one of the commonest cancers in North India. In fact, in women in North India, other than the gender related organs, that is breast, cervix, and ovary, gallbladder is the commonest cancer. And out of that also we picked up the theme of or the topic of incidental gallbladder cancer, because that is the cancer which is eminently treatable, potentially curable, but often neglected or not properly treated. So we thought that it is the need of the hour that we discuss and then formulate guidelines for proper and appropriate and timely management of incidental gallbladder cancer, so that these patients who usually have an early cancer are receiving proper treatment. The format actually initially when we thought was of a core group meeting which will develop a clinical consensus statement. We couldn't say guidelines because there is very little high quality evidence on this topic. So the idea was to develop clinical consensus statements on various aspects related to incidental gallbladder cancer. And with that idea in mind, we selected a group of young faculty colleagues from India. So about 50 of them volunteered immediately and said yes, who were then asked to generate questions related to the topic of incidental gallbladder cancer. And these questions were then collated and crystallized into a set of 25 questions. And then a group of young faculty members were given the responsibility to review the literature on each question allotted to them. And the group was enlarged to include some senior faculty colleagues from India and from outside India. Those who are in the field of HPB surgery. We also approached members of IASCO and through personal contacts. And then for each question, we could create a group of 4 to 7 or 8 mix of young and senior faculty members who were assigned one question each. So all the young faculty colleagues, they have done an extensive review of the subject, and that review has been sent to all the senior authors, the senior members of the group. And in some cases, the manuscripts have also been drafted. Also, many of the groups have been successful in registering this as a prospective systematic review on Prospero. The others also tried. In some cases, we were not successful, but we will try to get as many of these possible reviews registered on Prospero. And after this meeting, we will set a deadline by which time the manuscripts will have to be finalized and then submitted. Since the meeting is being held under the auspices of IASCO, we probably will submit these articles or these reviews to SGO, the journal of IASCO, which is covered in many indexing agencies. And I still need to discuss with the IASCO office bearers whether it will come out as a special edition of SGO or whether it will be serialized in multiple issues of the journal. So with that in mind, I would request my young colleagues who are the prospective first and co-authors of these reviews that whatever discussions happen here, please keep taking notes related to your questions specifically so that you can include those discussions in your final manuscript. And then, as I said, we will set a deadline of a couple of months for the final submission of the manuscripts. And once again, I would like to welcome all of you, those who have come from outside India and my Indian colleagues, with the announcement that the 2024 Jaipur Surgical Festival will again be the first weekend of December, 6 to 8 December. Please mark the dates in your calendar. We will soon discuss the theme and announce it. With that, I welcome you all. And then we have a pre-recorded message from Dr. Dan Duda, who is at the Harvard Medical School in Boston. He is the Secretary General of the IASCO, and he has sent a pre-recorded message. I can see Dr. Duda online, but since he sent a pre-recorded video, I'll play it and then I'll request him if he wants to say something else.
On behalf of the International Association of Surgeons, Gastroenterologists, and Oncologists, ISGO, I am delighted to welcome you to the third JAIPUR Surgical Festival, JSF, being organized by the Mahatma Gandhi Medical College and Hospital, Jaipur, on December 1st to 3rd, 2023. I greatly enjoy On behalf of the International Association of Surgeons, Gastroenterologists, and Oncologists, ISGO, I am delighted to welcome you to the third JAIPUR Surgical Festival, JSF, being organized by the Mahatma Gandhi Medical College and Hospital, Jaipur, on December 1st to 3rd, 2023. I greatly enjoyed participating in person at the second JSF meeting last December, and I'm sure this year's meeting will be equally a great success. JSF was founded in Amsterdam in 1988 as a unique multidisciplinary society with the aim of the globalization of medical knowledge. Surgeons, gastroenterologists, and oncologists are encouraged to join forces worldwide to realize the mission of ISGO. We believe that up-to-date medical practice and expertise are needed in all communities worldwide and must be made available beyond discrimination to every patient suffering from these challenging, life-threatening, and debilitating diseases. JSF's leadership strives to implement this vision through a well-structured educational program with a truly global reach, teaching and promoting multidisciplinary collaborative approaches for treating these diseases. Friendship and collaboration are vital in carrying out the mission of ISGO, the globalization of medical knowledge. This annual JSF meeting is another excellent opportunity to meet old friends and make new friends. We commend the remarkable efforts of Professor Kapoor, who has spearheaded the efforts to implement the JSF programs in India. Along with the dedicated organizing committee and a strong institutional support, he created one of the highest level programs, including international experts from Asia, Europe, and South and North America, and promising young fellows from the Southeast Asian region. This will lead to networking and cross-fertilization among experts at various stages of their career and diverse interests to promote further collaborative projects at an international level. Professor Kapoor has been actively involved in JSF for more than a decade, including by participating at JSF World Congresses in Bucharest, Romania, Vienna, Austria, Fuzhou, China, Seoul, Korea, Moscow, Russia, Taipei, Taiwan, Istanbul, Turkey, and Verona, Italy, as well as multiple symposia such as those in Beijing, Belgrade, Cairo, and Chiang Mai. Before that, he was the guest editor for a special topic on gallbladder cancer in the JSF official journal in 1999, an issue that included experts from all over the world. Professor Kapoor organized an JSF postgraduate course on jaundice in March of this year, attended by the JSF president, Dr. Ender Dulungi. Mahatma Gandhi Medical College and Hospital, Jaipur launched an international study group of gallbladder cancer, ISC, GBC, on lines of the International Study Group of Liver Surgery, International Study Group of Pancreatic Surgery, and International Study Group of Bladder Cancer. The aim of this large effort is to produce a series of clinical consensus statements on various aspects related to gallbladder cancer. The first aspect will be taken up by ISG-GBC, is incidental gallbladder cancer. About 50 young faculty members have identified issues and generated about 25 questions about incidental gallbladder cancer. They have reviewed the literature, they have prepared summaries on these questions, and the summaries have been sent to a group of approximately 50 international experts who provided their opinions. These opinions are now being collated to prepare the clinical consensus statement. Many of these prospective reviews have been registered on Prospera. The first on-site meeting of the ISG GBC will be held part of this third Jaipur Surgical Festival. 10 faculty will attend in person in Jaipur, and another 20 will join online. Approximately 50 Indian faculties are also participating in person. Given its relevance and its implications, YASGO has fully endorsed the efforts of the ISG GBC. We look forward to seeing the clinical consensus statements on various aspects related to gallbladder cancer and to publish them in the ISGO journal, Surgery, Gastroenterology, and Oncology. I would like to end by welcoming you again on behalf of the ISGO to this meeting in Jaipur, a festival of the latest medical and scientific advancements in GI cancer treatment. Thank you very much for your attention, and I really hope all of you will greatly enjoy this meeting.
Thank you, Dr. Duda. Thank you very much. Anand?
Good morning, everyone. So for the first topic for today's is for the first topic, the chairpersons are Dr. R.G. Sharma. He is a professor and head Department of Surgical Oncology, Mahatma Gandhi Hospital. I would like to call on the stage, sir. And the next chairperson is Dr. Shobna Bhatia. Ma'am's So I request chairperson to call the presenter on the stage.
Am I audible? Yeah. Good morning. We are about 5 minutes late, but this is the beginning, opening session. So I would request Dr. Prashant Mathur, who is the scientist and director, ICMR, National Center for Diseases, Informatics and Research, Bangalore, Karnataka. Gallbladder cancer is an Indian cancer. We should know what the problem is, what are we facing, and we have to give the answers. The world looks at us for the answers, and we need to know first what is the burden. So over to you, Dr. Mathur.
Good morning, everybody. Thank you, Chairperson, and thank you, Professor Kapoor and the organizing committee for giving me this opportunity to be present here. When I first time discussed with Professor Kapoor about this festival, we were quite excited about IGBC. But you are still completing the study, so I don't have the best results to show to this illustrious audience. Maybe if this meeting was held in March or so, I would come with better results. But disclaimer, I am neither a surgeon nor an oncologist. So my presence here is because we run the National Cancer Registry program for India, and it covers all 97 sites of cancer, and gallbladder cancer is one of the cancers, and this is run under the ambit of the Indian Council of Medical Research, Department of Health Research, Ministry of Health and Family Welfare, Government of India. We are a 42-year-old registry in India, and we started in 1981, and today we have 38 population-based cancer registries and 246 hospital-based cancer registries, and one of the registries is in this institution also. So NCRP, or the National Cancer Registry Program, forms the backbone of cancer control in India. As per the global standards set by the International Agency for Research on Cancer, the registry collects data on invasive cancers, which are also coded by the ICD-10, ICD-03 as Behavior Code 3. So a lot of carcinoma in situ and pre-invasive malignancies are not part of the routine cancer registry operations, because the national cancer registries are supposed to address public health problems. And the notion is that pre-invasive or carcinomas in situ are not public health problems. It is the invasive cancers which are public health problems. Maybe this notion needs to be revised and changed, but till then, so I'm giving you the background to understand what and why we collect this information. In 2001 and 2, with the support of the World Health Organization India office, we did a district by district mapping of all sites of cancer based on pathology reports. And that was the first time when gallbladder cancer was mapped across the 540 districts at that time in India. And what you see here, screen blank. Sorry, I didn't really realize it. Sorry for the interruption. So we did this mapping of gallbladder cancer across all districts of India. And this was the first time that we realized that there is a gallbladder cancer belt in India, which runs through the northern part of the India and is also known as the Indo-Gangetic Plain, after the river Ganges, which starts right on the top from the state of Uttarakhand and flows into the eastern part into Brahmaputra in the state of Assam. And this was an eye-opener that time, that there is a stark difference in gallbladder cancer in India. And now everybody very comfortably says that gallbladder cancer is a North Indian problem. So presently we run 38 population-based cancer registries. To your left are the population-based cancer registries, which are located in different locations. And these collect data on a defined geographic area on all cancers. So we are able to give rates based on population denominator. Whereas the hospital-based cancer registries, these are located in various hospitals, and from here we derive more of clinical treatment and outcome data. Survival can be estimated from either of these populations. So one set of registries gives us the rates at population level, the other gives us high quality clinical information. You would wonder, we are sitting in the state of Rajasthan and we don't have a population based cancer registry. Yes, we don't have. But about 6 months ago, we have started a Rajasthan Cancer Atlas project with the state government of Rajasthan, and hopefully in the next 2-3 years we will be able to give you district by district mapping of all cancers, including gallbladder cancers, in the state of Rajasthan. So if you look at this age adjusted incidence rates of gallbladder cancer, these are the 28 population based cancer registries whose data we published. So India is not one. There is a huge heterogeneity, and the color codes are for the different 6 regions of the country. And the top is the Kamrup district in the state of Assam in northeast, which has an incidence rate of almost 8 per 100,000. This is in males. Then Kachar, Delhi. And one can see that it is the southern part of the country which shows a much lower incidence rates. But in females, again the same sites or the same geographic regions, but at a much higher incidence rate of 16 per 100,000. And so gallbladder cancer is, yes, an Indian subcontinent problem with many other such LMICs, and the solutions also have to come from us. We would not expect some other countries and leaders to solve this very burning problem. And unfortunately, this has not caught the eye of policymakers in India regarding cancer control, because they are besieged with breast cancer, cervical cancer, oral cancer, lung cancer, stomach cancer, those kinds of cancers. These are the trends. So there are 5 registries which we had data for the last 40 years. And we looked at their annual percentage change of cancer. So Bangalore is southern India, the blue one. Mumbai is western. So you can look at the paradigm that yes, it is the northern part of India which is showing in females and males the highest changes in growth of gallbladder cancer. We looked at the ranking of gallbladder cancer. So Delhi, North India, between 1988 to 97, it was on 4th in females, this is all, but now it has come to occupy the 3rd position. So in a matter of a few decades, it has jumped in rank, and it is competing with only breast and cervical cancer. But Bhopal, which is in the middle part of the country, which could be considered as a transition zone between north and south, it is at a much lower rank. And then Mumbai in western part, it was not there in the top 10 in the 1980s, 81, but now it is there. And I'm not showing, but there are now registries from Bangalore and Chennai in southern India which are showing an increase in gallbladder cancer, but their incidence rates are around 1.5 per 100,000. And probably there is a lot of need for understanding as to what is happening, and maybe in the next 20 years this whole paradigm of north and south will be challenged. Then from our hospital-based, 96 hospital-based cancer registries in India, we published this looking at the age. The peak age in males and females remains the same. However, in females, the peak appears almost a decade before the males. Now, this is a data on almost, I would say, 2.8 million cases registered. Then we look at the clinical extent of disease. Whether it is males or females, the localized disease is just 1/4. And if you look at whether it is loco-regional spread or distant metastasis, it accounts for almost together 3/4 of gallbladder cancer. And this is the tragedy. And this is where the need for incidental gallbladder work comes in. anecdotally from published literature, we understand that a lot of incidental gallbladder cancer is missed. Cholecystectomies are done left and right in the northern part of India. A lot of it is not subjected to very good histopathological examination, and incidental gallbladder is missed, and these ladies after some time present as stage 3 and 4 gallbladder cancer. So it's a missed opportunity. And this is where the role of such organization comes in, to create that algorithms, that awareness within fellow colleagues that there is a thing known as incidental gallbladder cancer. And I think in this discussion you must have a lot of pathologists involved. Because when we set up a special study 5 years ago, we actually set up a lot of quality assurance measures, and we realized that everybody doesn't look at gallbladder cancers in the best of institutes in India very meticulously. So we have set up protocols on how the specimens should be sectioned, stained, and examined. Then we look at treatment. Now, I don't know, you all have to tell me, the use of chemotherapy, whether it is localized or distant metastasis, as it increases, use of chemotherapy is highest. And this is where you see a failing surgeon, because you don't get localized tumors to operate on. So probably you are looking at much advanced diseases which are inoperable, and so the role of chemotherapy, radiation therapy, and palliative care becomes more important. As I said 5 years ago, now we wanted to look in more detail on gallbladder cancer. What I just presented is a very overview of it. So we run a lot of studies known as patterns of care and survival studies. We have studies going on cervix, breast, and oral cancer. So we added gallbladder cancer also in this. And this is a data from nearly 30,000 cases registered between 2018 and 23. And the age distribution is very similar to what I presented earlier, that it is a much more in females at an early age. And also that almost 91% of the gallbladder cancers are around the neck body fundus, that is coded in the ICD-10 as C23 region. Majority, 41%, were distant metastasis, which reconfirms our earlier finding. And this study was done in 10 major hospitals of India, spread across the entire gallbladder belt from the northernmost part to the easternmost part. Then we looked at risk factor based analysis, and these are very preliminary results, so I don't have an interpretation, but just to cholelithiasis was present in 33% of females and 23% of men. Then you can similarly look at cholecystitis, history of infections, but there is a history of past gallbladder disease also. And these porcelain gallbladders, and there is data being collected on operable gallbladders also, which were then became invasive gallbladders cancers. This is a 3-year survival curve, overall survival for gallbladder cancer. And because we are still following up these patients for 5-year survival, and very clearly the female is at a disadvantage in terms of survival, relative survival as compared to male, and we see a lot of distant metastasis. Now when you look at stage-wise metastasis, the stage 1 offers the best 3-year survival rate of nearly 80%, whereas stage 4 gives you a survival rate of 2.8%. Now, these are some things which probably we are describing for the first time in a large sample size. And we would like to benefit from your knowledge and your wisdom, and we will certainly take up the questions which you put up to put it on an analysis map on a larger cancer registry database. So to summarize, there is a high burden of gallbladder cancer in the north and the eastern parts of India with much higher rates, and the force of cancer is higher in females with a decade earlier peak. And there are some now reported increases in incidence in southern registries also. Probably migration is a reason. People are moving across the country for education, employment, and settling down. So more studies are needed to look at this aspect. We have a huge problem of distant and advanced cancers of gallbladder, and that incidental gallbladder cancer diagnosis needs an urgent attention. So just to give you a figure, we have collected data on nearly 8,800 cholecystectomies done for benign causes, apparently benign causes. There was no pre-op indication of malignancy, and out of these 72 are incidental gallbladder cancer, which is around 0.8%, and it gels with generally what is published from India, somewhere around 0.5 to 1%. But we are still accruing that data, and we will come back. So we need better early diagnostic methods. Using these large data sets, we do hope to develop some prediction models for gallbladder cancer in terms of susceptibility, looking at risk and progression of disease to have an impact on its survival and outcome. Thank you very much for your attention, and I'll be very happy to listen to the deliberations of this festival. Thank you very much.
Thank you, Dr. Mathur. We really appreciate your work and the work the National Cancer Registry is doing in mapping the cancer pattern in the country. I know these figures seem to be minuscule as compared to the population that we have, but this is a wonderful work and it is really very difficult. We have conducted some studies from Rajasthan, we have already published it, but I know it is a very, very difficult problem, and how to collect the data is a tremendous amount of work that you are doing. So for gallbladder cancer, we know the incidence in the northeast is the highest, and there is an alarming trend and an upswing. Females develop at a decade earlier than males. Almost 40 to 45% gallbladder cancer is seen in advanced stages, and females are more susceptible. Only 20% seen in localized stage. There was an interesting chart of treatment with chemotherapy showing the limited role surgical treatment has. Survival varies from 70 in early to almost dismal in advanced stages. Now we know that all cancers are notifiable disease, but I think it has to be implemented that the moment the pathologist anywhere in the country diagnoses a malignancy, it has to be notified. And probably that would be the simplest method of getting adequate data. So we need to tap the pathology centers involving basic scientists to find out the etiology and preventive strategies. What is the cause, whether it is environmental, lifestyle, what is there, and proper detection and treatment of incidental gallbladder. Any questions, quick questions or comments?
I really enjoyed that, Dr. Mathur. The question that I have for you, you showed us very nice data on different aspects. How about the socio-economic status? Does the prevalence of gallbladder cancer in females in the Indo-Gangetic belt have anything to do with the socio-economic status of the population? And this particular belt, the issues have been regarding environmental contamination, water supply being contaminated by various kind of chemicals. The BHU work points in that direction. So is that something that the registry is looking at?
Yes. So that is why I said I'm in a little preliminary stage, but we will be coming out with the socio-economic aspects, the exposures, the chemical pollutants, pesticides, as well as infections, drug exposures, some of these things. So, I mean, we'll have a larger question for India. Why is this so peculiar to the Indo-Gangetic belt? not to any other river bed. I mean, the status of pollution and everything is similar across the country. Why should, and Ganges is our holiest river.
This very high incidence reported in the data from northeast, some of the districts, is it a true high incidence, or is it because the documentation they are recording there is better than other places? Because people who have worked in Delhi or North India and Southeast also, the perception as a clinician is that it is not that common as it is in North India. So is it an aberration of the data?
So, you know, this figures come from the population-based cancer registry. And the method or work, so the team goes to the hospitals and collects data on all sites of cancer. So it's not that you make extra effort for gallbladder cancer. Okay, it's same for whether it is stomach, leukemia, lymphomas, or stomach breast cancer. And this is a consistent data over the last 20, 30 years. So we don't see fluctuations happening. That is one of the reasons to believe underreporting will be there. And cancer is, sir, not a nationally notified disease yet. There are only 16 states in the country who have notified cancer as a notifiable disease. Rajasthan is one of them. So we don't have that. So there is a problem of underreporting, but it's a systematic bias. So there is no, fluctuation determined on that. A patient of Assam, Kamrup, Tripura may come to Lucknow, Delhi, Jaipur to get operated. And when you, as a clinician, you sit here, you see a lot of gallbladder. But as a registry, when I collect data from Mahatma Gandhi, I take the address. And when you give the address Kamrup, I will populate it in the Kamrup PBCR because it belongs to that. And so these rates are different from what you experience clinically.
So in other cancers, in these northeastern districts, there is no discrepancy or no difference as compared to other places?
So Northeast leads India in overall cancer burden.
That's what I was saying. So
Okay.
Is it better documentation?
It is better documentation also. But if you look at the exposure rates, tobacco use today is highest in Northeast. Alcohol use is highest in Northeast. So, so these are research questions as to why is there. So reporting becomes not a question of whether you collect more data. It is question of looking at the stability of data, and that is what is the credibility of a registry, to look at the stability of data. There are no fluctuations happening.
Other is just a comment. I think we should give up, although Dr. Shukla coined that term, that gallbladder cancer is a gangetic cancer. It runs from Pakistan, Nepal, North India, Bangladesh. Ganges doesn't run through all these places.
So for India, we will say Indo-Gangetic belt. That is the only thing. It goes up to Tripura is also there.
Dr. Mathur, I really enjoyed the data. It's eye-opening that we have this data from our place. I work in Bangalore. I used to work in the northern part, Lucknow, Delhi. And we know that there is a difference in the incidence of these, prevalence of these cancers. What would be, the research question would be that we know that these areas have high incidence, but there is a lot of migration now to other parts of India from this. And to make environmental factor the cause of that, would following these patients and seeing, or these people or population, and seeing that their incidence changes in that population in the different part would indirectly show that there is an environmental component in that. Is it possible to study in such a manner?
Yeah, certainly. These will be very intensive studies which will require a lot of following up of populations to document their ethnicities, their lifestyles, and measure environmental. So if we know what is the environmental exposure to be measured, one can. And then to ascribe it to the cause of cancer is something to, So these are very intense studies, but yes, possibly it can be done. It can be done in a limited setting. So migration is certainly an issue. So I don't know what genetic makeup will make a role in such cancers coming up in southern part of India.
That was a great talk, so I just have one comment. Of course, the genetic component has an overriding role to play along with the environmental pathogens. There is a study that comes from UK that goes ahead and says that in patients who've undergone a cholecystectomy, the chances of finding an incidental gallbladder cancer is way higher if the patient is actually coming from India. Just wanted to make that comment.
Yeah, so that is, but within India we don't want to see IGBC, you know. In many, unfortunately, specimens are operated and put into the dustbin directly.
I'm sure there are going to be many, many more questions to Dr. Mathur, and we can discuss over tea. So thank you very,
Thank you very
much. And I can invite the next set of chairpersons, Dr. Abhinav Sharma and Dr. Ajay Sharma, to define what exactly is gallbladder incidental cancer.
So for the next talk will be definition of the incidental gallbladder cancer. For this, the chairperson, Dr. Ajay Sharma, I request. Dr. Ajay Sharma is a professor and head Department of Surgical and Gastroenterology, Mahatma Gandhi Hospital. I request Ajay sir to call lead presenter on the dais.
For this session we have Dr. Abhishek Agarwal. Yeah, we have Dr. Abhishek Agarwal. He is the assistant professor of GI surgery and liver transplant at Amrita Institute at Faridabad, Delhi. So he will be speaking on incidental gallbladder cancer, definition of the incidental gallbladder cancer. So I think Abhinav is not here. So in the meantime, we can start.
Good morning, esteemed faculty and my dear colleagues. So I'll be talking about the definition of incidental gallbladder cancer, what it is and what it is not. Greetings from Amrita. So just imagine a routine surgical procedure aimed at addressing gallstones and related issues, only to unexpectedly encounter a hidden threat, the gallbladder cancer. So as we know now, the symptomatic gallstone disease comprises the major load of a surgical OPD, and North India has high incidence of gallstones as well as gallbladder cancer. The widespread use of ultrasonography has only increased this detection of cholelithiasis, and consequently the cholecystectomy rates have gone up, so much so that it is now the world's most commonly performed surgery across the world. Historically, the coexistence of gallstones and gallbladder cancer has been known for ages. In 1931, Evarts Graham observed that gallstone was present in 70 to 100% of cases of gallbladder cancer, and gallbladder cancer was found in 4.5 to 14% of patients with gallstones. Classical surgical teaching has been that 1 out of every 100 specimens of gallbladder removed for a benign pathology may reveal an incidental gallbladder cancer, although the rates that are reported are much lower. So gallbladder cancer may present as a metastatic disease, it may be an advanced inoperable disease, it may be a resectable mass-forming disease, or incidental discovery on histopathology for a simple cholecystectomy specimen. It is this latter category that is termed as incidental gallbladder cancer. Some authors may also ascribe the finding of intraoperative finding of a malignancy which was subjected to frozen section as incidental gallbladder cancer, although this definition has its fallacies. So there are different terminologies ascribed to the same: inapparent, unexpected, unsuspected, missed, or truly incidental. So are all these the same disease? All aforementioned terms do as a whole either take preoperative, peroperative, or postoperative diagnosis as histopathological examination. So if we do the literature review, we see the American College of Surgeons, as a part of their study for National Surgical Quality Improvement Program, they considered only post-operatively detected patients as a part of incidental gallbladder cancer in the study published in 2014. The ICMR consensus paper for management of gallbladder cancer also only took into account the histopathologically found gallbladder cancer to be the actual incidental gallbladder cancer. And another meta-analysis done from South Korea also took only the patients who were identified post-operatively detected cases to be incidental gallbladder cancer. Dr. Kapoor, in his chapter on incidental gallbladder cancer, took resected gallbladder specimens to be having incidental gallbladder cancer. Another paper from Dr. Varshane's group from Bhopal also had only the specimen of gallbladder which was possibly secondary to a benign pathology and revealing a cancer to be taken as incidental gallbladder cancer. The Brazilian consensus paper also mirrors the ICMR consensus paper in only taking the specimen which was done for a benign pathology and subsequently revealing a gallbladder cancer to be incidental gallbladder cancer. Dr. Bastianen from Netherlands described incidental gallbladder cancer as a histological surprise, which probably is the most abridged definition that we can think of to be incidental gallbladder cancer. However, there are few papers, such as another paper from Seoul, from Choi et al., where the gallbladder cancer suspected during the surgery as well as after the surgery was considered to be incidental gallbladder cancer. Similarly, from the study from MD Anderson group, also concluded the incidentally found intraoperative gallbladder cancer to be considered as a part of their study. However, even though we are on the both sides, from France, they considered only histopathological examination. Another study from North America also took pathological assessment following cholecystectomy as to be the real gallbladder cancer. So another terminology is missed gallbladder cancer. This was described in a recent paper from PGI Chandigarh group to be having either a preoperative suspicious finding, an intraoperative suspicious finding, or a finding which was missed even on post-operative histopathology, and the patient presents within 1 month with some distant metastasis. Dr. Bihari and Dr. Kapoor in the paper told that it actually is a misnomer, and the actual missed gallbladder should be ascertained only to those cases where even after a histopathological examination following a routine cholecystectomy, patient has presented within 1 month with distant metastasis. So this lack of uniformity in definition may lead to a lot of confusion, both in terms of management, the consensus, and also research. So what we propose as a part of this study is to have a uniform definition of incidental gallbladder cancer, which is the gallbladder cancer found in gallbladder specimen after surgery for a benign gallbladder condition without any preoperative or intraoperative suspicion of the same. We also should define the missed gallbladder cancer, which is the gallbladder cancer reported in a specimen or missed from reporting in a specimen, even though there were signs of cancer before or during the surgery. Thank you.
I think it was really a very good presentation, and I think Abhinav has joined. Abhinav, can you come on the stage, please? He's a co-chairperson with me. So I agree that having a definitive term to label it as an incidental gallbladder cancer is really difficult, because it has been widely used. Most of the times we have a sonography finding which shows an irregular gallbladder wall thickening. The patient undergoes a laparoscopic cholecystectomy and the gallbladder is not seen by the surgeon, and then subsequently sent for histopathology, and the pathologists take one specimen, one cut section, and there is no malignancy to it, and the patient comes with metastasis. But actually this patient had gallbladder cancer pre-operatively, which should have been diagnosed. So this is not a missed gallbladder cancer. So, and moreover, once you see the specimen, I think which this is the classical training for all the surgeons, that once you do a lap chole, you should see the gallbladder on table before you extubate the patient from anesthesia. So it is mandatory. Until unless you have seen that gallbladder, I think it is not correct that you extubate the patient, because if you find a lesion, this is a time when you can do something which is required at this point in time. So definitely there is a lot of overlap in the definitions. Abhinav, will you like to add something to it?
So, is a frozen is of value on the table? If you have any suspicious finding, you open up the gallbladder, you see a lesion, a suspicious lesion.
It can be used to confirm, but then it will not be an incidental gallbladder cancer. That is what we want to tell. If intraoperatively or on just before the extubation, when we are opening the specimen, we find that there is a lesion, then it should not be termed as an incidental gallbladder cancer. It should be a missed, because some finding has been missed either preoperatively or intraoperatively to find the gallbladder cancer.
Yeah, can we call Shraddha on the desk? Shraddha is a hepatobiliary surgeon of surgical oncology from Tata Memorial, Mumbai, and she will be presenting her comments on this session, and then subsequently we can have questions from the open house.
So
Shraddha,
I
please.
do not have a presentation, but I would like to summarize what Dr. Agarwal has very lucidly said in his presentation, that there is lack of uniformity just because everybody's interpretation of what constitutes incidental gallbladder cancer varies. We all agree with the fact that we need to do something to identify these patients so that we don't see a lot of incidental gallbladder cancers in our practice. Because unfortunately, all of us are faced with scenarios where we see patients who've probably had a diagnosis which should have been picked up earlier, and they present to us with metastatic disease, and this is a scenario which we want to avoid. What can be done to pick these patients up is what we have to reach at in this meeting, probably at the end of 3 days, where we'll be able to, once we have defined, now that we have defined and we all agree that this is the ideal definition of incidental gallbladder cancer, let's now strive to see what we can do to increase the incidence, because in our practice, if we've operating 100 patients of gallbladder cancer, 50% of them would be incidental. I'm sure that would be the practice around the country. We can take each and everyone's opinion on that. And as Dr. Agarwal nicely summarized, that the true incidental gallbladder cancers are ones which are detected post-operatively on histopathology, where we have operated thinking that it is a presumed benign condition, and that it's truly a surprise and not something which is missed pre-operatively.
So, Abhinav, we can have, Abhishek, we can have you on stage, please. So, what is your opinion if you have a thick wall gallbladder, patient undergoing cholecystectomy, patient is having thick wall on sonography,
So
uniform thick wall gallbladder?
uniformly thick wall may not be in classical teaching ascertained to have a gallbladder cancer unless there are some signs, but a focal thickening or which is unusual, that may be more ascribed to having a gallbladder cancer.
We have now two, Dr. Kapoor is on stage. We can have Mike with Dr. Sadiq and Dr. Saraswat. I think it will be a good discussion now. We have, yeah,
So
Dr.
Abhinav,
Kapoor.
Abhishek and Shraddha, you are the most important people in ISG GBC, because you have to define what are we going to talk about. So we have to be very clear, and your group includes other persons also. Dr. P.K. Mishra, who is one of the senior GI surgeons, he was not able to come because of a family commitment immediately after this meeting, but he's been contributing to your manuscript. And I think we need to be very clear, the scenario which Dr. Ajay asked, thick walled. In my opinion, as soon as you see a thick walled GB, whether it is diffuse or uniform, it becomes a suspicion. So that should not be clubbed with incidental. Similarly, the point which Dr. Abhinav was trying to ask about the role of frozen section. Obviously, you will not do frozen section in all gallbladders. You will do only if you see something in the specimen. So the surgeon opens the specimen and there is a suspicious area. The moment there is a suspicion, it becomes a suspicious gallbladder cancer. So I have been saying, and my colleague Dr. Anu Bihari, we have been saying, and I think as you projected, most groups tend to agree with this, that the true incidental gallbladder cancer, and that I feel should be the definition for this group, is when even the specimen opened by the surgeon or examined by pathologist looks normal, but histopathology shows malignancy, that and that alone should be classified as incidental gallbladder.
So,
Yeah, first Dr. Sadiq, please. Sadiq.
see, the reason to define this is there a different disease? So, for example, as we discussed, we'll go one by one. So, we see a lot of thick walled gallbladder. Now, what do? You treat them or with suspicion of gallbladder cancer straight away. That means the burden of suspecting gallbladder cancer increases many folds. This may vary in various parts of the country and may take different outlook if you are working in a certain part, whereas you're working in another part. So that part needs to be segregated from the part that where you have on histology. If you see intraoperatively there is a problem, why is it any different from that gallbladder cancer, different from incidental gallbladder cancer? Till now there was no suspicion of that, and now you're just seeing. If you had not seen, it would have gone there. But are they two different diseases? So if you find on the operating table and detect it, it becomes something else. So therefore we have to segregate them. So that's the key question, that we need to segregate patients into groups which have different outcomes or different management strategies, rather than just say by definition only if it is on histology. So how do we put, where do you put this? Suspected gallbladder cancer, is it any different from incidental gallbladder cancer?
Suspected and missed are different from incidental because they differ in terms of their outcomes as well and the management that we can offer to the patient.
Intraoperative, till now nothing. Open the specimen, you find some focal thickening, and you say, oh, I need to do histology. So my question is that a different disease than what you see on true incidental gallbladder cancer? And if that is the case, then there is a point in differentiating between these two.
So, very good question. Unfortunately, we don't have data anywhere from the world where we can say that the true incidentals, whether you detect them post-surgery, actually are biologically different. I think there is a session to address this question itself in the conference, and we just had a publication accepted today morning in which we have looked at outcomes of patients who are just T2 gallbladder cancers, which are resected upfront versus those which were incidentally detected. It's a series of around 400 patients, and we've shown that patients who have incidental gallbladder cancer detected, which are stage matched, tend to have poorer outcomes. Hopefully, I'll be able to share the manuscript once it is online. But till now, there is no data which has compared head to head, and I don't think we will get that answer with any kind of trial or retrospective studies. We just have to pool data and probably arrive at a consensus to see whether this actually behaves differently.
Shraddha, if I am correct, I am taking it correctly, it is the patient who is having a poor prognosis is the one who has now been diagnosed on histopathology,
Yes.
but he was fine intraoperatively.
Yes.
And if he is diagnosed intraoperatively, they will have a better prognosis.
Better
That's what you want to say?
Yes.
So do you mean to say that if it is done at the same sitting, the surgery is done in one sitting, it has a better prognosis?
Yes.
Is that you want to communicate?
Yeah.
Okay, so maybe Dr. Saraswat sir has a question. Sir, can we pass the mic to Dr. Saraswat, and then we can pass on to the, yes.
I think the consensus seems to be that incidental gallbladder cancer is something discovered at histopathology post-operatively, and nothing pre or intra-op would qualify. Now, when you say that, then discovered pathology depends very much on how extensive or how thoroughly the gallbladder is examined. So to diagnose incidental GBC and not make it missed incidental GBC, what is the consensus on how thorough should be the gallbladder examination? Proper gallbladder mapping by sectioning the entire gallbladder specimen and looking for it by what techniques, etc. So what is the consensus on that? And probably that would be a major part of what this group would have to contribute.
Yes, actually Dr. Mathur said that pathologists should be a large chunk of the audience here. If we have anybody, we can get madam to comment.
Yes, we have a pathologist, yes. Now, I would like to emphasize here, we have now two types of pathologists which are normally categorized. One is a routine pathologist, which will be doing a routine histopathology for a routine gallbladder which comes to him, and another one will be who is doing a oncopathology. So these will be two different groups. Our main work should be on the routine pathologists who get the routine gallbladder. How should they examine? Because oncopathologists will anyway take 50 specimens out of that. But how does a routine? So maybe I think she'll be able to better comment on that.
I think the index of suspicion should be more for every case, for every college. For every gallbladder specimen, the index of suspicion should be high, and then it should be thoroughly examined. It should be opened properly. It should be opened from the cystic duct to the fundus, and then each and every corner should be examined properly. Most of the times we don't have suspicion, and then we overlook and we take sections without, maybe sometimes without opening or without properly opening, without seeing every corner. Sometimes there are diverticula, or there are due to chronic cholecystitis, there are sometimes folds or there are adhesions within the gallbladder itself. Then some folds are not opened, and then we need to see it clearly, and many a times a stone blocks some part of the gallbladder. Then then we need to see that area, and that may harbor carcinoma.
So if
Or
we
even
are
a pre-malignant
taking you
stage.
correctly, meaning to say that you should either take more number of specimens from the same gallbladder
First
and
of all, sir, it should be
second,
thoroughly examined, and even a subtle
there are
thickening,
two parts of
subtle
thoroughly examining.
irregularity
One is,
should be taken into consideration, and then sections should be taken. And
suppose gallbladder is normal for you, once you have opened it,
Yes.
how many sections do you take from one gallbladder as a routine, not for malignancy? Now your routine gallbladder, simple cholecystectomy being done, patient had no history, wall thickness was normal on sonography. How many sections do you take routinely for this gallbladder?
we routinely take, say, 3 sections.
You take 3 sections.
Yes.
So, is that consensus correct on three sections? What do you think now? Sir, we have Dr. Mathur, he has to
Okay,
say something. Then we have Dr. Sadiq,
So,
and then we have comments. Yeah.
Yeah, so many of these questions our study will answer. You know, we are looking at pre, peri, post. Surgeons' views, intra-op views, ultrasound views, other imaging techniques, histopathology, outcome, survival. So I'm trying to build a story. And I see IGBC as a continuum to frank gallbladder cancer. And I don't have reasons to believe they will behave biologically different. Okay. So I don't know whether Prasenjit is here, but I saw his name in the agenda.
No, he'll be coming today.
So we have set up quality assurance mechanisms for pathologists. And this study is being done in routine medical colleges. We have not taken onco hospitals. These are routine surgeons who do routine cholecystectomies, routine pathologists who do routine reporting. When blocks are sent to Prasenjit from these centers, our pickup rate has improved for IGBC. They were missing. So we will be publishing this protocol on how pathologists, I think our committee has recommended 12 strips from each gallbladder. So it was a committee of around 8 or 10 pathologists who have sat down together and said, as a study, this is what, and it has improved our pickup rate, particularly the hand-holding which is being done for routine pathologists. So our focus should be on routine pathologists, because the chunk is not done in academic institutions anymore. The chunk of cholecystectomies are being done outside academic institutions, and histopathology is an extra burden financially. So, I mean, you know, that's the problem we are grappling with.
I think point well taken that at least 12 sections should be taken from a routine gallbladder for any histopathology. Ma'am, want to say?
One more, that's the most, I think one of the most important points is that most of the times this sampling of the gallbladder specimens are usually done by residents or junior pathologists who don't have the experience, and then they just open it. They think that it may not be harboring. It's a routine surgery. It's the most common surgery. So it's being done for chronic cholecystitis. Most of the times we get it chronic cholecystitis. Unless we take sample from a specific region, we cannot, even after reviewing the slides, even after reviewing the blocks, we cannot get gallbladder carcinoma unless it's sampled from the proper end.
Yes, I think we agree with what you are saying. Same thing we happen to face as a surgeons, that the lab call is being done by the junior consultant, junior most resident in our team, being thinking that it's a routine surgery. He does not open the specimen. So it is not a fault on him. It's my fault that I don't take that responsibility. I think we can have more questions from the audience.
There is a different twist to the story I want to bring here.
That will be interesting.
We agree that the prognosis of a truly incidental gallbladder cancer may be different, or the outcome or the survival curves may be different. But isn't the idea here to identify a CA gallbladder that should have been identified in the first place and not missed? I think that is also an overriding thing. Till now, whatever data has been published, so-called incidental gallbladder cancer, we don't know the preoperative characteristics or the radiology, how meticulously these things were assessed, and then how well the pathology specimens were assessed. So truly incidental to my mind becomes where you have ruled out every clinical suspicion of a malignancy on pre-op history, examination, etc., where you have a to-the-point ultrasound or imaging that says that there is no suspicion that this may be a thick-walled or a possibly malignant gallbladder. The surgeon has opened the gallbladder and not just inspected but also palpated. And I think it's very important that after inspection and palpation, the surgeon should point out with a suture or inking that this is where the problem is so that the pathologist can see, and a proper pathological examination. So when we look at the previous studies or the reporting or the nomenclature for IGBC, how many studies have actually done all of this?
No, I agree. Yeah, please.
The early lesions where muscular invasion is not there, they will be difficult to pick up on simply by palpation. So we have to devise the ways of looking at gallbladder grossly under dissecting microscope or maybe some other modality to identify in situ lesions or early lesions which are truly incidental gallbladder.
I think that point has already been asked by Dr. Sadiq, that what is the difference between diagnosis and prognosis between the two groups. Prognosis has already been asked. If Shraddha or Abhishek want to take anything, comments on that before we go to the question?
I mean, it's a utopian world where you would have the ideal imaging done and ultrasound to the point by expert in the field. We have a study from India which has defined criteria like GB-RADS, where they've given specific points which have to be looked at, and the specimen being opened, palpated. But unfortunately, this
I think Dr. Kapoor has said, and then subsequently histopathology. I think we'll have in subsequent discussions this thing about PET-CT. Dr. Rajgovind sir?
Can we have a recommendation for the future that we take photographs of all the gallbladder cancers opened up? Now that we have face recognition, AI coming in a big way, probably if we give 1,000 images of gallbladder pictures, AI would be able to tell that this is there. So we can make a recommendation that after you do surgery, just take a photograph and we have a database of all those photographs.
Yeah, this is actually happening in endoscopy.
As a missed gallbladder cancer should be ones which we miss even on the histopathology. So let the benchmark be histopathology rather than the preoperative ultrasound. Just a short one.
Abhishek, you would like to take that?
So what you just said, I actually presented two different papers. One was from the PGI group, in which they counted even the on-table finding after the specimen is removed as one. But another paper by Dr. Bihari and Dr. Kapoor said that actual missed is the one which is even missed on a histopathology. And a patient is presented within 1 month with distant metastasis or spread. So actually that should be considered as missed, because you have lost the chance of detecting it preoperatively, intraoperatively, as well as postoperatively. And now the patient is presented with distant metastasis.
In simple language sense, missed, it would be right. Definitely we have missed the opportunity.
Correct.
But in scientific term, like we are in a scientific meeting, should we not label it as unsuspected gallbladder cancer?
If you're finding a thickening, it should be rather labeled as a suspected gallbladder cancer, pending a histopathological confirmation, because we have found a thickening there.
So again, I would prefer, we would prefer that suspected should be something based on the preoperative imaging, and intraoperative we would prefer to label it as unsuspected gallbladder, which we were not suspecting preoperatively, and we found it intraoperatively either before completion of cholecystectomy or after completion of cholecystectomy while opening the gallbladder specimen. So
I think it is interesting. We have a lot of semantics into it, which can be a lot of words. I think we need to define them. That is what the purpose of the meeting today is. What is unsuspected, suspected, missed, found, incidental, intraoperative, detected? I think they need to be defined so that we have better things. So I think we can have questions. Yes, please.
So, I mean, the problem we are discussing is we want to get the maximum out of that big volume, right? And then you want to say that it has to be uniform reporting. So gallbladder ultrasound would be reported by various people at various places. You can't make a uniform method of expertise available at each place to detect finer details of that, right? And then you say that at the end of that, none of those should be there. So then only we will deem it as incidental. We know that in incidental, it is not only PT1, it will be PT2, PT3, right? So that means they have had some indication which were not picked up, but that doesn't mean it becomes a missed gallbladder cancer. The second point which I want to say, as Dr. Sumaya said, that junior most does it, or somebody who's not well versed with it does the pathology. But that's the real case life scenario. Gallbladders will be examined everywhere, and you don't expect expert pathologists to be looking at gallbladders all the time. And another real life scenario is you don't remove a complete gallbladder most of the times during a cholecystectomy. If it is a thick walled gallbladder, if it's an acute gallbladder, you split the gallbladder and take it out. Now it's not a complete gallbladder. Sometimes we have various strips of gallbladder. How do you examine that gallbladder? So, you know, all these things have to be kept in mind. So the definition has to be simple, overall, uniform, irrespective of who's there, all other things we should leave away. The point about how much to examine should be uniformed. I mean, it should be defined now. That then only you would say it is the incidental gallbladder cancer. Otherwise, you may not pick up as everybody's experiences. And I personally feel that at the table, if you detect that, it should be the same as incidental gallbladder cancer, because till now you have not picked up. And as a matter of fact, we'll discuss when the time comes for discussion that I don't believe that opening on the table makes a big difference, because there are various other considerations offering treatment at that time to the patient on the operating table. You don't have consent, you don't have information to them, they have come for a simple daycare surgery, you suddenly tell them, and there's no suspicion, mind you, and you tell them, oh, you're going to undergo a major operative procedure. And is that right? So those things we can discuss at that time. So a big thing is made about opening the gallbladder and finding out. I think you do a safe gallbladder operation, it is not suspected, you subject it to histology, and then take the steps from there, what you get.
Okay, we can take a next question, please. Yeah.
Like Dr. Mathur had recommended, subjecting every gallbladder to a 12-strip examination, economically and clinically, how justified it is, especially when the Western world is now going towards selective biopsy. There's a lot of talk about selective biopsies from the Western world. Of course, there's a huge difference in the incidence of the disease in question. But also, it might be some evidence that says that if the patient has had a laparoscopic conversion to open, it is more chances that this is a malignancy rather than a benign disease. But then, since we want to talk about the preoperative parameters, this is something that I really didn't touch into. If you look at the radiological assessment that is quoted in the literature, we are looking at the stones, the size of the stones, the volume of the stones to the gallbladder volume, the kind of gallbladder wall, and the surrounding structures. So large has been defined with various cutoff values, cutoff of 3 centimeters, 2 centimeters, or 1 centimeter. There is no consensus available on this, what would constitute a large stone, but the studies say that the stones are larger by 1 to 1.2 centimeters in patients who have malignancy. But again, we need to identify which large stone would quantify as a large stone to be associated with gallbladder cancer. The data about this is still ambiguous. Solitary stones, of course, the larger the stone, solid stone, higher chances of it being a cholesterol stone than a pigment stone, higher association with malignancy. And there is some talk about the stone to the gallbladder volume. So this goes all hand in hand. The larger the capacity of the gallbladder that is occupied by the stone, more the inflammation of the gallbladder wall, more chronic inflammatory changes, a higher chance of developing malignancy. I'm just mentioning this because this is what needs to also be assessed on a radiology, whether the patient has an associated gallbladder polyp or a porcelain gallbladder. But when this comes into talk, we are no longer talking about an incidental gallbladder malignancy. When we look at the gallbladder wall thickening, we want to look at whether the thickening is focal thickening or diffuse thickening. Evidence goes to suggest that focal thickening more than 5 mm, which is irregular, there is associated breach in the gallbladder mucosa, the thickening appears inhomogeneous, low in echogenicity, and a central vascularity, has a very high chance of being malignant. A diffuse thickening is more likely to be inflammatory, and thickening in the absence of a fluid collection should be highly suspicious of malignancy. We are coming to GB RADS, and that's been just touched upon by Dr. Shraddha, where an Indian consensus has gone ahead and described what would require to be looked at in an ultrasound for suspected gallstone disease. So on the left, this is typically a benign lesion where all layers of the gallbladder wall are seen. The mucosa is seen separately. There is no breach in mucosa. There is no irregularity versus what is there on the right. This is a very important concept for which the radiologists need to be sensitized, because the onus ultimately for identifying gallbladder malignancies preoperatively will be dependent on radiology. GB RADS actually looks into two kind of things. One is the intraluminal changes, how well the gallbladder is distended, and what are the intraluminal contents. That takes me back to that whether it's a single stone, how large the stone is, what is the volume of the stone to the gallbladder, are there any other mass lesions in the gallbladder or not. And then there are mural changes. How is the wall thickened, whether it is symmetrical, asymmetrical, what is the extent of involvement, what is the site of involvement of the wall thickening, is there mural layering. There is a suggestion that if all layers of the gallbladder are seen, it is less likely to be malignancy versus if there is an invasion of the layers, which is more likely to be a malignant change. And how is the interface of the lesion with the liver? GB RADS has gone ahead and described 6 stages, which are equivocal, normal, benign, malignancy being less likely, and malignancy being high likely. This needs to be validated prospectively. This is an expert consensus guideline published in 2022 from a group from India, but this has not been validated. Depending on what your preoperative suspicion is, clinical findings, biochemical findings, and ultrasound findings, it goes on to decide whether we want to do an MRI or CT or any other further imaging or not. So the question to my mind remains is that what would be the parameters to which we decide that after this point in time we require to investigate the patient with more cross-sectional imaging. So we need to have a high index of suspicion, which is based on the clinical background. Elderly patients in India, younger cutoff for women; in the Western data, higher cutoff for men; patients who have vague abdominal symptoms, associated weight loss, derangement of liver function tests, which cannot be explained by acute calculus cholecystitis, a proper radiological assessment, which should entail a GB RADS, followed by any cross-sectional imaging. Thank you.
Thanks, Dr. Siddha. I think we should follow the sequence provided by the organizer. Dr. Diksha can join us here so that we can have discussion at last. Next speaker is Mr. Dr. Yung Bin Liu from China. He will be delivering his lecture online.
Definition of suspected gallbladder function. Talk is what is suspected gallbladder function. We focus discussion on that only.
सॉरी सर जमा कर दिया अच्छा डायरेक्ट यहाँ से एक्सट्रैक्ट नहीं हो रही है
Recorded है क्या?
Good morning, Professor. Good morning, Professor Liu. You can share your screen.
Yes. 我 share my screen. 我们就共享屏幕，共享屏幕在哪？共享屏幕。But I can't.
You are co-host now. You can share. Just see.
Yes,
yeah.
That's okay.
Sir, you have to open your presentation and go back.
Yeah.
Yeah.
That's okay.
Yeah. You can make it in PPT mode, yes.
Can you see my
Yes.
PPT?
Yes, sir. We can see, sir.
Okay, thank you. I'm so sorry. Dear professors and fellows, I would like to give my very thanks to Professor Kemper for inviting me to make a presentation at this conference. Today, I will share some of my observations and experience on the topic of the proper timing suspected gallbladder cancer in patients with gallstones in clinical practice. Our research and the clinical team based in university, affiliate hospital in Shanghai, Jiaotong University, China. My team mainly consists of surgeons, oncologists, pathologists, epidemiologists, and statisticians. These have been several interesting controversies and ideas among my faculties about proper approach to screen for gallbladder cancer when treating patients with gallstone. So in my hospital, maybe 1 year, we get gallbladectomy over 300, just 3,000 patients. There have been several interesting controversies and ideas among my faculty. This question began with the surgeons finding that some patients has been diagnosed with gallbladder cancers by biopsy and a simple colectomy for gallstone disease. In summary, except for considering the radical regional sex and age patterns, we assume that clinical may take notice of several indications during the interview with the patients. Will review the test report and even in the surgery. The importance of the interview patient in outpatient departments is usually ignored because subjective information from patient may not be as punctuated and accurate as lab test for image examination. However, systematic interview with special details about known risk factors such as the long-term course and the family histories and the gallstone history of biliary tract disease, body weight changes, and life habits may help what we miss is the diagnosis of gallbladder cancer. Back in 1980s, Dr. Trevino wrote a report on JAMA, elaborated that the gallstone size may have a positive correlation with the risk of gallbladder cancer. In 1997, a large population-based study was conducted by a former director of Shanghai Cancer Institute before me. After 10 years of follow-up, a report based on the cohort was published. Result of this study indicated that family history of gallbladder cancer significantly increased the risk of gallbladder cancer, especially in those whose first-degree relatives has been diagnosed with gallstones. These conclusions has been well recognized by experts over the world and was cited by 2029 ISMO guideline for biliary tract cancer. The latest available data of a global burden of disease study estimated the significant risk of effect of the 369 disease gallbladder by analyzed disease registry data and found only one risk factor related to the gallbladder cancer and biliary tract cancer, which is high BMI. Previous research about high BMI as a risk factor analyzed GBD data and found that high BMI attributes more to gallbladder cancer in females than males. Image examination. As a favorite test of surgeons, for it can intuitively guide diagnosis and treatment when a patient complains about abdominal pain or discomfort occurs. According to the experience of my faculty, ultrasound, CT scan, and MR are the most popular and efficient approach to a different gallbladder cancer from simple disease. Description in image examination reports like the center wall and atrophy, neuroplasma on the structural anatomy of a gallbladder usually alert clinical for potential risk of the malignant. Last year, American College of Radiology reported that and the data system has published a consistent named GB readers to guide the categorization catheterization of a gallbladder will seeking with a gradually increased risk of malignancy. In fact, our research team has been working on building the prediction model and the risk stratification system fitting the different characteristics of different locations. Chinese research group of gallbladder cancer, my leader, I am the leader, consists of a dozen of surgical centers in China and has gathered and structuralized epidemiological, clinical, and pathology information of more than 10,000 gallbladder cancer patients. We believe that localized cohort and well structured real-world data is the foundation for further population-based research, and more accurate precise diagnosis pattern will be built with the improvement of the population-targeted research. There are some photos of my research team. They are all dedicated specialists working on basic kind of clinical research of pancreas biliary disease. We welcome experts and specialist fellows over the world to visit our faculty in Shanghai and share their experience and views, as well as academic cooperation. Finally, I give my thanks, special thanks to the Coopers, Professor Cooper, giving me a chance. By the visa reason, I can't go to the India. 就是我怎么感到非常遗憾。
Thanks, Professor Liu, for your excellent talk. I request you to wait for the question-answer session to be online with us. Next speaker will be Dr. Osman from Turkey. He will also deliver his talk online. Please play the next talk.
Good morning. Thank you for this kind invitation and introduction. I will give my comments on this topic in 2 minutes. When to suspect gallbladder cancer is a difficult question. Actually, there are 2 reasons for this difficulty. First one is prevalence of gallstone disease is very high. It's like a forest. About 15 to 20% of the population has gallstone disease, and this is even higher in females. And the problem is the rarity of gallbladder cancer. Gallbladder cancer accounts less than 1% of all cancers. So the suspect is big, but target is small. So it's really a difficult problem to predict gallbladder cancer in patients with disease. On the other hand, incidental gallbladder malignancy is reported in less than 1% of all routine cholecystectomies for benign disease. Gallbladder cancer is rare, and it's also rare in cholecystectomies performed for gallstone. Besides this, there are well-defined risk factors, and basically these rely on history history and radiologic findings. Old age is a risk factor, especially patients older than 65 years old, and ultrasonography findings, including thickening of the gallbladder wall, bile duct dilatation, and presence of lymphadenopathies may predict gallbladder cancer. Unfortunately, these risk factors are not always reliable. Besides these well-known, let's say well-known risk factors, there are some other risk factors. We know some studies showing that if gallstone is larger than 3 centimeters in diameter, the risk of cancers increase. Again, the presence of gallstone and large polyp, usually larger than 1 centimeter, may be a risk factor. And in addition to these, general risk factors for gallbladder cancer, like family history, obesity, ethnicity, may predict cancer risk. In my experience, usually I think that asymmetric gallbladder wall biochemistry tests in these patients before taking these patients to surgery. I would like to thank you all for giving me this opportunity, and I'm glad that I was with you last year in Jaipur, but this year I couldn't make it. Hopefully we'll meet in person in the future Jaipur surgery meetings. Thank you again.
Thanks, Professor, for your nice talk. I'll request Professor Liu and Professor Osman to stay with us online for the question answer session. I also request Dr. Diksha to join us on the dais for the question answer. Now house is open for the discussion for the topic when to suspect gallbladder cancer in patient with gallstone disease. That is, what is the definition of a suspected gallbladder cancer in patient with gallstone disease? Yes, sir.
Hi. Thank you for the nice presentations. Enjoyed it. Sridhar Iyer from Singapore. So I think we need to have some clarity on these definitions of when to suspect, because we don't bat an eyelid when there is a thickened gallbladder on ultrasound report. And most of them are chronic cholecystitis. Half of them are done by the residents. There was a lot of talk about opening the gallbladder and looking at it. Are the eyes trained to look at it? Somebody who is certified to do a gallbladder and exited their exams are competent. So we need to be very practical. Now, even the definitions that we put when we suspect gallbladder cancer under these circumstances, let's say they have a 99% sensitivity and a 99% specificity. But if the prevalence is 1% in the population, that means it has only 50% accuracy. So basically, the population incidence will determine how accurate the test is. So if we are going to define something, it has to be defined across the population and not just specific to certain high-risk incidence areas. So that's my difficulty. So where do we draw the line? So best to have a sort of a Delphi consensus, because once we have guidelines, then you are, if you miss a gallbladder cancer, you will be liable if you don't follow those things. But otherwise, thick wall gallbladder in a high prevalence area, yeah, index of suspicion is high. In a low prevalence of area, index of suspicion will be low.
Dr. Diksha, you would like to comment?
So that's a very valid point. But even if we are identifying those 50% patients, I think we are on the nail. The other is, of course, I think what we need is a Delphi consensus in which we decide that based on the available data and literature, these are the pointers where we start suspecting malignancy and start doing additional tests. So actually, I wanted to ask the House 4 questions as to what should be the age cutoff when we should start suspecting malignancy. Do we, for the Indian scenario, do we want to keep it at 50, 55, 60 or 65? Because all the data comes for 65 as a cutoff. That's also what Professor here on his comments mentioned.
Yes, sir.
Next section. I'm Kishi from Japan. You mentioned that, sorry, I think the diagnosis of gallbladder cancer in gallbladder cancer is still a very difficult problem. And, and as you mentioned, the large system, the focal irregularity or thickening of the gallbladder wall could be one of the major or important findings. But I suspect the sensitivity or specificity to detect gallbladder cancer is still low. But in such cases, if you find the cases with focal thickening or irregularity in gallbladder cancer, you mentioned CT or MRI could be recommended. But in such cases, if the patient is especially is symptomatic with acute cholecystitis, do you recommend simple index cholecystectomy or schedule postpone the operation for the further examination to for the assessment of cancer?
No, what I believe is if there is some thickening in the gallbladder, which is asymmetrical, focal, in a patient who has large stones, which raises suspicion for malignancy, cross-sectional imaging may be recommended in the form of a contrast-enhanced MRI or a contrast-enhanced CT scan. And the surgery should include a frozen section, followed by, if we find evidence of malignancy, to proceed to a radical cholecystectomy.
Dr. Diksha, what should be the suspected gallbladder cancer? What should be the definition of a suspected gallbladder cancer patient with symptomatic patient with gallstone disease comes to our OPD?
Sir, in a patient who's elderly, for Indian scenario, I would say that 65 is a little on a higher cutoff. For our scenario, we might want to decide a little lower cutoff. Patient for whom the symptoms do not fit into a typical gallstone disease. Either it's an incidentally diagnosed large stones with wall thickening, there are vague abdominal symptoms, associated weight loss, there is derangement of liver function tests which do not get explained as acute cholecystitis, and the ultrasound findings are not of a plain simple gallbladder. I think we should evaluate further for malignancy.
Professor Liu, what should be a suspected gallbladder cancer? When will you suspect gallbladder cancer? What should be the definition? Professor Liu, please.
Yes. Yeah. That's sorry, pardon?
What are the findings, clinical or radiological, and ultrasound when will to suspect a patient with gallbladder cancer? The patient may harbor gallbladder cancer. When will you suspect? What is the criteria for that?
Gallbladder.
Professor Osman, you can also
so we can't follow you clearly because of the bad internet. So, is your question about which symptoms should be for the gallbladder cancer for the surgery or something like that?
Yes. What should be the criteria for to suspect gallbladder cancer? Maybe an ultrasound or clinical.
Clinical what?
Yeah.
Sorry, I can't follow your question.
I think you can place question, but what should be the criteria for Sadiq sir to suspect a patient with gallbladder cancer? Yes, sir. Should be age only age in isolation should be a criteria for it. Should be in association with other factors should be a criteria for the to suspect gallbladder cancer.
Could you please type in the question in the?
Just I would like to make one comment. As we have listened to the talks, BMI is a predictor, age is a predictor, size of the stone is a predictor, in biochemical alkaline phosphatase is a predictor, previous study CA 19.9 is a predictor. Can't the house or all the make a consensus and make a scoring system based on the clinical, radiological, the GB rad imaging and the biochemical parameter to say that when to suspect a gallbladder cancer in a patient with gallstone disease? A patient, young female with a large stone is having more risk rather than a patient with even 55 years of age and a small calculi is at, I feel, is at lesser risk. can't we assign score to each of the risk factor and then devise the when to suspect a gallbladder cancer in a patient with gallstone disease?
So you're very right that there is evidence that goes and says that patients with comorbidities, obese, hypertriglyceridemia, elevated CA99, but when you look at the data or the statistics, the odds ratio or the hazard ratio are not very high. They have not even crossed 2, or they are in the early parts of, between 1.3 and 1.6 or 7. Do we want to investigate every patient with a CT scan or an MRI? If that is there, is the question. Also, we need to differentiate the data that is coming from the West versus what's coming from India. We know from our epidemiological studies that gallbladder malignancy is seen at a younger age in women. We keep a cutoff of 65 for investigating a potential malignancy. We are going to miss out a big chunk of incidental or suspected gallbladder malignancies. I think it has to be, a lot of it requires uniformity of imaging, a proper reporting, and then identifying which factors can have the maximum prediction. Radiology will likely play the most important part. If an asymmetrical focal thickening of the gallbladder is documented, it might be prudent to say that it mandates further investigation irrespective of the age or the size of the stones.
Dr. the idea of this talk is to define patient with suspected gallbladder cancer to avoid, to reduce incidence of missed gallbladder cancer by providing them adequate imaging and adequate treatment, appropriate treatment, and to avoid over treatment and under treatment for the patient. For that, we have to make some guidelines. In my opinion, as Dr. Kapoor said, any gallbladder on ultrasound having more than 3 mm of thickness, maybe focal or circumferential, should be considered as a first suspicion for the gallbladder cancer, and depending on the clinical and other age factor or biochemical factor, it should be further evaluated. Suppose if a patient has got raised bilirubin, acute cholestatis, they should LFTD range, raised bilirubin, raised alpha, they should go for MRI for further diagnosis, and patient with acute symptoms and signs of acute cholestasis should go for CT scan first. Patient with suspected Xantho should be evaluated according to that, maybe CT or MR or endoscopic ultrasound or further imaging to decide the treatment plan.
Yes, sir, I agree. Sir, Dr. Liu or Dr. Osman, hi, can you hear me? Good morning.
Good morning, yes, I can clearly hear you.
Sir, would you like to make some comments?
Yes, please. Thank you very much for your nice presentation and nice review. Actually, in my country, in Turkey, the prevalence of gallbladder cancer is not very high. So, regarding ethnicity, the Turkey is not a common part of the world regarding gallbladder cancer. In my clinical experience, number one finding suggesting gallbladder cancer is asymmetrical gallbladder wall thickening. You know, in many patients we see gallbladder thickening for long-standing chronic or acute cholecystitis effects, but these are for entire gallbladder wall. In cases with gallbladder cancers, according to my experience, this thickening is to a certain part of the gallbladder wall, and it's asymmetrical, not circumferential. And the second important finding in my practice is atypical presentation. And the most important finding is persistent pain. In gallstone disease, the pain is usually colicky, it comes and goes, but in cancer it's persistent. So if I see a patient with persistent pain and asymmetrical gallbladder wall thickening, I always order an MRI scan, not CT. In my personal experience, if sonography findings are and clinical findings are in correlation with cancer, the next step should be MRI, not CT. MRI seems superior to CT, and in MRI, the most prominent finding is nodular thickening without layering. If the layering anatomy of the gallbladder is disrupted, it's most likely a cancer. So we go in a stepwise fashion, and also agree with all the speakers that drawing a line is very difficult. And I think we have to work on this field for many years for clear definitions. But for now, we have to rely on sonography and MRI according to my experience. Again, thank you all for the kind invitation.
Thank you, sir. Thank you for chipping in.
Yes, sir.
Actually, what we are trying to do is we are trying to put suspected gallbladder in a single basket. Suspected gallbladder should be clearly categorized as clinically suspected, radiologically suspected, suspected at the time of laparotomy or laparoscopy,
Yes,
or suspected after opening the gallbladder. And all four scenarios need to be discussed and handled differently. There is no single answer to it. And
So what should be clinical criteria, sir?
clinical criteria she has very wonderfully outlined. The moment you have an older lady, the moment the patient is a female gender, there is a pain, persistent pain. If there is a jaundice, there is a weight loss, you should consider it as clinically suspectable. And if your ultrasound findings, the first investigation obviously is an ultrasound. And if your ultrasound finding does not correlate with your clinical history, you should proceed with further investigations.
Okay, fair enough. Sir, Sadiq sir.
So I have two comments. One is, your point about having a scoring system. So the Dutch have made a scoring system of various clinical parameters to suspect whether they should send the specimen for histology or not, with a high sort of incidence of cancer in that. And we could have a similar kind of scoring system because our parameters will be very different from what they have taken. But I think that may be one of the important steps to collate all the high risk factors and at least to say that in these more detailed evaluation should be performed. And that we have enough data so as to collate that and come out with a scoring system. The second part is about the thick-walled gallbladder, what Dr. Nag you mentioned. Now, long back, if Dr. Kapoor would remember, we did a study at SGPGI of thick-walled GB, which were all examined by a CT scan, right, uniform thick wall. And 3% had gallbladder cancer in the thick-walled gallbladder. But interestingly, none of those three were picked up on CT scan. So, to say that uniform thick wall, and this is in Lucknow, so a high incidence belt. So to say that all thick wall GB scans should be, gallbladders should be viewed with suspicion and evaluated further would be a much higher burden of investigation to all of them. So these points that focal thickening certainly uniformly comes as a important point. But I still feel that this group can come out with a scoring system which would collate all the data. Thank you.
Okay, sir. Sir, I think points are well taken. House agrees to have clinical features to suspect gallbladder cancer. Then ultrasonological features should be defined. Then further imaging should also be defined. I think this topic needs further discussion to frame the final guidelines.
Thank you, sir.
Thank you, everyone. I request for a tea break for 15 minutes. We'll again start the next session at 11:30. 15 minutes after that. Sharp.
कॉपी कर लीजिए, ये सिस्टम ही लगेगा। एक मिनट, एक ना बाहर होगा, बाहर ही नीचे चलिए, एक मिनट। कौन सा अपडेट है? जल्दबाजी में मैं पुराना भी लाया, नया भी लाया। इसको खोलेंगे कैसे? तो ये तो काम नहीं कर रहा। अच्छा ठीक है। ये है कौन सा आपके पास प्रोग्राम बुकलेट है? चेक कर लो। ठीक है, ये वाले। भैया ये क्या हो गया आपका कॉपी? आपने नाम ये रीनेम कर दिया? हाँ सर, स्टार्टिंग में ये नाम दिया था ना आपको। अच्छा, तो बंद कर दीजिए। रहेगा आपके नाम के साथ।
हाँ
Mr. Parikh is our media in charge. He wants that we have a group photograph. So can I request everybody to please come here for a minute so that he can have a group photo and then we can restart the session. Yes, please, everyone.
Good morning all. Next question of discussion, when to suspect GBC during cholecystectomy and then what to do. For the session, I would like to invite chairpersons Dr. Lakshman Agrawal. He's a senior professor at General Surgery in Mahatma Gandhi Hospital, past professor and head General Surgery SMS Hospital, Jaipur. Sir. And I request Dr. Puneet, he's a professor in Department of General Surgery at IMS BHU Varanasi. I request chairpersons to call our lead presenter.
Yeah. I welcome you all to the next session, and that is on when to suspect GBC during cholecystectomy, then what to do. And the lead presenter for this is Dr. Sarwari. I invite Dr. Sarwari to have a presentation.
JSF 2019. This is JSF. I have a pen drive. I have it on pen drive also. हाँ, pen drive लगा दो.
वहाँ दी नहीं है. वहाँ दी नहीं क्या मैडम की पेन ड्राइव.
Good morning, everyone. So after the end of first session, now I think we have reached a consensus to define what is incidental GBC, and that we can, if we are defining it as that one which is detected on histopathology report after cholecystectomy for presumed benign disease, still a situation persists, the one in which the GBC is suspected for the first time during cholecystectomy. And majority of the literature, as it was pointed out by the previous speaker also, talks about the situation where the and calls the incidental CAGB is the one which is detected on histopathology after the surgery. In spite of widespread cholecystectomies, thousands of cholecystectomies being done every day, there are hardly any literature is there which clearly indicates what are the intraoperative features which indicate malignancy, and neither there are guidelines to tell us what to do in such a situation. So in this context, we have undertaken this research question so as to find out what are the intraoperative features suspected during cholecystectomy and what should be done in such a case. So the exclusions are all those cases where the GBC is preoperatively diagnosed, preoperatively suspected, and also post-operatively detected GBCs are excluded from my research, my review. So there are various possibilities when the surgeon refers a lab call as a difficult lab call. However, those findings which indicate malignancy are less clearly identified. Some of the cases, like finding an obvious mass infiltrating into gallbladder, or metastatic disease, peritoneal and liver metastatic mets and ascites will be the obvious things. In that case, it can be considered as missed on preoperative imaging. But but even after excluding these situations, there will be some factors like dense adhesions around the gallbladder. When the gallbladder appears to be infiltrating into liver and surrounding structures like duodenum, colon, and fistula formation, these can be some of the factors which may raise the alarm of being malignant case. Now this paper, I have taken this paper because they have reported all the intraoperative findings in all these 6 patients which were labeled as incidental gallbladder carcinoma. And in that, thickened gallbladder wall is the most common finding in all the patients, along with the presence of stones. But however, in out of these 6 also only in one patient there was intraoperative suspicion of GBC, and in that case there was callot strangle was difficult to dissect, and presence of dense surrounding adhesions were reported. So thick wall GB, which is also seen in most common, and we have already discussed about it, it is defined radiologically as more than 3 millimeter thickness. However, if we come to an intraoperative situation, it is very difficult to determine exact thickness of the gallbladder wall if it is not done preoperatively. So we can think that intraoperatively thick wall GB, which is difficult to grasp, can be a factor which should raise alarm of malignancy. So Batra et al. Have also reported that presence of chronic inflammation leads to thickening of the gallbladder, and it is carcinogenic, so that can be considered as one of the feature suggestive of malignancy. Now this Swedish registry, which registers about more than 36,000 patients, the data from this registry is there, and their study was to aim to find out the predictors of malignancy. They excluded preoperatively diagnosed GBC, and in their study they found older patients, women with previous history of cholecystitis, jaundice, and acute cholecystitis were the risk factors in which the IGBC was more likely to be diagnosed. Now coming to xanthogranulomatous cholecystitis, we know that it masquerades malignancy. However, there are few reports which tell us that both the conditions may coexist, and so also is the case with Miriz's syndrome. Miriz's, especially in elderly patient with long duration of disease, is considered to be a pre-malignant by some authors. Now coming to what to do if such a situation is there. So usually the lab call is being done, the usual scenario is the lab call being done in a smaller setup with modest expertise of the surgeon, especially in the field of oncological and HPB surgery. So So now there is a dilemma about presence and confirmation of malignancy, staging of malignancy, resectability of the disease, and whether to proceed or abort the procedure, and whether biopsies should be taken or not. Now we have enough evidence to suggest that the long-term survival, in the long-term survival, there is no difference when the patients are operated in the same stage or after cholecystectomy also in incidental CAGB. So the ICMR has given the consensus that if any of the above factors which I just said, that is about the center or the expertise of the surgeon, are compromised, then it is prudent to abandon the procedure, and it is recommended to make a detailed note of the findings and refer the patient to a specialized HPB center. In such a situation, the biopsy may be considered only from the lymph node or omentum if chemotherapy is contemplated considering a neoadjuvant treatment. And gallbladder perforation must be avoided in all the cases. Now, if there is a situation where there is some opportunity to proceed with radical surgery, means surgery is being done at a highest center with the highest expertise available, can we proceed with the surgery? And in such a situation, whether we should confirm the diagnosis by intraoperative histological examination. Various authors emphasize the intraoperative diagnosis as it helps to decide the treatment strategy and also decide the extent of surgery and need for radical resection. However, exact method to obtain tissue diagnosis intraoperatively remains unclear in the literature, and the optimal diagnostic method appears to be core needle biopsy, preferably transhepatic. Now, this paper, which talks about incidental GBC, and they have compared intraoperative and postoperatively detected IGBCs, and in their series, 40 patients were diagnosed to have IGBC and 13 underwent radical operation, and they have chosen intraoperative frozen section as when the suspicious lesion was found. But in fact, from their methodology, these 40 patients were excluded from the further study. So they have just they have just noted these patients as intraoperatively detected CAGB patients. From this another paper which has from Nitta et al. And fairly large number of patients, 529, 8 patients had IGBC, and they emphasized to form a strategy whenever there is suspicion of malignancy. And they also performed intraoperative histological examination for suspected cases of GBC. They highlight that intraoperative examination facilitates surgical resection of tumor. Frozen biopsies from cholecystectomy allow for intraoperative diagnosis, and full thickness frozen biopsies should be taken. Regarding full thickness frozen biopsies, that is the cholecystectomy, Choi et al., the paper which was already discussed about, they advocate again full thickness frozen biopsies from laparoscopic cholecystectomies, and if positive, they added the lymph node dissection. In this paper, which talks about the surgical management of GBC, what they have done is after evaluation, after staging, when the patient was offered a radical surgery, they have added one more step of surgeon's assessment, and whether the intraoperative frozen section helps the surgeons, adds into the surgeon's assessment to reduce unnecessary lymphadenectomies. And what they found is that in their alternative approach, where the surgeon's assessment was added with intraoperative frozen section, it led to unnecessary lymph node dissection reduction in all the cases, whereas when only surgeon's assessment was done and radical cholecystectomy was carried out, more than 50% of the times it appeared to be inadvertently done lymph node dissection. Now there is no doubt about the fact that macroscopic examination of the gallbladder specimen should be done, and it is discussed already in detail. This is a study from Kapoor sir, and in all these cases who talked about intraoperative diagnosis, the cholecystohepatic plane has got violated. So this is a novel concept proposed by Dr. Kapoor's team, that is the anticipatory extended cholecystectomy. And the rationale behind that is non-violation of the cholecystohepatic plane, and unwanted lymphadenectomy was avoided. They reported 13 patients, as was also quoted by Dr. Sadiq just now, and in 3 patients, frozen section was done. GBC was on frozen section, GBC was suspected in 2 and suspicious of GBC in 1 patient, and on final HPR where the lymphadenectomy was added in all 3, and on final HPR malignancy was found in 2 of these 3 patients. This is another approach where Omi et al. Have proposed laparoscopic whole layer cholecystectomy, and they give a protocol when there is suspicious benign lesion or adenomyomatosis or thickened gallbladder wall. They propose to do a laparoscopic whole layer dissection, and they have explained their intraoperative procedure where the plane of dissection goes behind the serosa of the gallbladder and the liver bed is exposed. And they propose that this can be a safe procedure if there is a suspected gallbladder mass intraoperatively. Now this is a recent paper again from Kapoor sir's group, says that whenever there is any suspicion, this should be considered as GBC, and if you want to proceed, then it should be performed by an extended cholecystectomy. NCCN guidelines in 2023 also mention that if there is any compromise about the center, about the expertise, doubt about the resectability, then it is prudent to abandon the procedure and refer the patient to higher center. And if we are going to do anything curative for the surgeon, then it is nothing but the extended cholecystectomy. Thus, coming to conclusion, these can be the intraoperative factors indicating malignancy, like finding obvious mass, dense adhesions to the surrounding structures, frozen calots and mirices, especially in elderly patients. And in absence of any guidelines as of now, it is prudent to abandon the procedure if anything is compromised. Simple cholecystectomy should not be done. Intraoperative biopsy should be avoided to prevent dissemination, unless it is a neoadjuvant therapy where a transhepatic or omental or lymph node biopsy can be considered. And if a decision to definitive surgery is taken, then it should be extended cholecystectomy adhering to all oncological principles. And this is the proposed algorithm which I can draw of according to the review of this literature. So if there is nothing, if there is any compromised thing, then directly refer. Even if expertise and everything is available and it is a clearly resectable lesion, then extended cholecystectomy may be considered, but still in view, I have not included all the views like no informed consent and evaluation of the patient is not done. But so even if everything is available, then also we can abandon the procedure. And if there is, if there is any doubt of resectability, and definitely if it is unresectable, then biopsy can be taken to go ahead with chemotherapy. This is a proposed algorithm and not published. If everybody agrees to this, then we can think of this. Thank you.
Next speaker is Dr. Matilo Dotani. May I invite him to give his talk?
Dr. Masilo is Associate Professor in Surgery in the Department of Surgery and Medical Surgical Specialties, Italy.
Let me say first many thanks to Professor Capo for this invitation and for giving me the chance to make some consideration about what we have had till now. I would like first to underline that I work in a low incidence area of this disease. So please consider that in Italy, those are IOM data, Italian Association of Medical Oncologists, we are dealing with 5,400 carcinomas, gallbladder carcinomas for year. So divided in our 20 regions, and for 60 million citizens, it's a very low incidence. We have around 0.5 cases each 100,000 citizens. And so, as already said from someone of the speaker, is, by some of the speaker before me, is it's difficult to develop standardized guidelines for something that is very rare in front of an intraoperative suspicion that can be really that can be realized much more often, because we have many also advanced chronic cholecystitis and something like that. So that is difficult to define. Of course, the object of my presentation is not such an advanced cholangiocarcinoma in which even the suspect or not the suspect has no rule on consequence on the surgical treatment. So we are dealing with 0.2% of all the cholecystectomies, and those are the conditions that are associated with the bladder cancer, as already said by other speakers. So let me summarize some things. You see also when we speak about gallbladder polyps, the real incidence at the definitive histology is very low. So consider those data before develop guidelines. Maybe operative flow charts should be different in low incidence area and in high incidence area, and this should be considered in our guidelines. So how is incidental gallbladder cancer? It can be during a laparoscopic cholecystectomies or an open cholecystectomies, or converted also cholecystectomy, and this risk was already stratified by some study. Simply the fact that we are performing an open cholecystectomies in the study is raising the risk, the intraoperative risk, because of course maybe there are already some local conditions suspected for gallbladder cancer that are hosting us to perform the operation completely laparoscopically. So you see there are different incidents in the three approach. So when to suspect it was already said. There are all the macroscopic signs that were already discussed. I don't want to go through these data, were already extensively discussed, but such retracted gallbladder with this change also of the lymph nodes and are already suspicious lesions. Of course, all those aspects were also already listed. So the role of the intraoperative biopsy, and there is the consensus of 2015 that is already establishing that we need at least 3 samples of the cystic duct in front of the abnormal appearing gallbladder, and of course the role of the pathologist is here a key role. So the frozen section has a very nice reliability, and those studies has showed this. You see only 2 false negatives, so we can rely on a good biopsy with a pathologist that is looking at this gallbladder in the right way. And then what to do? I liked a lot the flow charts right presented from the colleague. I think that Capo proposal is very nice. Is good not only for a high incidence area but also low incidence area. We can say that the kind of resection is standardized. When we have to proceed to a resection, it must be with segment 4 or 5, or at least a wedge resection of the liver bed. And this was already stated and clarified. Please consider that with also from Swedish registry data, the cumulative overall survival, of course, with resection is much more implemented. So, but the point is when to do the Dembler resection, the lead resection, and a good answer was, please consider if you are in an HPB center or you who's managing the patient is an experienced liver surgeon. For me, this should be is a key point, of course, and consider also that only 1/4 of the patients we we do a reduced surgery or we extend with a resection, because sometimes there are general conditions or local conditions for the tumor that are avoiding or hosting an extension of the resection. For example, we know that for T1B, there is no influence of extension on survival, so we must consider it for T2. And for T3 patients, maybe T3, despite T3 has a poor prognosis, and as you see, the R0 resection at T3 is implementing very little the survival, the overall survival of those patients. So that's just to show you how rare is such a lesion in Sicily. It is the region which I work, and we have maybe also less than 0.5% of incidence. And in the open cholecystectomies, we had more incidental gallbladder cancer, and but we have only 9 surprise in quite 800 cholecystectomies. So it's something to be considered in developing flow charts, especially for the Eastern countries. In conclusion, I say that intraoperative gallbladder cancer suspect should be based on of course, on the appearance, as already said and listed in a lot of indirect signs, direct or indirect signs, and presence also of risk factors. You see also for gallbladder polyps, the progression of the growth progression of the polyps seems to be a key point to suspect. Of course, the suspect should drive a correct frozen section technique, and the positivity should induce a change on the surgical management only in a limited stage of those patients. Already T3 has a very poor prognosis, so maybe the surgeon must really think about extending the resection if there are high risks factors or local condition, also general condition which the patient is coming to operatory theater. Sometimes is an emergency operation, is perforated or something like that. So this is hosting for me an extension intraoperatively and should be delayed, maybe the definitive treatment. Thank you very much for your attention.
Thank you, Dr. Marcillo. Now I invite Dr. Thomas Gambling for his comments.
All right, great. Thank you so much. I'd like to thank Dr. Kapoor for the kind invitation. And as a commenter, I get to try not to say too many things that have already been heard several times and maybe add a little bit more to it. Really what we're trying to do this morning is talk about avoiding the script of being in the operating room at all with gallbladder cancer. You know, many of the gallbladder cancers are not recognized unless there's carcinomatosis or evidence of metastatic disease. And the gallbladder is commonly entered in lap choles. And so we know that it's entered somewhere between 20 and 30% of the time with elective gallbladder surgery, and we know that that's twice that probably with cancer. So this is a huge part of the detriment of our patients. Surgeons often don't examine gallbladders on the back tables in the United States. We again, as was said from Italy, are in a low instance institution, but we're a high referral center, so we see an awful lot of the second operations at our center. And the surgeons usually will call and say, I've got a patient I need to send you, they have gallbladder cancer, I'm amazed, I'm so surprised on their pathology, I'm certain that they don't have disease elsewhere. And so I guess one of the things I would add to our algorithm that we say is that at the time of assessing someone in the operating room, they really need to be placed in reverse Trendelenburg and left lateral and right lateral decubitus. I mean, their entire peritoneum needs to be closely examined at the first operation before they're referred for their second operation per se, or maybe their definitive operation if, as the speaker said earlier, it's abandoned. So, identifying prior is the key, the cholecystitis, the stones that are long-standing, the women more than men, the 7th decade of life, the suspicious ultrasound findings we've talked about all morning, and then really approaching them open unless the skill set of the surgeon is unique in that setting. Obviously, allowing us to diagnose them preoperatively allows us to stage them adequately, provides perhaps a window for neoadjuvant therapy, spares the patient really with advanced disease, even the laparoscopy. And I would say that even when they're referred to me after their cholecystectomy has been done and it's an incidental finding of gallbladder cancer, even if I'm going to do it open, I still put a laparoscope in them first on the second operation, because I would say probably about 40% of the time I find carcinomatosis that the surgeons simply were tunnel vision, general surgeons taking out gallbladder after gallbladder, or residents taking gallbladder after gallbladder, and they didn't look around. They recognized it as a difficult case. They were amazed that it was a cancer case and the peritoneum wasn't inspected. So that would be one of my take-homes for you today. Obviously, we see patients with significant weight loss, with PSC, with chronic infections, large polyps, especially sessile ones, the thickened gallbladder wall that we've talked about all morning. Perhaps enlarged lymph nodes, even on the ultrasound, might trigger us to get cross-sectional imaging. Elevated CA19-9s well beyond the normal range in clinical jaundice. And we see shrunken gallbladders, we see intraperitoneal disease, suspected distal. We look on the back table at the wall. As was mentioned earlier, we palpate it. It's cheap, it's there for us to do. I really think that when we're doing these operations, if we describe that we've obtained the critical view of safety, we should be describing that we opened the gallbladder on the back table, and we should be describing that we inspected the peritoneum. So the intraoperative decision time, really there are no studies that have demonstrated that it's superior for a one-stage versus a two-stage, and so in that light, as was already described, the more radical surgery is not mandated. The patient obviously has to be fit for a more extensive operation, as we all know. The family really needs to be consulted if you're going to proceed with something beyond an outpatient same-day surgery. And so we would certainly advocate pausing, going down and speaking to the family members, the decision makers while that patient's asleep, if we think they're fit for that. And I think the experience of the surgeon really guides the decision making. So some surgeons in the United States would stay laparoscopic and perform a wedge of the liver, a little bit of 4B and 5, and do a lymphadenectomy. But if we're compromising the operation, staying laparoscopically, then I certainly wouldn't advocate for that. I think the cystic duct margin influences what we're able to do with minimal impact to the patients. If we're taking simply a small portion of the liver with the gallbladder and stripping out some nodes, it's quite different than a common bile duct resection and a roux limb and such. And so I think that margin may lead surgeons to either stop or go forward. Preparing for the second surgery, and the only reason I put this in here is because the T&M staging, we're just guessing in the operating room, right? We have a patient with an ultrasound only. We have no idea what their chest looks like. We have no idea anything else about this patient, and so we can certainly assess margins and such in the operating room, but the T&M staging is what we're really missing there. So I think the take-homes that I would add to the group are just that frozen section may guide the cases, and that if distant disease is suspected laparoscopically or if the gallbladder is abnormal. Certainly laparoscopic partial liver resection and lymphadenectomy is based on the expertise of the surgeon and would be only considered in light of that if you had no staging scans. And I would say too that many times in the United States people are beginning to talk about partial cholecystectomies and a difficult gallbladder, and you're terrified that you're going to hurt the common bile duct, and so now you're going to open the gallbladder, you're going to take out the front wall of the gallbladder, you're going to stitch something down at the distal end of the gallbladder and leave a large portion of the gallbladder behind, and this would be incredibly detrimental to the patient. So I think that this should really be spoken to as well as we talk about the difficult gallbladder that might be gallbladder cancer, but certainly shouldn't have a partial cholecystectomy. So I appreciate the time. I hope that adds some comments to our discussion. I know we have two more people to comment this morning, so thank you for your attention.
May I invite Dr. Abdul Hakim for his expert comments. He is at Leeds Teaching Hospital, NHS Trust and University of Leeds, Department of HPB Surgery and Liver Transplant.
Abdul Hakim Rahman नहीं है.
स्विच करना ऑडियो देना 2 नंबर.
My name is Abdul Rahman Hakim. I am a consultant hepatobiliary and liver transplant surgeon at Leeds Teaching Hospital, NHS Trust in the UK. First of all, I would like to thank Professor Kapoor and the team at the Jaipur Surgical Festival for this fantastic opportunity to talk on this important topic. Apologies that I am not able to be there in the meeting. And also sincere apologies if I am repeating something that you've already heard in since the morning. The topic that was given to our group was when to suspect gallbladder cancer during cholecystectomy and what to do. So obviously the suspicion should come when you're thinking in terms of the patient demographics, especially in high incidence areas such as the Asia, in northern India especially, and also in African American background, and also those patients who are older, let's say more than 70 years of age, and also the female gender is high risk for gallbladder cancer. And also in terms of the symptoms, I think sometimes patients do mention that there has been change in symptoms where from the typical biliary colic intermittent pain, the pain becomes continuous. So these are the things that can help you to find out whether there is actually some element of suspicion that things have changed. Further to that, I think when you look at the investigation, they might have a high alkaline phosphatase due to the compression of the bile duct, or there could be a mass lesion that has been picked up on the ultrasound scan, or a polyp that is more than a centimeter, which is the usual recommended guidelines for consideration for cholecystectomy, or the ultrasound scan or any other imaging might show that there is focal or diffuse asymmetrical wall thickening. Obviously, those who have got porcelain gallbladder are at risk of converting to a cancer. So these are some things that you might look at in terms of suspicion for gallbladder cancer. Intraoperatively, I think obviously the main suspicion comes when there is a risk of conversion to open because the anatomy is difficult or there are no planes, and you found that the gallbladder is extremely hard and immobile, and has been some involvement of the local structures, whether it could be a cholecystoduodenal fistulas or the colonic fistulas, or you're obviously sort of through the calyx and then taking the gallbladder off the liver bed, and you notice that there is some liver involvement. Obviously, a late stage when you actually have a suspicion of this, but that can happen. So intraoperatively, there are various things that can lead to you to think that there might be a gallbladder cancer. Now, at this stage, I think what to do when you've already there is some suspicion of gallbladder cancer, but you're not entirely sure. Obviously, there's a lot. All this depends on various things. I think one, depending on what is the setting. Is this a small hospital where you cannot complete do a completion cholecystectomy, or obviously the surgeon skill set. Is this a general surgeon doing it or a hepatobiliary surgeon? For example, in the UK, obviously, if this operation is being done in a district general hospital, obviously they would want to abandon it and send the patient to a tertiary hospital so that it can be appropriately staged and appropriately operation be carried out. And obviously the other important thing is to think about the consent of the patient. Has the patient been consented for an extensive surgery, including the liver bed excision or lymphadenectomy or a bile duct excision, and what stage of the operation you are in? You've already through the liver the bile duct, cystic duct has been already been clipped, cystic artery has already been taken, and you're taking the gallbladder out the liver bed. Is this the right stage to actually abandon the operation or to complete the operation because you've identified the tumor at a very late stage? So obviously there is a role for intraoperative frozen section. There are data to suggest that this actually helps in terms of reducing extensive surgery, but the most important thing when you think in terms of a frozen section is not to perforate the gallbladder or to spill any cancer cell, because that can lead to a poor oncological outcome. And obviously the important thing, as I said, I think suspicion is very important. Has the patient been appropriately consent to complete the operation? If not, obviously think in terms of abandoning early and then stage the patient with appropriate imaging, possibly a neoadjuvant chemotherapy if it is required, and then relist at the next possible availability. Obviously, the important thing is to think about radical surgery only when you are definitely sure and the patient has been appropriately consented. So in summary, I would want to say that there needs to be a high index of suspicion in any cases of cholecystectomy, but obviously if there are features of atypical clinical and ultrasound scan finding or any other imaging finding and in high incidence areas, frozen section is useful when there is index of suspicion, and obviously operate in the right setting of this right setting. If there is any suspicion, this has to go through the multidisciplinary team meeting, and appropriate imaging needs to be done before the patient is taken, and more importantly an appropriate consent to be obtained to see what you can actually do which is beneficial for the patient. And obviously all of this will help to preventing the over-treating of these patients with radical cholecystectomies. For example, in cases of xanthogranulomatous cholecystitis, where there are some suggestion that we should actually do much extensive surgery, but this can be avoided if frozen section is done appropriately. Again, thank you for all your time, and I apologize again if I've repeated something that you've already heard in the morning. Thank you.
Next, again, we have online comments there from Dr. Hop Tran Sanderson. He is Associate Professor in Department of Surgical Oncology, Division of Surgery in University of Texas, MD Anderson Cancer Center, Houston.
Hi, this is Hal Tranko, joining you from MD Anderson Cancer Center in Houston, Texas. Sorry I couldn't be there in person, but I appreciate the invitation by Dr. Kapoor and the organizing committee. Let's jump right into the question. When performing a laparoscopic cholecystectomy for a presumed benign condition, when should you suspect a gallbladder cancer? And if that is the case, what should you do? We'll assume that most patients, when they are taken to the OR for such an operation, only have an ultrasound to guide them, and very rarely do they have cross-sectional imaging. In the operating room, the typical findings of a gallbladder cancer, an incidental gallbladder cancer, would be those that mirror a quote-unquote difficult cholecystectomy. By that I mean the presence of adhesions, especially not only of mental adhesions, but solid organ adhesions or involvement with the gallbladder. Whether the colon is pulled into the gallbladder, the duodenum is pulled into the gallbladder. When you find those things, that is a worrisome sign and should be an indication, as are subsequent findings that I'll share, to pause, step back, look around, assess the belly space, the peritoneum for any nodules, any abnormalities that may suggest more advanced disease disseminated kind of peritoneal carcinomatosis. Likewise, look for ascites in a patient who shouldn't have any kind of fluid in the belly. Those are things that you should assess for when encountering a finding that may suggest gallbladder cancer. Another thing is, even in the absence of these dense adhesions, if you find that the gallbladder is very thickened, and difficult to grasp, that may be a sign of gallbladder cancer as well. Now, of course, we all know that in the setting of cholecystitis, you can also have a tense, distended, difficult to grasp gallbladder. But if the wall is especially hard and thick and difficult to handle, again, that is another sign of potential gallbladder cancer. Another area that may suggest the presence of a malignancy is as you start dissecting the gallbladder along the cystic plate away from the liver, you may encounter that space, that cystic plate is violated. You now have effacement of a natural plane that should exist between the liver and the gallbladder. In such a situation, again, step back, consider performing an ultrasound in the operating room. Look for any kind of mass or corresponding mass or tumor that may be invading into the liver directly. What you don't want to do is come across tumor and render a potentially curable situation into a no longer curable cancer condition. When encountering these findings, again, it's important to just assess the peritoneum, assess the rest of the abdomen, look at the rest of the liver, see if there's any other lesions on the liver surface, or even on ultrasound, other tumors and nodules within the liver that may suggest intrahepatic metastasis. Next, ask yourself, are you in a facility? Are you equipped with the ability to take care of a cancer of this nature? And by that I mean, do you have what it takes to perform a radical cholecystectomy that may be difficult, that may require bile duct resection, especially if the gallbladder cancer involves the infundibulum of the cystic duct and may involve, therefore, the common bile duct. If you are not, it is best to stop, get out, close the patient, and then refer the patient to a high volume center with expertise. I think it's always a good idea to get the cross-sectional imaging whenever you suspect gallbladder cancer, and therefore don't burn any bridges. Back out before you create any true damage or trauma. If you are going to want to biopsy something, all the more reason to perform an ultrasound, and then, if need be, do a transhepatic biopsy of the mass if you find one. Although we understand that sometimes that may not be fully accurate. And certainly if you see any kind of nodule or other masses surrounding the gallbladder, whether it be in the liver, on the peritoneum, or on the omentum, get a piece of that and send it to pathology. So in summary, just some key points. One, if you see marked inflammation, marked signs of difficult quote-unquote gallbladder cholecystectomies, adhesions of solid organ or omentum, a thickened hard gallbladder wall, effacement of the natural plane between the gallbladder and the liver, difficult dissection of the callose triangle, those should all give you pause and make you suspect the presence of gallbladder cancer, number one. Number two, once that's the case, assess the peritoneum, assess the belly, assess the liver, look for evidence of metastatic or distant disease. Number three, stop if you don't feel comfortable, back out, get cross-sectional imaging to stage the patient fully, obtain some blood work, including CA19-9, for instance. And number four, refer to a high-volume cancer center or a high-volume center that can manage gallbladder cancer and has experience doing so. I hope these words will help you, and please feel free to reach out to me should you want to chat more. Thanks a lot, and have a great Surgical Festival. Thank you.
Thank you, Dr. Sandarshan, and we invite comments there from the floor.
No, I just want to say thanks to Dr. Sanderson for being online at 1 a.m. in Houston, Texas.
Oh, that's great.
Yeah, this is Dr. Sumita Jain, HOD Surgery from SS Medical College. I just want to know one thing. What should be the take-home message for the mediocre surgeon? A surgeon who knows how to do lap chole, who can do the difficult chole, but should we ask him to abandon the procedure or should we ask him to continue? Because number one, the chances of getting gallbladder cancer in a difficult gallbladder is not that high as we think. It's 2 to 4%, number one. So why not to give take the advantage of completing the cholecystectomy and get the full section, full thickness frozen section biopsy or histopathological biopsy, HPR, full thickness HPR. So we come to know whether what is the T stage, because if it is T1A, you need not to proceed further. Whatever he has done or he or she has done is the complete procedure. So why to abandon the procedure if a person is definitely can do difficult cholecystectomy?
So,
because that is because cholecystectomy is now being done even at periphery. So we should be very clear in our thoughts, and we should give them clear message that when to abandon the procedure. So why to abandon the procedure when we get proper histopathological report post cholecystectomy?
Whatever evidence is available in such a case, doing a simple cholecystectomy is definitely not the complete surgery if the person has malignancy. So whatever less percentage we are erring on the side that we are not doing the complete justice to patient.
No, just one thing, because if it is T1A, whatever you have done, it's more than sufficient. And even if it is T greater than, see, if it is T3, T4, even the person will identify on the table and he may abandon.
Yes.
But
so
I am just talking of T1B and T2, in that whether you do single stage or
Yes.
whether you do two stage. The long-term data says that there is no difference.
Yes.
So why
So
we ask them to
so
abandon?
the middle approach, I was going to tell the second clause to that. So the middle approach is what Dr. Kapoor has proposed, that Lucknow approach. You go in a plane behind the usual plane. You take out 2 centimeter wedge of the liver in all the suspected cases, and then whether to do lymphadenectomy or not, you keep it at
second stage
after reviewing the report.
So
of
I think that take-home message
But
should be for
whatever
the
you
mediocre
have-
surgeon is that if you can complete the cholecystectomy, you do it and take 2 centimeter of the liver by dissection.
No.
Is it?
No. If there is any suspicion, you should not do a simple cholecystectomy as far as possible.
See, but the problem is most of the time it comes out to be chronic cholecystitis as biopsy.
Then we
Because,
are then we are giving benefit of doubt to the patient, but at least we are not erring on the opposite
And the
side.
second thing, the mediocre surgeon will never abandon the procedure. Because he has taken patient for cholecystectomy, he will do it because he feels that I can do it.
So these are that is the purpose of, I think, guidelines. And we have to make them aware that you should not do this and you should not, because there will be perforation, there will be spillage, all the further things and complications will be there, and we have to, if we abandon the procedure, not only doing the oncological resection, we avoid all these things also.
But then again, if you do it in private setup, how will you justify to the patient? Because suppose if you have abandoned the procedure and biopsy comes out to be benign, then you are asking patient to go for second surgery, and I tell you the second surgery for benign gallbladder, it will be more difficult.
But rather we cannot justify a patient doing an extended cholecystectomy, an extra procedure,
See,
when
but
there is
what
a
is the
malignancy
percentage?
without giving consent, without taking consent, and without explaining the patient.
I think, madam, we'll discuss it later on,
Yeah,
and
yeah,
I
please.
hope that the message has been conveyed to the
Because this is a very common procedure
presenter.
to be done at all centers, and the message should be very clear to everyone.
We can have a next question there from there, or comments I can say.
So, I think I've been trying to rock the boat since morning. If you find a mass lesion in the gallbladder in preoperative evaluation, you would suggest a complete staging.
Yes.
Right? Now, why should we change now?
Exactly.
In the sense, no, let me just complete the question. So, if you find a mass in the gallbladder, you have not staged this patient.
Yes.
And you want to do a radical surgery.
Yes.
Why not have a simple recommendation that if it is a mass in the gallbladder which is highly suspicious, abandon,
Yes.
stage the
I agree.
patients,
Yes.
and come back.
Yes.
So that is my first, that you are not stage the patient.
Yes.
We as surgeons always think that we can cure everything.
Yes.
So we say, oh, I'm there, let me just take it out and hopefully I'll cure this patient.
Yes. So that is the recommendation, that is the evidence what I can come out with the available literature. That is what I was trying to tell. The abandon the procedure is the best possible advice. If you can give, I mean, there are even situations where we get a call from a surgeon operating at a periphery, and this situation is there. This is the best possible advice we can give, that you have to abandon the procedure and come back.
So the second point, which I do a lot of, we encounter a lot of difficult cholecystectomies. And we recently reviewed our cholecystectomy out of about 300,000 plus cholecystectomies over the period of 8 or 9 years. There is one patient who had gallbladder cancer with us. And we do almost about 15% of subtotal cholecystectomies. Now, if for all thick-walled, difficult gallbladders, I start doing extended cholecystectomy, I mean, the burden of that would be too much, and the evidence is that I don't see that many gallbladder cancers. So, rather than saying that difficult cholecystectomy or thick-walled gallbladder, which is difficult to dissect in the callus or hepatocystic triangle, should have consideration for malignancy and do a more major procedure, sounds to me as overkill, at least in the place where I work. So, do these recommendations be guided by the region and the incidence that you have, or it is a universal recommendation?
Sir. So these are the recommendations available on the literature, available with the literature. There is a lot of literature from India also, but the guidelines as of now, whatever I have shown, are from the Western countries only. So we have to now, I think, propose guidelines and validate it for our setup. Yes.
That is taken from the Western, actually. That's taken from the NCCN.
So,
ICMR is the Indian guideline that also says whenever there is a suspicion, you have to stop.
Are we drawing a parallel between thick-walled gallbladders and difficult cholecystectomies? I don't think they are synonymous.
I also
Yeah,
don't think
so
so.
just simply stating that all difficult cholecystectomies are going to be thick-walled and there is a suspicion of malignancies doesn't cut it. I mean,
I agree.
acute calculus cholecystitis, a mucocele can be very difficult
Yes,
and can bring
definitely.
you to tears.
So that is why the entire thing was, which are the intraoperative parameters among the difficult cholecystectomies which will indicate the malignancy.
Yeah, Dr. Ajay Sharma.
Just, I think we are having a lot of overlap between the things. One is a suspected carcinoma gallbladder where you have a gallbladder mass. So there is no confusion about that. Second is you have a preoperative high suspicion of malignancy. That is second area. If you have a preoperative high suspicion, I think what Dr. Kapoor has already advocated, that anticipatory extended cholecystectomy works for that, where you still have a suspicion. Third, what Dr. Sadiq is saying is you have a difficult gallbladder. Not all difficult gallbladders have a high suspicion of malignancy.
Yes.
So that is a third area. You preoperative investigations have not shown any suspicion of malignancy. But this is still, when you go on and you find a difficult gallbladder, I think that gallbladder should be resected. You will have a stone spill, bile spill, you know it preoperatively when you are going in for the procedure, but since you don't have a suspicion of malignancy in this till now, you have to proceed. This is the area which is now still in gray zone, where we have to identify out of these patients which you identify on table which have a no suspicion of malignancy preoperatively but difficult intraoperatively.
Yes.
But
So we are
I don't think that there is a
focusing only
recommendation
on
that it should undergo
that
extended.
group of patients.
Actually, ma'am, the question is the same. The question is when to suspect. That is the
Yes,
first question you have
yes.
to address. But once you've gone in, because if you had a
Preoperative diagnosis,
you
then
wouldn't have
it is
gone. You would actually have
advised
staged
complete
it
stage.
and then went
Yes,
in.
yes.
So right now the question is, when you actually went in for a lab cholecystectomy,
Yes.
thinking that this was only a gallstone disease,
Yes.
or maybe some thickening, but not something which you were suspecting as a carcinoma.
Yes.
And then when intraoperatively when to suspect is the first question to address
Yes.
actually. What we are doing is we are giving like kind of thinking of recommendations before, like ahead of that. So that is the first thing that we
No,
have to
I
think.
have
What are the
excluded
criteria
what-
where we actually suspect that this is a patient, it is difficult, but this looks like a carcinoma and this looks like more like a xantho. Are there different things that we can follow, like age, endemicity, where you are working, everything? Like Sadiq sir said that he is doing only one gallbladder cancer. On the other hand, if it was done in North India, maybe close to Lucknow, probably there will be much more. Even sir's paper shows the numbers are slightly more than one patient in 3,000.
So all
that
these,
also
this review
takes
was
precedence.
excluding all these factors, excluding age, gender, age, preoperative diagnosis, preoperative imaging. You are just inside the operation theater, or just imagine you are
Then
you are
have to
getting a call.
revisit. So the thing is, then you have to revisit. You have to revisit back to your previous
Usually, but
symptomatology.
you will not have anything other
No.
than USG.
What I'm saying is, now you've gone in and you realize that it's a difficult gallbladder. Then you have to revisit each and everything that was there, even the symptomatology, his age, his region from where he's coming from, what he's suffering from, and probably the length of the symptoms that he had, even the ultrasound, have you missed something? Because each and every step will actually guide you to what exact management for that patient should be, and then take a call whether I go ahead with the surgery, which would be beneficial, or whether I abandon and send the patient for re-staging and re-procedure. That's what I think it is.
Ideally, I mean, in real situation, all that will be obviously taken into consideration and will be reviewed. But I'm not sure whether it will guide us for any change in treatment, or whether it will guide us to go in one or the other direction. Obviously, when we see difficulty in gallbladder, then we review the report, review the history and everything.
I think we can have a comment there from Dr. Kapoor.
So one clarification that the ISG GBC, we are not going to call them guidelines, because as I said earlier, we don't have much and we don't have strong evidence. So it will be difficult to call them guidelines. We will probably call them a clinical consensus statement. It will be for high incidence area like North India, but we have intentionally included experts from low incidence area to have another point of view. And if any exceptions will be made in the consensus statements for low incidence areas, they will be highlighted separately, that this doesn't apply to low incidence areas. So that is just a clarification. Now, coming back to a difficult, so ultrasound doesn't say difficult gallbladder. Ultrasound only says whether the gallbladder wall is normal or it is thickened. If it is thickened, and if it is a good ultrasound, the sonologist should, and that is the point we need to address to the radiologist, they should say whether it is a focal thickening or a diffuse thickening. Focal thickening in the gallbladder is to be treated like malignancy, at least in high incidence area. If it is diffuse thickening, in the absence of a recent episode of acute cholecystitis, it should be labeled as a thick-walled gallbladder, which again in high incidence area should be further investigated with cross-sectional imaging, CT or MR. Based on this, if there is still a high suspicion of malignancy, and I'm not going into those details, again it should be treated as malignancy, which means straight away an extended or radical cholecystectomy should be done. If you do 10 such cases, one may turn out to be benign, just simple chronic cholecystitis or xantho. For our colleagues from West, this entity of xanthogranulomatous cholecystitis is a manifestation of long-standing chronic inflammation of the gallbladder. It's a purely benign disease, but on imaging, at surgery, on the specimen, it looks exactly like gallbladder cancer. We all have seen XGC, xanthogranulomatous cholecystitis gallbladder, centimeters thick, not millimeters, centimeters thick, and final histology says no malignancy. Some of us feel that it is a step between chronic cholecystitis and malignancy, but not strong evidence. So based on imaging, if the suspicion is high, it should still be treated as malignancy, and 9 out of 10 times that extended cholecystectomy should turn out to be malignant. 1 out of 10 it may be benign, but that we feel is a small price to pay to at least do a proper procedure for the remaining 9 cases. If based on cross-sectional imaging in a thick-walled gallbladder, suspicion is low, then what we recommended is the procedure which we described. It was published many years ago. Now we are trying to modify that slightly based on experience in Jaipur, that we need not take 2 centimeter wedge, because there is nothing sacrosanct about 2 centimeter, because for an average, the question which Dr. Sumita asked, for an average, I won't say mediocre, but with average skill general surgeon, 2 centimeter wedge in liver may be difficult. So we are saying stay out of the cholecystic plate, take a small wedge of the liver so that you don't violate the oncological plane. Now in this situation, 9 out of 10 times the histology should show that it is benign. That should be the degree of differentiation for you. And only 1 out of 10 times it should be malignant. And in that 1 out of 10 cases, because you have stayed in the liver parenchyma, and because imaging did not show liver infiltration, because if imaging shows liver infiltration, it is GBC. It should be treated like GBC with a proper extended chole. So in 1 out of 10 case, by doing a simple cholecystectomy, you have not violated the oncological plane. I agree the point which Dr. Sadiq made, and Sadiq, you have to rock the boat, because for a clinical consensus, the boat has to be rocking. It cannot be that everybody says the same thing. The objection is valid that in 9 out of 10 cases, we are doing an unnecessary liver wedge resection, which has its own morbidity, number 1. And number 2, the point, whether a simple cholecystectomy followed by an extended chole as a second operation, does it decrease the outcome? That is the point which other groups will consider. So these are pros and cons which we have to keep in mind. No, so that is why the AEC is done in low suspicion cases. That means only 1 out of 10 is malignant. Yes, in that you can say that there could be a metastasis somewhere and you have done an extended cholecystectomy, yes. So these are points which are for and against, which the groups have to keep a note, and these points have to come in the final review articles.
Just a comment, most of the center doing anticipated extended cholecystectomy usually HPV centers, and most of the patient had preoperative suspicion and workup, adequate workup for the patient. On the basis of that, you decide whether suspicion of was high or suspicion is low. Accordingly, you perform. It is not right in every case. Patient is not workup. If patient is not workup, then we may follow what Dr. Sadiq sir says. We may abandon the procedure, and if a general surgeon is doing without HPV exposure, he may abandon the procedure, refer them. But if it is HPV this thing center and patient is already worked up, then we should proceed accordingly.
To answer once again Madam's question, I think we also come across a lot.
Just one more concern and then you just answer the question. Like per operative finding, you find a difficult gallbladder, you ask that recommendation is to abandon the procedure. Okay, fine. Suppose the person abandon the procedure, what type of histopathological report you will get before proceeding to the second surgery? Because ultimately it should be a full thickness frozen section biopsy, because in T1A, unnecessarily you will be doing extended coli. So ideally it should be full thickness biopsy, which is must, because otherwise you will be over treating some of the patients, right? In the especially in the patient where you have not suspected preoperatively.
So I will once again try to answer your previous question.
Yes.
For all difficult cholecystectomies. I agreed to you that we also come across with difficult cholecystectomy every day. But when just I gave a thought over it, in majority of the times in all those cases, we expect that gallbladder to be difficult. In such gallbladder, we even have a faculty member or somebody supervising the resident. So I mean 90 out of the 100 difficult gallbladders are also expected before posting the patient, considering preoperative acute cholecystitis, repeated attacks of and ERCP and all those things. So this is particularly when nothing has been expected to be there preoperatively, and this is an intraoperative surprise, and intraoperatively we find for that situation, these recommendations should be there, I think. And coming to our second question, if the guidelines say that if you suspect that it is GBC, then it should be considered as any other GBC suspected preoperatively. In that case, you don't do any biopsy for confirmation of the diagnosis in the preoperative setting. So here, also considering the same, no biopsy is required,
Then
unless you contemplate, unless you think of giving a neoadjuvant.
And then
or
if you
palliative.
do second surgeon, it comes out to be benign, right? Then it will be a very difficult situation. And I tell you, our center, we run 7 OT, we'll be doing almost 20 to 25 gallbladder cancer.
Overshooting the time. The
And
only
we
one
hardly
comment
find
I want
gallbladder
to make
cancer
is
that
this.
frequently.
I
in
want
this
to make a
center.
comment that if you are doing a gallbladder where ultrasound has not shown you anything, because it is the ultrasound which is the first investigation that we get done, and on basis of that we decide what is the difficulty or ease that we are going to face. So on doing a lab call, if you find a white patch on the gallbladder, that should be considered that probably it is going to be malignancy, and then you must think of proceeding accordingly. That is.
Yeah, I'm just going to introduce a new terminology, accidental cancer. T1A is 99.9% an accidental cancer. On an imaging, it is never picked up. So when we are talking of a suspected gallbladder cancer or identifying a gallbladder cancer, when we enter the abdomen or we open the specimen, it is not a T1A which we identify ever. It's always an accidental.
Three contradictory points, I think, which Dr. Kapoor has said. I would like to say, maybe some people may not agree to it. One is anticipatory extended cholecystectomy even with a smaller margin. It is for a general surgeon not an easy surgery. Going into the liver for a person who is doing it at the periphery. He may not have all that armamentarium, he may not have a harmonic, he may not have a ligature, he may not have a good hemolog clip applicator, so it is not an easy surgery, one thing. Second thing, a gallbladder wall thickness which is uniform versus non-uniform. I think sir has said in a non-uniform gallbladder wall thickness in a high incidence area may be considered as malignant. No, I think universally irregular wall thickness should be considered as malignant wherever it is. It is whatever is the place. Third thing, a uniform gallbladder wall thickness in a high incidence area, I think that needs further evaluation. If a uniform wall thickness is there in a low incidence area, suppose it is in south, then you may consider it to be chronic cholecystitis. But if it is in Ganges belt, I think you will need a CT, PET or whatever investigation is required.
Thank you. And before we summarize, we have one question for you. Okay. You have emphasized the importance of frozen section there in your presentation. What's the recommendation for a person, those who are operating there in the periphery, those who won't have a facility for frozen section, how exactly they should proceed?
So if you are contemplating an extended cholecystectomy, frozen section has to be there to decide whether to decide the cystic duct margin. So it is a mandatory thing in the oncological setting. So if it is not there, then definitely it is some compromise of available expertise, available infrastructure, and so you have to stop and not to do the things.
Means the surgery is not to be performed in a place where the frozen section is not available.
A curative surgery, extended cholecystectomy. As far as the diagnosis, tissue diagnosis is considered, then there is again a question of frozen section and full thickness biopsy. In that full thickness biopsy, transhepatic core needle biopsy is recommendable, as frozen thickness, frozen section will not give carcinoma in situ or information about depth of invasion.
I'm talking of a lesion which has been suspected by any person and he has done a cholecystectomy, whether he should do a extended cholecystectomy, how we are going to have a frozen section. Unless until someone perform a extended cholecystectomy, he is not going to have a frozen section biopsy.
Yes, so for cystic duct margins, you have to have a frozen section biopsy.
So even if you don't have a frozen section in your place, and if you are capable of doing a radical cholecystectomy, you can proceed with radical cholecystectomy. It is not necessary to have a cystic duct margin frozen in every radical chole. It's not a standard operating procedure.
Maybe in few lesions where the lesion is there at fundus, you may...
It is not in the standard of practice. In the standard of practice, the first step of radical chole is to go into the retroduodenum area, biopsy the aortocaval node, and submit that to frozen section. That is when you are doing a planned radical surgery. But if you are not doing a planned radical surgery, you are at a place, but if you are capable of converting a simple chole to radical chole, you should convert it into a radical chole.
I think we have a discussion and we should summarize now. I think you want to say something?
Good morning, Dr. Kao. Can you want to make any comments? Can you hear me?
Yeah, no. Yeah, I can. Can you hear me?
Yes, yes, we all can.
Great. Thank you, first of all, for the invitation and really, really wonderful discussion. I come to you with a vantage point of being in a country, of course, where the incidence of gallbladder cancer is not very high. But as Dr. Gamblin also mentioned, I work at MD Anderson where we get a lot of referrals for gallbladder cancer that are incidentally diagnosed. And, the first tenet of surgery in medicine is first do no harm. And there's no worse scenario that I encounter than somebody who goes to the operating room and had a potentially curable gallbladder cancer that gets turned into metastatic disease because of violation of the tumor. And we see that quite often, and those are not the patients that I can salvage. I would say even in a low incidence country like the US, my recommendation for the general surgeon in the US, and perhaps this doesn't apply to other countries where the resources are different, where the implications of not doing surgery right away are different, but if you're a general surgeon in the US doing a difficult gallbladder, that's one thing. But when you're encountering a lot of these signs that are more advanced, like you have duodenum really stuck to the gallbladder, or you're dissecting and you're seeing really this mass that, and believe it or not, sometimes people just chisel right through the mass, telling us that they thought it was just inflammation. And sure enough, they're dividing through cancer. To me, there's nothing wrong with the moment you suspect gallbladder cancer. First of all, if you have the findings that make you suspect that there's gallbladder cancer, it's probably advanced enough for you to stage it. So backing out to get cross-sectional imaging is a totally good thing to do. Number two, it allows you to check a CA19-9, which most likely you didn't draw before surgery. And if that CA19-9 is going to be high, especially with CT findings that are consistent with gallbladder cancer, then that allows you to take a different approach. Versus, if those investigations don't support a gallbladder cancer, you can always, at least, the very least, when you go back in, be prepared for what you found the first time. So to me, if you suspect a gallbladder cancer, at least in the United States, and you're worried enough about it, best to back out, stage it, get CA19-9, and if you don't have the ability or the knowledge or the expertise to deal with it, send it to a high volume center. I will tell you that in the United States, a lot of surgeons do not feel comfortable even doing an open cholecystectomy. And Dr. Gamblin, I'm sure, can also speak to that. Quite often we refer patients who had a difficult gallbladder cancer laparoscopically, and so they just abort and don't even do it just because they're not comfortable doing an open cholecystectomy. So all the more reasons to kind of really recognize your limitations, do a full investigation, and then get a definitive operation. I think it's much better to be planning ahead of time to do a radical cholecystectomy with goals to achieve negative margins, full no dissection and everything if you suspect it, rather than do something and potentially do a second stage radical in that kind of difficult situation. But again, I recognize that my experience and what I'm saying may not be applicable to other parts of the world.
Thank you, Dr. Sanderson, for concluding remark. Thank you, Dr. Kauri.
Thank you, Dr. Kao.
So we conclude that if the suspicious mass lesion is been detected during surgery, of course we should suspect that it is a carcinoma, although there is a controversy exactly if the thickened gallbladder is there, always there is a suspicion that it is a malignant one, and if you suspect it is a malignant, it should be, means the procedure should be aborted and must be referred to a higher center where the surgeon is capable of managing the case. Patient should be further evaluated, staged, and then one should do the laparotomy for doing an extended cholecystectomy. Of course, the gray area always remain there for the xantho and the merices because both of them, they mimic like a carcinoma, so it is very difficult to differentiate. Of course, if someone is comfortable, one should proceed, otherwise should abandon these patients and refer there to the higher center for the further management. What is important here is the intraoperative biopsy should not be done, and there should not be any bile spillage done. Someone is doing for the suspicious of a carcinoma. It's all because of the reason that it may lead to dissemination of the disease. Thank you.
Thank you. Thank you.
You want to add something, sir?
Thank you, faculties. For the next session, next question will be what to do if if a suspicion isn't found on GP. For this session, I would like to invite Chairperson Dr. Monica Gupta. She is a Senior Consultant Gastrosurgeon at Manipal Hospital, Jaipur, and Dr. Sanjay Singhal, Professor and Head Department of General Surgery, Mahatma Gandhi Hospital. I request Chairperson to invite for the presenter.
Yeah, for this session, I invite Dr. Jaya Agrawal, and the comments will be offered by Dr. Manoj Pandey.
Good afternoon to all. Greetings from Amrita Hospital, Faridabad. Most of my presentation has already been discussed in the previous sessions, but I would still like to emphasize on a few points and maybe add on a couple of points. My review question was what to do if a suspicious lesion is found in the gallbladder specimen. Lot of literature is available worldwide, and on reviewing the literature, one point is very clear, that incidental gallbladder cancer is a global problem and not just an Indian disease, and the incidence of which is increasing all over the world. Before I jump on to my topic, I would like to say what is a suspicious lesion in the gallbladder specimen. A mass lesion detected on ultrasound is a suspicious lesion in about 50% of the cases. In about 1/3 of the cases, polyp of size greater than 1 centimeter or focal or diffuse asymmetrical wall thickening would raise suspicion of malignancy. Another common suspicious lesion that we encounter is a porcelain gallbladder with wall calcifications. But why is it missed preoperatively is a question that is commonly asked. Some of this cancer is a flat type cancer in which tumors are not formed and not detected preoperatively. Also, couple of times we see cases in which the gallbladder is full of gallstones, which makes it difficult to observe the wall adequately preoperatively. Cholecystitis is another complication of the gallbladder, which induces thickening of the gallbladder wall and it is difficult to distinguish it from malignancy. So, what do we do if such a lesion is found in the gallbladder specimen? The first question to answer is, where is the surgery being performed? Whether that center is equipped with all the facilities, including a frozen section and a trained pathologist. And secondly, who is operating? Whether the surgeon has the capability and the experience of performing a radical surgery if needed. There are a lot of papers that focus on early referral to a tertiary center. Whenever there is high suspicion on table after seeing the gallbladder on the laparoscope, or if there's a high suspicion on table after opening the gallbladder and the surgeon is not prepared for a radical surgery, the patient should be closed, all the surgical findings should be appropriately documented, and the patient should be referred to a high volume tertiary center. The surgical details, besides the usual details that need to be mentioned, is the extraction port from which the gallbladder was taken out, whether an endo bag was used during the surgery, and whether there was any stone or bile spill intraoperatively. As a rule, all these studies suggest that gallbladder should be opened and examined on table by the operating surgeon before the incision is closed. It hardly takes a minute, but it goes in a long way to change the future management and the prognosis of the patient. Once a suspicion is there, the specimen should be subjected to frozen section. We should speak with the pathologist and ask further questions like whether there is malignancy or not, and if it is there, what is the depth of invasion as well as the location of the tumor. The cystic duct margin status, whether it is free or involved, also needs to be told on the frozen section. If the frozen section comes as positive for malignancy, the first and foremost thing is to discuss the same with the relatives, and an informed consent needs to be taken for further treatment. If the family agrees and the surgeon is prepared for radical surgery, it should be proceeded based on the stage of tumor and involvement of the cystic duct. This is the Japanese classification where they classify macroscopically gallbladder cancer. Early gallbladder cancer has been divided into three main types, which is protruding, depressed, and superficial types. Advanced gallbladder cancer, which rarely is detected on a frozen section, is defined into three main types, which is papillary, nodular, and flat type. The ICMR consensus document for management of gallbladder cancer suggests it's the pathological T stage that is important for further surgical point of view. If it's only a T1A cancer, simple cholecystectomy should suffice provided that the cystic duct margin is negative. T1B and beyond warrants an extended cholecystectomy because there is a high chance of residual disease as well as a high chance of possibility of recurrence. Various studies have come up that tell us about utility and limitations of intraoperative frozen section, and this latest study from Tata Group shows the sensitivity of the frozen section to be as high as 88%, specificity of 99% with a diagnostic accuracy of 95%. There could be situations where the frozen section is false negative and the final histopathology comes as positive, although rare. If we discuss the algorithmic approaches based on intraoperative suspicion of gallbladder cancer, there is a divide between West and East. The Western studies show that if there is a planned cholecystectomy with suspicious findings, abandon the procedure, stage the disease, and with an urgent referral to a specialist. However, the definite treatment has to occur within 2 weeks after a multidisciplinary team meeting. There is an Indian study that tells about the algorithmic approaches of incidentally detected gallbladder cancer. This is the algorithm where they say if there is a suspect GBC in difficult cholecystectomy, if the surgeon does not have expertise, first thing is to convert to open cholecystectomy, cut open the specimen, the suspicious part needs to be subjected to frozen section. If it is resectable, the surgeon is trained and prepared for radical surgery, it warrants a radical cholecystectomy. Otherwise, close and refer the patient to a center doing radical cholecystectomy with detailed operative findings. So I would like to conclude by saying that early referral, clear documentation of all surgical findings, a proper frozen section by a trained pathologist, early definitive treatment once malignancy is detected clearly determines the further management and prognosis of patient. Before I end, I would like to discuss a case whom we had operated yesterday. He was a 65-year-old male patient from Jammu, recurrent right abdominal pain. Preoperative ultrasound showed a single large stone, no gallbladder wall thickening, no other evidence suggestive of malignancy. We took him up for laparoscopic cholecystectomy. The surgery was not a difficult one. We take out the gallbladder in an endo bag from the epigastric port. On opening the specimen, fundic region had a thickening. We subjected the gallbladder to a frozen section, and to our surprise, or not to our surprise, it came out to be a xanthogranulomatous cholecystitis, which is a common mimicker of malignancy. With that, I would like to say I'm thankful to Dr. Kapoor sir for inviting me for the conference.
Thank you, Dr. Jaya, for elaborate. Main conclusions which I take from your presentation is that if a suspected lesion is found in the biopsy, in grossing in the theater, first and foremost important which we learn from the today's discussion is that it should be inspected by the chief surgeon, because the assistant is closing the wounds.
Yes.
So the chief surgeon should go to the table and open it and examine it, preferably palpate it.
Yes.
And if there is suspicion, there can be a variety of causes. Like it can be a thick walled xantho, it can be a malignant lesion, small lesion, because it's not a pre-operatively diagnosed lesion.
Yes.
So that has a main emphasis on the intraoperatively diagnosed, which can be missed if we don't open the specimen.
Yes.
So to avoid it being a missed CAGB, we need to open the specimen and see it and get
On
frozen.
tape,
The frozen rates you have quoted here with the literature proof is quite high. Probably they had a very good imaging system and they have suspected very borderline lesions which are close to the malignant ones. That's why the 88% of the frozen positivity is there. So that's quite high in my view. I think 70-75% is.
There was a question asked previously, suppose if we don't have a frozen section, then I would personally recommend that the specimen along with the patient should be referred to a tertiary center where the facility to look at the gallbladder is there and the family should be adequately informed about the same.
Yeah, that's an important issue, that information and consent. Dr. Manoj, I'd like to invite comments from Dr. Manoj Pandey.
Yes, sir.
Very good afternoon, everybody, and thank you, Dr. Kapoor, for inviting me here. It has been a wonderful day since morning. There had been a lot of stimulating discussions, and I'm going to shake the pot a little bit more with more controversies. Being a surgical oncologist, my job is to deal with suspicious lesions most of the time. But then the difference is that these lesions are suspicious when they come to us, they are staged, they are investigated fully, and they are operated as suspected gallbladder cancers. So before doing the surgery, we never know they are gallbladder cancers, because we now as a routine do not take a biopsy or a cytology in a suspected gallbladder cancer. So they straight away go for surgery. So most of them are suspected. But what I'm going to talk about, or the job given to me, is to talk about suspected lesions of the gallbladder which are found at the time of opening of the gallbladder specimen. So now all of us would agree that this is something which should not happen. In an ideal situation, in a utopian world, 100% of these lesions should have been identified preoperatively by imaging, but it doesn't happen. It doesn't happen because most of the time gallbladder disease is worked up by only an ultrasound of the abdomen. And many of these ultrasonologists are just trained ultrasonologists. They may not even have an MD degree. Ultrasonology is something which people can do in 3 months' time, learn it, get a certificate, and start performing it. And for some of the findings, specifically lymph nodes, etc., the ultrasound has a very low specificity. So some of the findings may not be picked up in ultrasound even in the best hands. So we have to remember that ultrasound is good when it comes to picking up the gallbladder anomalies, the stone, the thickness, the infiltration, liver infiltration, the liver metastasis. It's a very good. It's almost as good as CT scan. But when we are talking about anything beyond, the ultrasound is something which will miss the findings. But this is how the system is, and this is how most of the cholecystectomies are done. The false negativity rate of ultrasound is about 10%. And this 10% figure is the 10% of the suspicious gallbladder cancer, 1% of which will become incidental gallbladder cancer ultimately. So what we are going to talk about is 10% which are false negative on ultrasound most of the time. Cytology and biopsy people have added, it improves, but then that is also not a gold standard. So this is our own studies. We have published 4 studies on imaging, and you will see that despite the best imaging with MRI, CT and ultrasound, your sensitivity for some of the features is very low, especially when it comes to lymph nodes, especially when it comes to carcinomatosis peritoni. These are the 2 things, and some of the stations of lymph nodes are very rarely picked up on ultrasound imaging examinations, and that is why I'm saying that there is a 10% false negative rate, which actually leads to what we call as suspected gallbladder cancer at the time of surgery. We have published our findings where we had clinico-pathological or surgical pathological correlations. We have compared our findings of preoperative imaging with postoperative histology. And here also you will see that though most of the time the accuracy of ultrasound is very good, but then there are certain areas like infiltration of porta hepatis, infiltration of common hepatic bile duct, partial infiltration, partial obstructions, the pancreaticoduodenal nodes, the carcinomatosis peritoni, where again the best of the imaging fails. And these false negative rates ultimately leads to suspected gallbladder cancer. So my first question is that should abdomen be explored before all cholecystectomies? That means most of us are doing 20, 25, 30 cholecystectomies in a day. Our operating time is 10 to 15 minutes. And we just go in, do the cholecystectomy and come out. So the first question that I'm going to throw at the house is to think, should there be a minimal that we should do before we start the procedure of cholecystectomy? Should we inspect something before we start, or what is the ideal, or we should keep doing what we are doing?
I would like to comment first. The question doesn't stand valid if we don't investigate patient preoperatively. Like the exploration stands valid only when we have done all the tests required for a suspected or a doubtful case or a thick-walled case, right? So that's what I want to say. So exploration by laparoscopy is not justified because CT scan has a very good sensitivity and specificity. If we have a thick-walled or a doubtful case like some mucosal mass is there, ultrasound done outside, which you have mentioned, should be repeated at your own center. That's what we do. Like if it has been done 1 month back, I'll repeat it. If it has been done outside, but the report is not very elaborate about the wall thickness and CVD, we will try to repeat it. There, as you have quoted, 10% of the missing rate is good. But when they have written a thick wall, because like 1 or 2 to 3 in 10 cases, we get thick wall gallbladder. where we suspect preoperatively, and we get the CT and CA99 done as a screening tool for the patient. So there, the chance of doing this exploration goes off for us.
Ma'am, that might be a personal opinion, but then the question was to house that most of the time when a cholecystectomy is being done for a suspected gallstone, it is done on the basis of ultrasound alone.
Yeah.
So in that case, should the surgeon put his laparoscope and see something or a minimal something before he starts hooking up the gallbladder and performing the surgery? Because all it's going to take is another few minutes. So that is one question that I want to throw, that should it be done? Or should it be done for all cholecystectomies, or it should be done for some of the cholecystectomies? When it should be done? What is ideal and what is minimal? What can be done? So I know that most of these surgeries we just go in, put it and do come out. I was trained under a surgeon who used to do cholecystectomy in 9 minutes, skin to skin, open. So when we are doing cholecystectomies like this, we are doing 30, 40 cholecystectomies in a day. What are the chances? Our chances of missing something is much higher than we give it time and do it. So the question here is, can we just give it a few more minutes, look at porta hepatis, look at liver, look at some of the lymph nodes, the omentum, and we may not. That's a different thing.
We do that. Screen the abdomen.
Exactly. Exactly. So that is one thing that we can do. And my second question to the House for the discussion would be, should all gallbladder specimens should be opened at operating table? Now, we are talking of high incidence, from the high incidence areas. If we look at 1,000 cholecystectomies, the general rule of thumb of 10%, about 100 will be having abnormalities or gallbladder thickening, and 10% of that is 1 out of 1,000 will turn out to be malignant, even in high endemic areas. So the question is, when we ask that we are suspecting gallbladder cancer and we are asking everybody to open the gallbladder specimen, so should we open all gallbladder specimen and inspect it? That is second. Or when to suspect. So what in a gallbladder can tell us that this is the gallbladder I should open, this is the gallbladder I should not open. Because it is not possible to open 1,000 gallbladders to find a single gallbladder cancers. If we have to open the specimen, we have to be very meticulous in opening it. As I said, one of the things that can point to is the outer surface of the gallbladder. We can look at the color of the serosa, if it is pink or it is darkish or it is brownish. We can feel a mass or a thickness. If we feel a mass or thickness, definitely yes, it's an indication to open the gallbladder. And if you feel a floating stone, probably it is a uniform normal gallbladder, thin-walled gallbladder, what we call as a lollipop. You probably need not open it. But when it is to be opened, it has to be opened from bile duct to fundus. This is most important because you don't want to spoil the grossings and margins for your pathologist. So the cut has to be made as per the grossing rules of the gallbladder, and it has to be from the biliary duct to the fundus. And then you have to ink the biliary duct even if you don't find anything. So that is one thing that we need to do. We can examine the mucosal colors, mucosal surface for its color again. Smoothness, mass, lumen, you can see bile, we can see granularity or stone. Polyp and tumors, whether they are sessile or they are flat. Thickness of the wall can be seen. The cystic duct can be examined. The neck can be examined. The lymph node, if it is there, it can be examined. And if a mass is identified, which I said is going to be in 10% of the cases where you open, 10% of them will either have a thick wall or a mass. So from 1,000 you come down to 100. In those 100, you have to measure the dimensions of the mass, note the site, and then you have to ink the mucosa and the serosa and you have to ink the cut end of the cystic duct. As I'm coming from surgical oncologist, if the surgeon is capable of performing an extended or a radical cholecystectomy, in a suspected mass, it is always better to perform the extended procedure whenever possible. If the surgeon is not capable, or if the place where he is operating doesn't have the facility, he should close and come out. But by that time, you must remember that in our situation where we are dealing, a cholecystectomy, simple cholecystectomy has already been done. And if it turns out to be malignant later, the planes have already been violated. So it is always better in this situation, if you have the facility and if you have the capabilities, convert it into a radical surgery whenever possible. If you have the facility for frozen section, you can send it for frozen section. If it is positive, then again you should convert to radical cholecystectomies. Now I'm just going to present in small and a brief some of the data of there are very few series, about 1,000 cases where people have opened the specimen, suspected the carcinomas, and they have proceeded into the radical cholecystectomies, converting their simple chole to radical cholecystectomy. About 1,000 patient data, some 3 or 4 series, most of them retrospective. So the best evidence we have is a level 3 evidence here. 10 to 15% have carcinomas. The 10 to 15% rate varies from low incidence to high incidence area. The high incidence area, it's about 15%. And 40%, about 80% of these lesions are either T2 or T3 when they're identified. That's what I was telling, that T1A lesions are usually not identified on mucosal examination by naked eye, especially T1A. They are most of the time found on frozen section examinations, and they are not usually visualized by naked eye, because mucosal only disease is very difficult to pick up, or sometimes otherwise. And 10% of them will have PT4. Now this PT4 is something very dicey. Xanthogranulomatoous cholecystitis, wherever is present, mimics carcinoma, and most of the time these T4s would be coming out either as a malignancy or as a xantho. So either of the two. Morbidity by converting into radical comes to 10 to 15%, and this 10 to 15% includes conversion to open. And 5-year survival, if these cases are converted, irrespective of stage, is about 60%. Thank you.
दो नंबर
Espirodalis, director of the HPV unit, Costa Hospital, Grace. It's my honor to present the international global cancer. One particular relevant piece of information from the index surgery.
सीधा करो सर, सीधा कर दूँ?
Espirodalis, director of the HPV unit, Costa Hospital, Grace. is the cystic lymph node. The cystic lymph node biopsy in the positivity may helps and assists with the decision making in this incidental gallbladder cancer treatment. The lymphatics of the gallbladder are classed into 3 echelons according to their proximity to lymph nodes. The cystic lymph nodes and the perichoidal lymph nodes are the first echelon. The second echelons are the rest of lymph nodes like celiac, paraortic lymph nodes, SMA lymph nodes, etc. Including perichoidal node sampling may be technically challenging and could lead to increased morbidity. Hence, it's suggested that both nodes or none be considered from an oncosurgical perspective. The central lymph node is the first node expected to receive lymph flow from an affected organ. It's a crucial concept in oncologic surgery. However, it's not very useful in the gallbladder cancer due to the skip lesions and lymph node metastasis that may be presented. From an oncosurgical viewpoint, in incidental gallbladder cancer, the status of the cystic lymph node, which may or may not have been harvested a specimen of index cholecystectomy, in dictating further treatment options is equivocal. Many other variables are far more crucial and of momentous gravity than the metastatic status of the cystic lymph node. Thus, a case cannot be made to include this anatomical entity in each cholecystectomy specimen from the standpoint of IGBC. It, however, enjoys additional importance in contributing to safety in technical conduct of cholecystectomy, avoidance of CBD injury, for which its inclusion in the specimen excised may be worth a while.
So, any questions or comments from the house?
Again, I think all the young faculty members who are going to be the first authors or the co-authors, please make sure that we consider these scenarios as we have mentioned in the program. One is pre-operative suspicion, second is intraoperative suspicion, third is suspicion on the specimen once cholecystectomy has already been done, and then the incidental. So all these steps will have to be mentioned separately in the respective review articles.
Jaya, will you touch upon the points of how to, I mean, in specimen, can we make out a bit about xantho versus mass we can make out actually, but xantho versus adenomyosis, are there any findings you can suggest on the gross?
Grossing, ma'am, it will be difficult mainly if it is related to the area where the stone is stuck. If it's a big stone and there is a thickening that is located next to it. But it would be very difficult to say only on macroscopic examination that whether it is xantho or a gallbladder cancer, especially from a high endemic area.
And what about that frozen? Is the frozen always performance ready in your centers? Because in our center we need to inform them prior.
Right now, if there is a suspicion, if a difficult cholecystectomy is there, we would also inform 1 day prior. But if there is, then we have a 24-hour on-call. That may not be the situation everywhere. So that needs to be discussed amongst especially peripheral centers. So if we are proceeding or any decision needs to be taken, it has to be in a center which is a high volume center. Best, as everybody was saying, is to abandon and send the patient to a place who can deal with such situations rather than managing it at a center who is not equipped with the same.
How big tissue you require? You require full gallbladder or you require a part of it? For
We send the whole gallbladder.
Whole gallbladder.
Yes.
Always.
There's
always,
one
right.
more point where
Because
frozen is not available, because previously we also did not have frozen. So we suggested crush cytology sort of thing. Our pathologist suggested it. And I think when it was negative in 2 cases we did, and final biopsy was also negative. So I take it as a bit reliable, although percentage wise sensitivity specificity I don't know. So that is also one of the options. They make an imprint on the slide and check it for the, if you don't have any options.
Can I take that question? Now, that is one is a crush cytology and imprint cytology. I think that is quite effective. But normally frozen is the recommendation. It is not the imprint cytology. Second thing regarding Dr. Manoj's question, that opening the gallbladder, I think irrespective of what, how, which patient, where you are doing, opening the gallbladder should be made a rule on table. Almost all the gallbladder should be open. Third thing, the frozen section you mentioned, there is very often you may get a negative report that it's not frozen and positive, and subsequently you may get a positive report.
Yes.
Most common reason which I have found over these years is that the surgeon not marking the suspicious site and the pathologist specimen being cut by a technician, and by the time the chief pathologist comes, that comes as negative. So I think that is the reason why frozen comes to be negative. Second thing regarding radical cholecystectomy, trained surgeon versus a untrained surgeon. Doing a liver resection is one section of that, getting a trained surgeon. Getting a lymph nodal good clearance is a second level of training, trained surgeon. Doing a biliary reconstruction is third level of trained surgeon. And then doing, if it is required, a portal venous reconstruction is a fourth level of trained surgeon. So most of the surgeons may not be trained at all the levels, but most of them will be trained at the extended cholecystectomy, meaning to say liver resection level, meaning a 2 centimeter margin level.
Jaya, what do you do in the scenario where you are suspecting it to be a gallbladder cancer but frozen is negative?
If frozen is negative, then
you are suspecting it to be a strong case of gallbladder cancer. Then what do you do? Should you proceed?
So
should you
why
proceed for extended poly, or should you
give a
abandon
case
this?
scenario, ma'am? Like, why are we having a strong suspicion of gallbladder cancer? Like, is there a mass or a polyp?
No, parop. Suppose if you have suspected it to
If
be
frozen is negative,
and then frozen is negative. What do you do?
Sometimes, ma'am, what ma'am is saying, sometimes impacted large stone with some cholecystoduodenal or cholecystocolic fistula gives an impression of it being a malignant, and that's a fair conclusion that it can be malignant. And another thing is xantho, where it can be like looking like a malignant.
if frozen is negative, then we would counsel the family that we'll wait for the final biopsy and based on that we'll stage and then proceed. Frozen is negative, we will not proceed with extended cholecystectomy in the same sitting.
And intra-op consent is very important. Like this is a very crucial part in our private practice, because sometimes pre-operatively we have thick walled gallbladder. Ultrasound and CT suggests chronic cholecystitis, but a small trace of doubt is there in your mind. So there you need to counsel them properly, pre-operatively as well as intraoperatively. Mostly intraoperatively they will say that perform cholecystectomy right now and we will deal it with later. This is what like the result of fair consent, which I know. Like if the patient is told about it, they will say perform the cholecystectomy right now and then later. So that is the main issue with the extension of the procedure.
Yes, ma'am.
So thank you all.
Maybe.
Thank you, respected faculties. I would like to invite you for lunch. And after lunch, we'll start next session at 2 o'clock sharp. Thank you.
आपका भी दीजिए। देखेंगे बाद में, देखेंगे एक मिनट चेक करने में। Give me.
Good afternoon all. I invite Dr. Prasannaji for the next session, and it's on should all the gallbladders removed for gallstone be sent for the histopathological examination and histopathology of gallbladder. Dr. Prasannaji, he is a professor in pathology at AIIMS Delhi.
Presentation, please. So, good afternoon everyone, and welcome back after the lunch. And at the outset, I just want to say thanks to Professor Kapoor and his team for inviting us. And I think this is a burning topic, as we are discussing from the morning. What should be done, how to suspect the tumors, and what is the importance of histology. And these are the questions I am going to cover. There are 4 sub-questions. The question 1 would be, should all gallbladders removed for gallstones be sent for histopathological examination? My answer is yes, all cholecystectomies performed for gallstones should undergo histological examination to rule out incidental gallbladder carcinomas, and here are the evidences. All these discussions I am hearing since the morning, possibly highlighting one of the fact that the Dutch group, they did a very nice study, and they said selective histological examination is sufficient for gallbladder examination. And they said because incidental gallbladder carcinoma incidence is very low, hence is it justifiable to do histopathological examination in all cases of gallbladder, and even if there is a TIS or T1A lesion, a simple cholecystectomy should be sufficient, and up to 10-15% of all histological macroscopically atypical gallbladders show microscopic abnormalities. But there are other aspects. If you don't do histological examinations, because as we are discussing from the morning, what are the challenges the surgeons on table and preclinical level they face to identify which one is gallbladder carcinoma. So are we leaving the patient to assumptions? And please remember, not all IAS or T1A tumors have gross changes, because of the simple fact that now we know very clearly that gallbladder carcinoma has 2 different pathological origin. One is from the papillary dysplasia, which is we call as ICPN, and other is flat dysplasia, which call built-in. Hence, all august gathering in this hall can say which one of them perineoplastic lesion will show you macroscopical abnormality in the gallbladder wall. Hence, it will be an assumption to see, to think that this patient will not have a perineoplastic lesion or an early invasive gallbladder cancer. And see at this Malaysian study, they showed that T1B and even in T2 in invasive gallbladder carcinomas, they did not have any documented macroscopic abnormalities. Bosch et al. Did a very large study, nearly about 7,000 cholecystectomies, and these proportions of neoplastic and invasive gallbladder are in sync with others. And see, this is most important, in only 0.5% of these neoplastic and perineoplastic lesions, they could identify macroscopic abnormality during naked eye examination in the operative theater. Renzo et al., they examined 16,000 gallbladder dissections, and they identified nearly about 9 high-grade dysplasias, but there was not a single case which showed gross abnormalities of the gallbladder mucosa. We know there are many studies has been done from the Chile, and ROA group is one of them. And in their 2 separate studies, they also said they could not identify any macroscopic abnormality or naked eye examination in about 30 to 60% cases of invasive gallbladder carcinomas respectively. Hence, not recommending the histopathological examination will be non-diagnosis we are offering to the patient in up to 30 to 60% cases. Hence, there will be deprivation of the re-resection and other oncosurgical excision. This is a simple example how the selective histological examination protocol failed. The Dutch group make nationwide protocols and they said this should be followed in all hospitals in this country, the selective histological approach. However, it was found in 2021, only 47% of all hospitals in the Netherlands, they followed the protocol. Hence, this shows that there is a question even among the surgeons, and all gallbladders should be examined. I'm hearing a lot of assumptions and assertions about the frozen section examination during the gallbladder surgery, and frozen section is a very good modality. But please remember, not in all cases frozen section interpretation is very easy because of high inflammation, fibrosis in the gallbladder wall, and it will be very difficult to identify in TIS or T1A lesions in frozen section especially. And most of the literature what you see about the sensitivity and specificity, those are from the tertiary care centers, and they often don't mention about the early stage gallbladder carcinoma which was identified on the frozen section examination. There is another fact, we all know that there is a marked difference in the survival described from the European countries, which is 5-year survival of about 30% versus 10-year survival of about 90% from the Chile. And this was primarily because of the sampling and histopathological examination and further management course of the gallbladder. Hence, in all countries with a high prevalence of gallbladder carcinoma, histological examination of all resected gallbladder for the gallbladder stone is must. My second question was, should the cystic duct be marked in all gallbladder specimens sent for histopathology? My answer is yes, cystic pedicle margin should be marked in gallbladder specimen, because we all know a positive cystic duct margin not only increase the PNI, LVI, and when the cystic duct margin is involved, the CBD involvement chance is almost, it is around 40% versus when the cystic duct is free, it is about 4%. But what is the state? There is not many studies which are available who have done this kind of survey, but the Dutch group survey says that when they evaluated their nationwide reports and found that cystic duct margin status was mentioned only about in 77% of the tumor, and the distance from the tumor and cystic duct margin was mentioned only in about 10% cases. Hence, somewhere we are failing, and pathologists are not mentioning or sampling the cystic duct margin status. Why? Either they are not aware, or they are grossly disfigured and calcified, and as someone mentioned, all gallbladders must be open in the OT, and that should be a protocol. That also make us our job difficult, which one is actually the actual cystic duct margins. Hence, it is important when you are opening a gallbladder in the operation theater, you should mark with a water resistant dye or put a suture mark so that the pathologists know this is the margin I have to sample and put in face. My last two questions are three sections from the fundus, body and neck of the gallbladder are enough for histological examination? If no, should a complete histopathological mapping of the gallbladder be done in every case of gallbladder carcinoma? The answer, first one, is yes, but there is a modification. How we are taking these three samples from three vital areas of the gallbladder, it should be continuous longitudinal sections including the fundus, body and neck of gallbladder, plus the in-face sampling of the cystic duct as we discussed, and this should be enough when the gallbladder is macroscopically normal. However, if you have identified something at the OT, opened up the gallbladder, there is a macroscopic additional lesion, then this 3+1 protocol along with all those areas where there is thickening, asymmetrical thickening or small bump in the mucosa, those should be additionally sampled. We know this evidence that if we if we do only macroscopically guided histological sampling, possibly we are missing 70% of the TIS or T1 means early stage gallbladder carcinoma, and up to 1/3 of T2 lesions or above even will miss if we not do histology in all. But what is sufficient sample? I will quote this beautiful study by the Duet et al. They compared three protocols. The first one, they took one sample from the fundus of the gallbladder. Next one, they took one longitudinal section and divided into three-part fundus, body and neck. In addition, they took cystic duct margin, and they also compared the sample, the whole gallbladder, and mapped the whole gallbladder. and they found that if we are only taking 3+1 sampling method, then also we may be missing 65% of the neoplastic lesions in comparison to the whole gallbladder mucosa sampling, that is the gold standard, and when only one random sampling technique is followed, then possibly we are missing 85% of the neoplastic and pre-neoplastic lesions. There is another nice study by the Argon et al. They also compared if the metaplastic changes, dysplasia and incidental gallbladder carcinoma differ in these two protocols. One is longitudinal sectioning, including the whole gallbladder mucosa, and 3 random sectioning, and they found that all these changes are much more in the cases where one longitudinal strip was taken and divided into 3 parts. This simply says that we are covering more mucosal volume, then we will be identifying the neoplastic lesions more. Because we should know that while it has been seen in this kind of study where the whole gallbladder mucosa was mapped and sampled, the metaplasia is usually in average involved 25% of the gallbladder mucosa, hyperplasia similarly, and when the dysplasia and invasive carcinoma occurs, then their area of involvement is very limited. Hence, more the number of sample or strips we are taking, we will be identifying more neoplasia. But the question is, what should be the responsible sampling, and if we can follow a step sampling method. There is one study which showed that one longitudinal sectioning protocol of the gallbladder, what we already discussed, was identified in the initial sections. But in this also, though the neoplastic lesions were identified, after taking more sample in the second step procedure, they identified that the deepest part of the gallbladder carcinoma, or for the staging purpose, there was some discrepancy when they only relied on this one longitudinal sectioning protocol. And Renshaw et al., already I have mentioned, they studied 6,000 cholecystectomies. They identified 106 atypical mucosal lesions in the initial random sampling. Then they took 4 additional mucosal samples, and they found that in them they could further identify 16 low-grade dysplasias and 9 high-grade dysplasias. There was, from these studies or from these publications, the people take a cue, and they published a protocol in 2005. That current protocol strongly recommends that the whole residual gallbladder mucosal mapping when a high-grade dysplasia or polypoidal dysplasia is identified. However, the Bosch et al. In subsequent studies found that though they have taken initial 6 to 8 additional sectioning after identifying high-grade and low-grade dysplasia, only they could identify incidental gallbladder carcinoma in 10% of the cases which showed high-grade dysplasia, and there was no invasive carcinoma in case of low-grade dysplasia. There was another study who also, after taking additional sectioning, could not identify no further difference in the dysplastic lesions or invasive carcinoma. Reyes et al. Also, this is the group from the Chile. They also took additional section, as well as they took sampled some entire mapping of the gallbladder, and they also found no additional lesions in their gallbladder. Hence, it is clear rationalization is needed. Hence, my last slide is like that. If macroscopically normal gallbladder you have sent from the OT, 3 continuous longitudinal section like this should be sufficient, including the cystic duct margin. However, if there is a macroscopically abnormal gallbladder lesion or gallbladder, then 3+1 additional sections as per the macroscopical abnormal areas must be taken. When high-grade biliary intraepithelial lesion identified, then additional 6 sections and we can just put 3 longitudinal sections in one block, so it will add only 2 blocks to our workload. That is not very high, and if there is no further lesion identified, then in a high incidence area further whole gallbladder mucosal mapping can be done, but it should be at part discretion of the institutional protocol or the pathologist. If the gallbladder showing intestinal metaplasia or low-grade dysplasia, additional 6 section must be taken to see if there is any high-grade dysplasia or incidental gallbladder carcinoma. If there is no further lesion, no further action should be done. Gallbladder showing incidental gallbladder carcinoma on the initial section, 6 further sections must be taken. This is for accurate staging and identifying the deepest part of the tumor. And if there is polypoidal dysplasia, the whole polyp must be examined, and additional 6 sections from the adjacent area should be taken to see if there is any other additional mucosal lesion into the adjacent area. So with that, I will leave it to the comment, and thank you so much for inviting me.
Thank you, sir. Now I am calling for the comments. Dr. Isidora Di Cario from the Italy and Dr. Pooja Sakuja.
All is perfect. Ladies and gentlemen, thank you very much for your kind invitation. First of all, let me to apologize. I'm Italian, so I do not speak well English, your language, so I hope you will understand. First of all, I would like to thank Professor that invited me. That is, for me, a great honor to be there. It's my 5th time in India. It's a fantastic country, and I visited several cities, but it's the most important historical city, in my opinion. So it gives me this opportunity to talk about if we have to do examination or histopathology after cholecystectomy or not. So as you see from this image, India and Chile are the most important, impressive country in which this has become a problem, and especially in Northeast India, this is a great problem that you have to examine it day by day. So what is the risk factor for the gallbladder? Why we have to ask to ourselves if we have to do examination by histopathology or not? So gallstone disease is the first, so the age. But remember that a gallbladder cancer in young girl have been reported in the literature. We have tuberculosis, especially in some country like Asia, become a problem. And of course, female sex due to hormones. Everybody knows this. But last we have obesity that become a great problem, especially in Europe and United States. And is a factor that is not depending from the other factors, so have to be analyzed very well. After we have other factors, especially in Asia, there's a common aflatoxin, for example. Probably the majority of you do not know that the country that produces pistachio in the world is Afghanistan, and the majority of pistachio in Afghanistan is affected by aflatoxin, and this is a big problem. We eat pistachio, we don't know, and we have this problem with us. How to do the examination when we have this problem? So all this possibility, we can use whatever you like, whatever you want, whatever you have in your hospital. You can do also biopsy by a fine needle aspiration in presence of mass, or you can drain fluid if in case in which you have some cholecystostomy. This happens. But sometimes the examination, as you said this morning, is by self-surgeon examination. I think has to be avoided, because sometimes if you have a TA or TB tumor, you are not able to do right diagnosis. So also if you have wall thickening, mucosal ulceration, and all the factors, it's much better to send it to pathologist to do the correct examination. It's very difficult pre-operative to do diagnosis. So because if you have a cholecystitis, it becomes very, very difficult. This is our study that have been published on junior emergency surgery. In case of cholecystitis, we do a subtotal cholecystectomy. We have 4 types, and we can apply what is the best for us. This is translated also for cancer. But when you have a cancer and you leave the infundibulum on the body of the patient, you have the risk to leave also the cancer. So for this reason, I have a new technique that I have to show today, and as the following, right, is commented. Can you put it there? Sorry, there is just a little bit patience because I have to put the. Is here, is here, is here. Yeah. Right. Look at the volume, please.
The gallbladder is completely covered by the greater omentum. The dissection gently begin in order to identify the fundus of the gallbladder. When the gallbladder can lift it up, the greater omentum can be detached from the anterior wall. The inflamed wall of the gallbladder is incised by electrocautery into a safe boundary between the body and the neck of the gallbladder. Then the inflamed external layer is separated from the inner layer and the gallbladder is moved upwards, leaving the inflamed external wall down. Gently and carefully the gallbladder is raised more and more, until the confluence of the cystic duct into the gallbladder is clearly identified without any doubt. This maneuver is of the utmost importance. Then the cystic duct can be clipped and sectioned. The cholecystectomy is completed as usual, leaving the inflamed layer attached to the liver bed, which is subsequently electrocauterized. Extraction of the gallbladder, cleaning of the cavity and positioning of a suction drainage is done.
Right. This has been a procedure
The
that.
gallbladder is.
Sorry, this is a procedure that I pointed out for inflammation of the gallbladder, as you understand. But this can use it also for cancer because it permits to avoid the total cholecystectomy. In the opposite, you have to do subtotal cholecystectomy in a part of gallbladder remain in the abdomen. So just to think what we can do if it's useful for us or not. So continue my exposure. We have a survival if do early diagnosis, but to do early diagnosis, we have to have all gallbladder, of course. And if you analyze histopathology, yes or not, you see that the majority of authors coming from India said that probably there is an amount of a disease that is not diagnosed before. Also, in this case, we have almost 200 cases is not diagnosis. And when people from Netherlands try to do, if some surgeon prefer to do diagnosis or not, there is equity in this problem. So there is a problem of cost, of course. In Turkey, is less expensive European countries, 60 euros per pathological examination. This is a diagram that has been done by Professor Kapoor. It's very, very interesting because it's the complete algorithm that you can find in the literature that analyze all the cases and what you have to do in a difficult situation. So my conclusion is this. So probably histopathology examination for us as Italian is mandatory. I explain you why. There is a 3 countries in the world in which there is a penal prosecution if you have a problem with the patients with no diagnosis of cancer. It's Mexico, Poland, and Italy. So if you have a problem, no diagnosis, the cancer, and the patients come back 5 years ago, send you, I have the cancer, but you know, do the gallbladder to pathological examination, you go in the jail. There is no solution. Is it true? Oh, if you do not go in the jail, you have spent millions of euros. So this is another problem. So this is the reason why probably my conclusion is not considered all over the world. By now, country is mandatory to do this. Right, this is the literature that analyze, and I have to conclude with a simple question. And if somebody would like to ask, I would be more than happy to have the answer. If the gallbladder is your, what you do? Thank you very much.
Dr. Pooja Shukla.
Are there any online comments as has been written?
So I'd like to thank Dr. Vinay Kapoor for inviting me here. It's very interesting to discuss these problems, and it's even more interesting to hear all the surgical issues, because that's something we don't hear every day, and that often has a pathological aspect. So it's nice to hear the discussions there too. So I'll be answering I'll be commenting on the question 7, as Dr. Carlos has commented on question 6. So now I've put this in red, my answers, because this is not necessarily an all or none question, and a lot of it depends on whether you're in a high risk area or a low risk area. So though yes, 3 sections from fundus, body and neck are usually sufficient, but that may be true more in a low risk area, and in a high risk area it may not be sufficient to not give enough sections of the gallbladder, because you do not want to miss any gallbladder cancer. And one of the articles which Prasenjit has also referred to shows how where fewer sections are taken, the 5-year survival rate is in fact lower than in countries where more number of sections are taken, because of the fact that there is increased sampling. You can catch the cancers in time and adequate treatment can be given. So although the usual section, as Prasenjit also showed, is to take the cystic duct margin and then one continuous longitudinal section which you divide into neck, fundus and body, and process it accordingly, neck, body and fundus, and process it accordingly. However, in a high risk area, if without increasing the number of blocks, you can put a few extra sections from the neck, body and fundus into the same block, then that would be advisable, because you're not really increasing the workload of the pathologist or the path technical staff, and yet you are covering more volume, which was what was explained by Prasenjit also, which is very essential. The more volume you are covering, or surface of the gallbladder mucosa you are seeing, the more likely you are to pick up any atypical epithelial lesions. Of course, if there is any suspicious area, extra sections are taken. Also, it's important to check the contents of that container, because sometimes a small polyp or mucosal region which is necrotic may fall into the container, and so the contents which you think are just debris, stone, sludge must be checked once to see that there is no mucosal substance in that. That's for the pathologist, of course. The reason being, now the other thing that we always explain to all our pathology residents the moment they start grossing gallbladders is that don't just look, feel, palpate the entire gallbladder specimen, because the flat dysplasia is often not macroscopically visible. Yes, it may not even be visible to palpable, but often if you see a small area which is firmer, it may be thicker, firmer, more granular to touch, then that area must be sampled, as that area is definitely suspicious. So now the recommendations, which I'll summarize in the end, but just to take you through these. If you see in a gallbladder pseudopyloric or antral metaplasia, it's very commonplace, we don't need to do anything extra. However, if we see intestinal metaplasia or dysplasia, without dysplasia, since intestinal metaplasia is known to occur more frequently in cases where there is gallbladder cancer, it is advisable to take at least a few more sections to rule out any dysplastic lesion. If we see low-grade dysplasia and or reactive atypia, where you're not sure whether it's low-grade dysplasia or reactive atypia, again, now the larger number of blocks I've put slashes, because the higher number of blocks may be advisable in a high-risk area and the lower number of blocks in a low-risk area. So you take a few extra sections from the gallbladder then. In a high-grade dysplasia, in a low-risk area, you may take just a few extra blocks, but in a high-risk area, it is better to whole process the entire tissue. Again, there are adenomyomatous nodules where the mucosal glands have dipped along with the muscle into the lower muscle or even the perimuscular tissue. They can be identified as adenomyomatous nodule. If there's any suspicion, a few extra blocks can be taken to rule out any malignancy. So in a pseudopyloric or antral metaplasia, no extra sections are required. Sometimes you get this sort of a polypoid appearance because of extensive pyloric metaplasia. And if these are not true polyps but just polypoid appearance less than 1 centimeter in size, again nothing more is to be done. If there is intestinal metaplasia or foveolar metaplasia, which is different from pseudopyloric, it occurs on the surface. Now in these two conditions, a few extra blocks should be taken. The panel on your left is intestinal metaplasia and the one on your right is superficial foveolar, gastric foveolar type of mucosa, which is foveolar metaplasia. Now low-grade dysplasia is when there is a clear-cut surface epithelial involvement in contrast to reactive atypia. So when there is surface epithelial involvement by crowding of nuclei, penicillate nuclei, overlapping of nuclei, it is low-grade dysplasia. These changes should not be limited to the crevices of the crypts, but in fact should be seen in the surface. In such cases, few more sections should be taken to rule out any high-grade dysplasia areas. In our institution, we allowed the pathologists to do whatever they wanted, more sections or whole process. So we found that when we took out a series of 85 retrospective disc cases and saw almost 50% had taken more sections and 50% had whole processed the gallbladder. And in these cases, only in one case, we saw a few cases which had high-grade dysplasia, but only in one case did we see an actual carcinoma in situ appearance, and that was a case in which it had been whole processed. However, still having said that, I think if you take a few more sections and it's still low-grade dysplasia, you don't need to do anything further. This is just to show you the difference between reactive atypia, which is a gradual transition often associated with some inflammatory cells, versus dysplasia, which has usually got an abrupt transition. Either way, if it's a low-grade dysplasia versus reactive atypia, you're going to take just a few more sections and look for any high-grade dysplasia. So this is an example from one of our cases. The low-grade dysplasia in the initial sections just showed a few more foci of low-grade dysplasia in the more sections, but no area of high-grade dysplasia in this. And so that was of no further consequence and nothing more needed to be done. High-grade dysplasia, in our country at least, I would recommend to whole process the entire tissue, because we know that it is often multifocal or diffuse, and then one of those areas may harbor invasive malignancy. And also, let's not forget, this is a good research tool for biomarker development, and so if you can identify these areas, we may be able to develop a biomarker to be able to identify this in a preoperative setting as well. So in our study, when we were whole processing all the gallbladders with high-grade dysplasia, and 7% of them showed further lesions away more than high-grade dysplasia, with 5% having T1A and 2% having T1B or T2 lesions. So therefore, I've clubbed that, meaning that maybe in those cases further surgical management would be advised. So this is an example of a high-grade dysplasia where you see a lot of nuclear crowding, overlapping, increased NC ratio, mitotic activity, etc., and it's often diffuse. And this was the one of the cases in which we saw T2 lesion, and we took I think it was around 30 more sections to whole process the entire gallbladder, and it was in the more section number 16 that we found the T2 invasion. In no other more section did we find this invasion, and therefore sometimes a stepwise approach in a high-risk area like ours may not be able to identify the full depth of invasion, and it's better to whole process the lesion. So which are the conditions where you would whole process? High-grade dysplasia or carcinoma in a high-risk area. High-grade dysplasia or carcinoma in situ, pancreaticobiliary maljunction because of the high propensity of risk of gallbladder cancer in these. If there is a polyp with dysplasia, you will whole process the polyp. Then take some more sections from the surrounding mucosa, and based on what you see there, you proceed. Then a hyalinizing or porcelain gallbladder, again at a high risk of carcinoma, and that too it is often not a papillary type of carcinoma but a flat carcinoma, and therefore can be missed if you're taking only few sections. In ICPN, you will process again the entire carcinoma to maybe in a stepwise manner till you find the maximum depth of invasion. So in our experience, the number of more sections required to be able to find the maximum depth of invasion was ranged from 4 to 29. So a stepwise approach may or may not help. To summarize, this is sort of a flow chart. So if there's antral pseudopyloric metaplasia, nothing further. If there is intestinal foveolar metaplasia, take a few more sections. If it's still the same, nothing further. If you see low-grade dysplasia, then proceed as that indicates. So in low-grade dysplasia, we take a few more sections, 4 to 6 in a high-risk country. Again, if you see low-grade dysplasia, nothing further. If you see high-grade dysplasia or carcinoma in situ in these, then you process the whole tissue. And if you have a polyp, as I explained earlier, process the polyp whole and the surrounding gallbladder mucosa, take a few sections, and then based on what you saw, take it back to the same algorithm. Thank you.
I would like to call upon for online comments Mr. Nicholas from Romania and Mohammed from Bangladesh.
दो नंबर दबाना नहीं उसका सॉरी
to Professor Kapoor. Hello and greetings from Bucharest, Romania. And thank you very much for having me at your prestigious Congress. And I would like to extend my thanks especially to Professor Kapoor. My name is Nicolae Bakalbasha. I'm the head of Department of Surgical Oncology at Fundeni Hospital in Bucharest, Romania, Eastern Europe. The topic today is whether we should send all the specimens of cholecystectomy to pathology. If you ask me, I believe we shouldn't, because the number of gallbladder cancer is very small, and they are in very incipient stages which do not require further treatment. So from an epidemiological standpoint, we the effort of analyzing and the resources put into analyzing all these specimens of cholecystectomy is too big compared to the benefit we draw from this. However, I would like to tell you a genuine Romanian story, and also to tell you that in Romania it is compulsory to send every specimen you remove from a human body to pathology. So the question whether we should send them to pathology or not does not apply to Romania because of the law. On the other hand, I have a little story I would like to share with you about a fellow surgeon who performed a cholecystectomy to a nurse who worked in the same hospital. The nurse didn't come back to collect the pathology report, and the surgeon didn't look at the report. 2 months later, the patient started feeling bad, losing weight, and a CT scan showed metastasis in the liver. And of course, then they went back and they looked at the pathology report, and it was a gallbladder cancer. It was a T2. The patient went to a tertiary center to get chemotherapy and further treatment, but unfortunately she died 4 months later. And the family of the patient sued the doctor, and there was a first expertise which was conducted by a famous professor from Romania, professor of surgery, who concluded that in fact the surgeon was responsible to get the patient to collect the pathology report, and actually that it was the surgeon's fault. The second report was done by me, and the conclusion was that it was not the surgeon's responsibilities, but the patient's responsibility to come and collect the pathology report. But anyway, for the surgeon and for the patient, it was a big problem. The patient died. Of course, we can only wonder if her destiny, if the patient's destiny would have been different if she had started the treatment immediately after the surgery and the arrival of the pathology report. And anyway, it was a big trauma for the family and for the surgeon. And imagine what would have happened if no specimen would have been sent to pathology. So in view of these things, we should only we should balance carefully if at least in the countries who do not have a legislation such as Romania, at least a macroscopical examination should be performed, and in case of doubt, a microscopical examination should be performed. I thank you very much. I wish you a pleasant stay, and thank you for having me here. Thank you very much. And
I would like to call upon for online comments Mr. Mohammed Sokat from Bangladesh.
नहीं ये
Respected faculties and learned audience, good afternoon and have a good day. I am Dr. Shaukat from Bangladesh, working as pathologist in Armed Forces Institute of Pathology, which is located at Dhaka Cantonment. I feel honored to join this third JSF Surgical Festival through online, and I express my heartfelt thanks and gratitude to our respected Professor D.K. Kapoor sir for giving me the opportunity to say a few words in this august occasion. I was assigned to make a comment on the question number 6, and for that reason I have prepared a short presentation, and I welcome you all to my today's presentation. Ladies and gentlemen, all 10% of the global gallbladder cancer burden. This global map depicts the incidence of the gallbladder cancer across the various regions of the world. India is among the high incidence area for the gallbladder cancer, similar to the Latin American countries. 22 out of 1 lakh population having the incidence of gallbladder cancer in this region. Gallbladder cancer is highly insidious and notoriously inapparent both clinically and macroscopically, as because the more than 1/3 of the advanced gallbladder cancer, that is the T2 stage, and about 70% of the early gallbladder cancer are missed during the gross examination, even by an expert pathologist. And incidental gallbladder cancer is gallbladder cancer detected for the first time on the histopathological examination of the gallbladder specimen, which was not suspected even in imaging or by the surgeon during operation or by the pathologist during gross examination. So the aim of my presentation is to apprise you about the rationality of histopathological examination of all cholecystectomy specimen and literature review. My question was, should all gallbladder samples removed for gallstone be sent for the histopathological examination? To find out this answer of this question, I reviewed several articles and I observed that there is a dilemma between a group of authors. Several authors have questioned the value of routine histopathology of all cholecystectomy specimen as because of low incidence of gallbladder cancer. Only 5.5 to 3% of the patient with polylithiasis will develop subsequently gallbladder cancer. The proponent of this group argue that this cancer is unlikely to develop in a gallbladder that seems normal and the patient do not possess any risk factor. And when a tumor is not visible under a microscope during a gallbladder examination, it is typically in its early stage, and straightforward cholecystectomy is the main way of treatment. In this regard, a systematic review and meta-analysis was done in Amsterdam, Netherlands, to determine whether the selective histopathological examination is safe in terms of maximum rate of incidental gallbladder cancer. Here, the 73 study, which included 232,155 patients, clinical consequence of the truly incidental gallbladder cancer were assessed. Analysis showed that at least half of the gallbladder cancer not detected during the surgeon's examination were early stage of cancer, and there was no clinical consequences. The study concluded that selective histopathological examination of the gallbladder after initial macroscopic assessment by the surgeon seems safe and could reduce cost. Another group of authors who support routine evaluation concur that macroscopic examination of the specimen can readily overlook the early stage cancer. The reason for such a dispute is straightforward, as because the gallbladder dysplasia may be missed through the inadequate sampling, since people with gallbladder dysplasia may progress to cancer and are more likely to develop cancer at other site in the biliary tract even after gallbladder is removed. One of the study done by the Royal College of Pathologists and recommend that it is mandatory to submit all gallbladder specimens for histopathological examination, as because many significant pathology can present with normal morphological appearance like dysplasia, incidental gallbladder cancer. Not only that, the histopathological examination also confirm the final diagnosis, justify the operative procedure, and document any pathology of the gallbladder, which also have some judicial importance. So this gallbladder is almost normal in gross examination, but in the histopathological examination there is a presence of the low-grade dysplasia in the lining epithelium. So in conclusion, I can say that the majority of the incidental gallbladder cancer expected to be at early stage of the disease. There are different opinions in the literature about the examination of the gallbladder specimens. Routine histopathological examination is necessary for all gallbladder specimens because it is only possible to detect the disease at its treatable early stage. Thank you all. Thank you for patient's hearing.
So there were two questions assigned for this session. Number one is histology of the gallbladder. So gallbladder is different from rest of the intestine by having a very thin wall which is comprised of 4 layers, mucosa and lamina propria, and the second layer which is comprised of muscle layer, and the muscle layer is also very peculiar in the gallbladder, that not continuous bundles are present as are present in the rest of the intestine. They are discontinuous bundles from where the Rokitansky-Aschoff sinuses invaginate into the third layer, and the third layer is also very peculiar by having a greater density of lymphatics and blood vessels. So the tumors of the gallbladder have high propensity and they have a high opportunity to go to the regional lymph nodes. And then the fourth layer is the serosa layer, which we all know that is lacking towards the hepatic side. So all the tumors of the gallbladder which reaches up to the third layer, that is the perimuscular connective tissue layer, they directly spread to the interlobular hepatic tissue and they have a poor prognosis. Then another thing is Rokitansky-Aschoff sinuses, which are actually the epithelial invaginations which invaginate from the discontinuous muscle layer to the third layer. So it is very important on the part of pathologists to differentiate between the carcinoma in situ or dysplasia which are developing in the sinuses from the invasive carcinoma, because for carcinoma in situ and dysplasia of Rokitansky-Aschoff sinuses, we all know that the simple cholecystectomy is curative surgery, while if it is an invasive carcinoma which is spreading up to the third layer, then radical surgery is mandatory. So this way histology of the gallbladder is different from rest of the intestine. And the second question was, should all the gallbladders removed for the gallstones be sampled or not? So the answer conclusively is yes, they should be sampled, and there are two reasons for that. Number one, that 80 to 90% of the gallbladder carcinomas are associated with the gallstones, and it depends upon the type of gallstones and also upon the length of duration that the stone has been into the gallbladder before developing the cancer. So all the gallbladder all the gallbladders removed for the stones should be sampled, and how it should be sampled and how the stone causes dysplasia and carcinoma sequence. So by the continuous irritation of the mucosa, it causes mucosal atrophy, followed by metaplasia, intestinal metaplasia, followed by dysplasia, and then carcinoma. So this is the sequence. Now the second reason why it should be sampled is that the biliary intraepithelial neoplasia, which is a term introduced by WHO in 2010, they comprises of two types, low grade and high grade. The high grade dysplasias or carcinoma in situ, they have a very high propensity to develop into invasive carcinomas. So now the question is, how many more sections should be examined? So we collectively have, I think, discussed in all the sessions that 6 additional sessions are sufficient to exclude or to diagnose invasive carcinoma, plus additional sections from any abnormally looking or abnormally felt areas. So with this I conclude the session if there are no further comments.
The group which is addressing these questions, two things have to be highlighted. One is, if the gallbladder grossly looks normal, are 3 sections, which is the standard routine today, good enough to detect or not to miss a lesion in the rest of the gallbladder?
No sir, additional 6 sections are mandatory if it is normal looking. If it is abnormal looking, then the entire gallbladder
Abnormal
is
is fine. Abnormal means you will do a good mapping. We are talking of a grossly normal looking gallbladder. What should be the recommended number of sections?
3 as per protocol plus 6 additional. If dysplasia is seen.
That point has to come out. What Dr. Prashant Mathur also said earlier, the recommendations which are going to come, because again the same point that these gallbladders will be looked at not in institutions. These gallbladders will be looked at periphery, the practicing pathologist. So we have to give practical, easily implementable guidelines so that cost doesn't go very high on one
Yes,
side,
sir.
on the other side we don't miss.
Yes sir, keeping both the points into consideration, financial aspect also and not missing lesions also, I think the 6 sections are sufficient enough to exclude or to diagnose invasive carcinoma in cases of
So
dysplasia.
the pathology members of this group will have to give little more details which can be understood by the routine practicing pathologist, that how and from where these sections are to be taken. That is one. Second point is, from your point of view, picking up a dysplasia or a bilin or a carcinoma in situ is all right because that is the documentation. That is for understanding the disease. But from the patient's point of view, from a clinician's point of view, anything up to T1A doesn't matter because the treatment has already been done, gallbladder has been removed. What is important is T1B and beyond. So you will have to highlight what are the chances that a T1B or a T2 lesion can be missed on gross examination, because the other group of papers which say selective histological examination, they say if the gallbladder looks grossly normal, there is no need to do it.
So as far as T1B lesion is concerned, the disease is coming up to the lamina propria, which is a part of mucosa. So gallbladder lacks submucosa and muscularis mucosa layer.
Muscularis propria.
Muscularis mucosa, not propria. Propria is there, but it is in the discontinuous form. Muscularis mucosa is missing in the gallbladder, and submucosa is also not there. So that is why the thickness of the wall is
Muscle.
T1B is up to the muscle. Okay, okay,
Muscularis.
fine.
So what the group has to say that if we follow selective histological examination, that means we don't subject the grossly normal looking gallbladder to histology, what are the chances that a T1B or a T2 lesion will be missed? If those chances are very small, then the other group is right. But if the chances are significant, then what we are saying that all gallbladders must be subjected to histology is correct.
So that depends upon where the patients are. Like if we are examining the patients in the high risk area, then of course will be.
So grossly.
Yes, sir. In high risk area, there are pretty high chances to miss the lesion.
Sir, as you have highlighted, in my presentation I made it into two ways. What are the points if selective histology is done? What are the extent we can miss the neoplastic lesions? And accordingly, there is no doubt we have to take a longitudinal section 3+1 protocol. But if we identify any neoplastic lesion, as has been highlighted by me and other speakers also, then we have to take additional section. But making it a mandatory to process the whole gallbladder straight on, it will increase the cost substantially.
Yes, I
so
also
that's
second.
why I make it like that. It is up to the institution and up to the pathologist discretion and the group's discretion. If they can afford, the patient can afford, then only that approach can be done.
Yes, I
but
also
additional
second.
section is a must and must.
Yes, I also second Dr. Prasanjit, but then there is a very important point. Like the pathologist, it's moral duty of the pathologist to differentiate between the reactive atypia and between the dysplasia. So there are certain markers also like P53, P16, but this is, I know they don't, yeah. So in case you find any atypia or dysplasia, it is mandatory to give additional section.
According to me, if you have given the sections before now of abnormal gallbladder and you are getting T1A, then how many sections more should we take to get it so that the chances of getting T2 or T1B is there? That is what the sir is asking, the percentage of sections, how many we have to take.
You have taken samples from a certain area. The specimen is with you. After you have detected carcinoma T1A in those
Yes.
sections, that means the tumor is there. You have taken from the center of the lesion, and you have to sample the adjacent area, whichever is left there and which is looking abnormal, to see if there is any deeper part or invasive part of the tumor which is left or not.
So are there any number of sections which we have to take,
Yeah,
or
that
the
we
mapping?
have already said. If there is a T1A lesion, invasive lesion, then it is better if you cannot afford the whole gallbladder mapping, take six sections. But as Dr. Pooja said, sometimes you have to take more sections. It all depends on your protocol. But minimum, whatever we are talking today is about the minimum which should be taken as a must.
One more question I want to ask. You mentioned about the distance of cystic duct margin from the gallbladder. But many a times you know that grossly we are not able to identify the tumor size. So how can we give the distance of the cystic duct margin from the gallbladder?
So whenever we are able to identify the tumor mass, then only we can give. That is for sure. And there is no such validated study also, like a colorectal carcinoma, the circumferential margin, there is a implication of the measurement. But I think always distance from the clear margin is important, and we should do that practice. So that was my personal interpretation.
So for that, don't you think that we have to give a radial section for that, not the shave one, so that we can identify how much is the distance where it is clear?
The radial section we only take when we can identify the tumor for definite and it is very close to the tumor. Otherwise, if you can identify, or if you are not identifying any mass, you are taking random sample, or you have identified the tumor mass which is sitting in the fundus, then circumferential margin is enough.
Even if you are giving random sections, they are marked beforehand in the grossing that from where the section has been given, so you know that what is the limit of the tumor and what is the distance from the cystic line.
My question is straightforward. It will have just an answer in yes or no. So it has arisen from what Monica said in the last time when she was chairing the session. If we have to take multiple sessions from the gallbladder and we feel that the small lesion can be missed, is it feasible and practical for the whole gallbladder if we take an imprint of the entire mucosa? So if it can be malignant?
No, the answer is straight away no, because many of lesions beyond the mucosa are missed.
True. And see, there are limitations of frozen section. So if we can grade that, histopathology is gold standard. Frozen section is dependable, but cross smear and touch smear we don't rely on, because it is a by chance you can identify something.
Thank you very much, chairpersons and speaker, for enlightening on this important topic. So for the next session on details of index cholecystectomy, what all informations do I need to plan the management of incidental GBC? I would like to call upon the dais our esteemed chairperson, Dr. Kulbhushan Haldania. Dr. Kulbhushan Haldania is an associate professor in the Department of Surgical Gastroenterology at NIMS Medical College, Jaipur. And to chair the session, the chairperson, I would like to call upon Dr. Rajat Bhargav. Dr. Rajat Bhargav is an associate professor in the Department of Medical Gastroenterology at Mahatma Gandhi Medical College, Jaipur. So chairperson, now you have to invite our lead presenter, Dr. Somriya Kadri, to present his talk.
Thank you. For the next talk, I would like to invite Sumaira Kadri ma'am from Department of Pathology, Sher-e Kashmir Institute of Medical Sciences, Srinagar, India.
Good afternoon, everyone. First of all, I would like to thank Kapoor sir for inviting me here, for giving me this opportunity, and I'm feeling honored to be a part of this prestigious gathering. Thank you so much, sir. I'll be talking on the details of index cholecystectomy. What all information do I need to plan the management of incidental gallbladder carcinomas? I'll divide this into two subheadings: the details of index cholecystectomy procedure, the details that need to be provided by the surgeon, and the details we get from a histopathological report. The details of index cholecystectomy procedure include the approach of surgery, whether the surgery was done laparoscopically, it was an open cholecystectomy, or laparoscopy converted into open. Then the removal of gallbladder, whether it was removed in total, subtotal, or in piecemeal. And then regarding the perforation and bile spillage, and whether this gallbladder was removed in a bag, and which port was used to extract the gallbladder, and then the date of index cholecystectomy. Regarding the approach of surgery, whether it was a laparoscopic surgery or it was an open surgery, with the advent, as we know, that with the advent of laparoscopic surgery, more and more incidental gallbladder carcinomas are being detected now, and of course we are getting them in earlier stages and they have increased survival. But laparoscopy is supposed to have certain disadvantages, like there is threat to the integrity of gallbladder, and there's breaching of the wall, and there's more risk of peritoneal dissemination, and there's more risk of neoplastic involvement at the trocar site. And we need to know whether the laparoscopy was converted into an open procedure, because at that time we may be dealing with a difficult cholecystectomy because of having an incidental gallbladder carcinoma,
and the rate of conversion of cholecystectomy has been found to be directly proportional to the T status of the patient. More the T status, more the rates of conversion. Then we need to know about the specimen, whether the specimen was removed in total or in parts or in pieces, because incomplete resection is again associated with difficult cholecystectomy, and there are chances of harboring a tumor that is in the part that's present within the patient, and the assessment of the tumor, complete assessment may not be possible, and there are chances of dissemination of the tumor. Then regarding the GB perforation within the during the procedure can lead to bile seepage, and there is that can lead to tumor seeding at the trocar site, at the diaphragmatic and liver surfaces. There can be peritoneal carcinomatosis, and obviously worsening of the prognosis. And the risk of perforation has been found to be increased when with gallbladder carcinomas. With gallbladder carcinomas 50%, and without gallbladder carcinomas it's just 36%. And there are more chances of having port site recurrences when there is perforation. It's 40% more chance of having recurrence at the port site, and tumor recurrences are more when GB perforation occurs as compared to those procedures where there is no perforation. Again, the bile seepage can lead to decreased overall survival and disease-free survival. And then the removal in a bag. We need to know whether the gallbladder was removed in a bag or not, because that can lead to, again, the bile spillage. The port site metastasis will be less, and there will be less instance of intraperitoneal dissemination. Then we need to know whether the port of extraction was epigastric or umbilical. Epigastric obviously is preferred, because port site hernia has been found to be less with epigastric ports, and the duration is less as compared to the umbilical ports. Then we need to know the date of index cholecystectomy to plan our radical surgery. It has been found that optimal time interval for resection is around 4 weeks. In one of the multi-institutional study from US, it was found that patients who were re-explored, who were subjected to radical surgery after 4 weeks, that's within 4 to 8 weeks, they had a better survival, better prognosis as compared to those who were explored before 4 weeks and after 8 weeks. One more study from India has also found around 4 weeks to be the optimal time of resection, radical resection. Then we'll come to details of the histopathology report. We will be discussing this under gross details and then histopathological details. Gross details we can note on the external examination of the specimen. We need to see the GB specimen, whether it's a complete GB specimen or only part of it, or whether the GB is in pieces. Then we need to know the integrity of the gallbladder specimen, whether it's intact or it's cut or it's perforated, any lymph node in the specimen, and we need to see clearly the hepatic and peritoneal side of the gallbladder. Then obviously the cystic, whether the cystic duct is marked or not. Then regarding the inner surface examination, it has already been discussed thoroughly that we need to do a thorough internal examination, and then the sampling also. We need to look for any mucosal irregularity, ulceration, any thickening, elevation or mass, and then the thickness of the gallbladder wall should be noted. Site of the lesion, whether it's fundus, body, neck or cystic duct should be noted, and the size of the tumor in centimeters should be noted, and the number of the lesions should be noted. It has been found that tumors having size more than 3 centimeters, there is 50% less probability of getting R0 resections. Now regarding the microscopic examination, we need to provide the details regarding the histopathological type, histopathological grade, the T stage, whether there was any LVI or PNI, and the margin status, then the nodal status and distant metastasis. Histopathological type, We will do histopathological typing as per the WHO criteria, whether it's an adenocarcinoma. Most of the times, in 90% of the times, it's a adenocarcinoma. It's a tubular adenocarcinoma, and this WHO classification has got prognostic implications. Then we need to type it properly. Sometimes we get a papillary carcinoma. They have a better prognosis, and small cell carcinomas and undifferentiated carcinomas have worse prognosis. Then we need to provide the histological grade. Grading depends upon the amount of the glands a tumor is making. If a tumor is making more than 95% of the glands, we call it a well-differentiated carcinoma, and if it's making less than 50% of the glands, we call it a poorly differentiated carcinomas. Again, poorly differentiated histopathology is supposed to have 50% probability of 50% less probability of having R0 resections. It's an independent prognostic factor, and it predicts the dissemination of the disease as associated with poor prognosis and residual disease. Then regarding the T stage, a histopathology report should be clear on the T stage of the tumor. T stage depends upon the depth of invasion. It's an independent prognostic factor and predicts the recurrence and outcome. Here I would like to mention about the recent WHO classification. PT2, that is the tumor that is going beyond the muscle. They have been divided into PT2A and PT2B depending upon the site of tumor, whether the tumor is located on the peritoneal side or the hepatic side. And it has been noticed that the tumors located on the hepatic side have more chances of getting vascular invasions, neural invasions, nodal metastasis, recurrences, and they have decreased survival. Then we need to provide the details regarding the lymphovascular invasion. It's an independent prognostic factor, and it predicts the nodal metastasis and recurrences. Then the perineural invasion, it's also an adverse prognostic factor. We need to give details on the margin status. It's considered the most important stage-independent prognostic factor and the strong predictor of recurrence and overall survival. The distance from the invasive tumor or any intraepithelial neoplasm should be noted from the cystic duct margin and from the liver parenchymal margin. Then we need to provide the details regarding the lymph node status. This will lead us to appropriate staging of incidental gallbladder carcinomas, and it has been found that with advancement of T stages, there is more possibility of having lymph node metastasis. Like in T3 tumors, 45% of nodal metastasis is a possibility. And then we need to do an optimal extent of the lymph node dissection that may be around cystic duct and around the common bile duct if it's provided with the specimen. Then obviously regarding the non-regional lymph nodes, if they are provided, and any liver sampling if it's done, and then the TNM descriptors. Thank you.
Thank you, Dr. Kadri, for such a excellent talk. I would like to invite Anu Vihari ma'am on dais. Anu ma'am is a professor in unit head in SGPGI Lucknow.
A very good afternoon to all of you, and thank you very much, Dr. Kapoor, for this invitation and the privilege to be a part of this gathering. I think Dr. Sumaira has covered everything as to what information we require about the index cholecystectomy, and maybe the points that I reiterate may be because from a clinical or a surgical point of view. So for me, because many patients are referred to us as incidental gallbladder cancer, but they are not truly incidental gallbladder cancers, because when we look into their history before the cholecystectomy, there are often subtle pointers in the clinical picture, and especially the radiology, when we have found that ultrasounds actually did show sometimes a definite mass lesion. Patient has been referred to us as incidental gallbladder cancer, but we see that there was suspicious focal thickening, there was irregularity in the gallbladder wall. So it is not truly an incidental gallbladder cancer, but a missed gallbladder cancer. And the thing is, especially if, and I also want many times like to know whether the cholecystectomy was done during an episode of acute cholecystitis. The incidence of incidental gallbladder cancer in patients with acute cholecystitis is higher than in elective cholecystectomies. And also, I think two factors get mixed. One is with acute inflammation, appreciating an associated mass lesion may be difficult. That is one part of it. And the acute inflammation makes the chances of, say, perforation of the gallbladder or any breach in the gallbladder and impairment of the radicality of the procedure. So if the acute, the cholecystectomy was done during an acute cholecystitis episode, chances are that there may have been a missed gallbladder or definitely a higher chance of breach in radicality. And there have been studies, like why I keep on harping about this, whether it was truly incidental or missed. Because when we are talking of incidental gallbladder cancer and what we should do about it, then we should stick to the truly incidental. That is the gallbladder cancers which were not suspected till a histopathology was done. And studies which have compared incidental with non-incidental gallbladder cancer emphasize that the two are different. The patients with truly incidental gallbladder cancers are less likely to have R2 resections or advanced T stages or high-grade tumors and positive lymph nodes, and definitely a better survival. The date of index cholecystectomy, as Dr. Somera also said, I don't think the issue has totally been settled about what is the best time, and I don't think any surgeon as of now says I will not do a cholecystectomy beyond a certain time unless there are definite indications for that. But most people feel that between 4 to 8 weeks is the time that best chance of curative resection and good survival are there. The procedure is important, as Dr. Somera said, whether it was done laparoscopically, whether the procedure was converted, and if it was laparoscopic, then whether they used a bag for the retrieval. The important point is that with all these things, especially any stone or bile spill, there is a definitely significantly higher incidence of peritoneal dissemination. These patients are much less likely to undergo radical resection, very much less likely to achieve R0 resections, and it is an independent predictor of a shorter disease-free survival. Again, as Dr. Somera said, whether it was total or partial piecemeal removal, one, it indicates that the gallbladder was breached, and therefore there was chances of peritoneal contamination. Any mention of adhesions to or infiltration into adjacent structures which the surgeon has gone through, like the operative details, if you are lucky enough to get those, whether the cystic plate was preserved or not, and was the specimen cut open and inspected, and were there any suspicious findings? Because if there were, if the surgeon found that there were some suspicious findings, likelihood is that this is again not a truly incidental gallbladder cancer. Histopathology, like Dr. Somera gave us an extensive list of things which are a component of the ideal pathological examination of a gallbladder specimen. For us, many a times, we have to see whether histopathology is available. Patient comes to us as, and whether those blocks and slides are still available for review, because so what were the findings on gross examination? As you said, growth, ulcer, thickening. To me, it is an indication that again, it was a missed gallbladder cancer rather than a truly incidental gallbladder cancer. The transmural extent, of course, is important because as of now, most of our indications for re-resection are dependent upon primarily the T stage, which is what we mostly know. Because the chances of having residual disease, whether it is in the liver or lymph nodes or distant disease, increases with T stage, as we all know. And we know that the presence of residual disease is the most important prognosticator of survival. Again, was the cystic lymph node present and was it involved? Because, as we all know, nodal involvement is a very important predictor of prognosis. The differentiation, whether it was well differentiated, moderately differentiated, or poorly differentiated, and any unfavorable pathological features of lymphovascular invasion and perineural invasion. Thing is, we often find that in the original pathology specimen, the report, none of this is mentioned, but when we get the slides for review and get our pathologist to have a look at those slides, then many of this information which we did not have in the previous report, we may get with our examination. Now the importance of this is that although it is the T stage which is usually taken to guide the subsequent management, if we incorporate all these pathological markers in addition to the T stage, it allows for better prediction of likelihood of locoregional distant residual disease as well as prognosis. In fact, from the American Consortium on biliary cancers, they tried to make a gallbladder cancer predictive risk score, which incorporated not just the T stage, but also the grade, the presence or absence of LVI and PNI. And they tried to then define the risk into local or distant residual disease into low, intermediate, and high risk. And they could very well see that with low risk, the chances of having locoregional disease and distant disease are near nil. And subsequently it increases with increasing number of predictive risk score. See, the thing is that we all know that if there is residual disease on re-resection, vis-a-vis if there is no residual disease, the prognosis goes down significantly. So basically, in the vast majority, what we are doing about the prognosis is different, but we are staging better. But if we had a chance of any investigation which could tell us 100% this patient does not have residual disease, there would be no point in going in. So these are just ways that surgeons may try to increase, like a T1B with none of these pathological markers, or with them, say a T1 with all these pathological markers may be worse than a T2 with none of them. So just the stage may give us less information compared to all the other, and in coming years we may have metabolic markers or histological markers which could probably tell us this patient does not have the risk for having residual disease, we may not do anything. The resection margin, of course, is very important because this will also, it will be an important consideration for the extent of resection during re-surgery, especially I think a lot of discussion around the cystic duct margin, because CBD resection increases the morbidity and the mortality without significantly affecting the prognosis unless it is truly indicated, which it will be if the cystic duct margin is positive, which cannot be made negative with a re-resection of the cystic duct margin. So basically, when a patient comes to us with incidental gallbladder carcinoma, what we are trying to do is, the information that we get is confirm that it is truly incidental, get the information about timing, the T stage, and all the important pathological markers, the resection margin status, other high-risk factors for peritoneal or port site contamination in the form of gallbladder perforation during cholecystectomy, especially with bile spill, stone spill, whether the retriever was in bag or no, and whether it was an emergency cholecystectomy, because this becomes a guide to subsequent staging and the management process. For example, in a patient with identical T stage, if there has been bile spill and if there has been no bile spill, maybe the surgeon's threshold for doing a PET scan or a staging laparoscopy prior to re-resection would be higher. So basically one kind of takes into consideration all the factors together to regard. And in my mind, as surgeons, we really believe as surgeons can do anything and they can manage everything. I don't think any of the malignancies, but also gallbladder cancer, is entirely a surgical disease. And if there is high evidence, there is a high chance that there is residual disease, in my mind, that is actually, the fact is saying, okay, we should have randomized trials so that we can do neoadjuvant, say chemotherapy, chemoradiotherapy, or upfront surgery, and compare and then say whether these two different treatment arms are different. So basically what we are trying to see is whether this patient has a chance of residual disease and is at a high risk of locoregional or distant residual disease, so that we can tailor our subsequent management to this. Thank you.
Thank you, Anuvyari ma'am, for such a nice talk. Now I would like to invite for online comment Dr. Alberto from Argentina and Dr. Mikhail from Russia.
colleagues. Thank you for your invitation to participate in very important and promising consensus on gallbladder cancer treatment. I will try to add some words on information we need to guide the management of incidental GBC. After cholecystectomy and pathological confirmation of incidental gallbladder cancer, appropriate staging is a crucial next step of patient examination. High-quality cross-sectional imaging with contrast-enhanced CT or MRI should be performed. PET is not considered as routine diagnostic modalities in patients with incidental GBC. Nonetheless, several studies reported on altering the treatment in up to 38% of patients with incidental GBC after positron emission tomography. The next step after cross-sectional imaging is staging-based prognosis of residual tumor. Up to 40% of patients with incidental GBC will have residual disease, mainly in the gallbladder bed. The primary predictor of residual disease remains the pathological T stage of the tumor. The rate of recurrence for D1 stage ranged from 0 to 37% and progressively increased with further T stages. In patients with incidental GBC, appropriate evaluation of T stage can be complicated by the initial non-oncological improper excision of the gallbladder. A more robust score was elaborated to predict the residual tumor based on T stage as well as other pathological parameters like tumor grade, lymphovascular invasion, perineural invasion. This predictive score may be used for calculation of the risk presence of residual disease. All patients are referred to one of three groups according to their total risk score, low, intermediate, and high risk. Each group was associated with increased prevalence of local regional residual disease and distal metastasis at the time of reoperation. Repeat surgery, represented by extended cholecystectomy, is indicated for stage 1B and more. Nevertheless, the role of surgery, namely in T1B stage, is still controversial. The better survival after surgery for T1B stage was confirmed by numerous studies which compare overall survival after surgery to those without surgery. The port site excision after initial laparoscopic cholecystectomy for incidental GBC is not indicated routinely because of several reasons. First of all, the incidence of port site seeding is very small, not exceeding 2%. On the contrary, port site metastasis mainly occurred after surgery for T2 and T3 stages and correlated with the development of peritoneal cancer spread. And finally, port site resection was not associated with improvement in survival. Lymphadenectomy is a standard part of repeated procedure as lead to improvement in survival in patients with T1B and T2 stages. It's important to remove not less 6 lymph nodes as it's correlated with better survival than after retrieving less number of lymph nodes. The recommended extent of lymphadenectomy includes stations around the bile ducts, so-called the first echelon, and retropancreatic lymph nodes behind the upper part of the pancreatic head, and stations around hepatic artery and right side of celiac trunk, so-called the second echelon. In conclusion, I dare to say that the rate of incidentally diagnosed gallbladder cancer is growing due to growing availability of laparoscopic cholecystectomy. Precise staging based on high-quality cross-sectional imaging and careful pathologic examination is crucial to guide further management of this tumor. Extended cholecystectomy is a standard procedure and it's indicated for T1B, T2, and T3 lesions without distant metastasis. And lymphadenectomy should include stations 8, 12, and 13 according to Japan Pancreas Society. Thank you for your kind attention.
Would you like to make some comments on the presentations? Dr. Alberto, can you hear me, please?
Yes, perfect. So, sorry because I was interrupted by the video. I will start from again. I'm Alberto Ferreras. I'm department chair, professor of surgery at the University of Buenos Aires, Argentina. Here it's in the morning. It's 5 a.m. in Buenos Aires. I want to congratulate, after thanking the kind invitation from the organizing committee and Professor JAIPUR, I want to congratulate the previous speakers, in particular Professor Quadri and Professor Behari, for their amazing presentations. The most important thing to distinct is what the ideal world and what happens in the real world. The real world is that the incidental gallbladder cancer is an histological surprise. So most times the surgeons are unaware of that they are confronted at what is going to be later informed as an incidental gallbladder cancer. In our country, we have a very low incidence. However, due to the immigration, we have seen more cases from migrants from particularly Bolivia and Chile. So, since the time frame for a reoperation is 4 weeks, this time is usually unable to be accomplished because the histological report usually takes more than 1 month in our region. And having details of an index cholecystectomy, it's most of the times a wish. However, on the other side, if we are planning to perform resection with an oncological basis for T1B and T2, both A and B, remembering that A corresponds to the size of the peritoneum and B to the liver size, most of the times, according to the Omega study published in Lancet 2023, we are going to operate most of the patients. Most of the times, in patients that have been referred to our institutions, we do not have details of the index operation, so we treat them following the guidelines that I have just mentioned. Once again, an excellent work, and I'm really sorry to miss you being present at that beautiful city, which is Jaipur, in the gold triangle in India. Thank you very much.
Thank you, respected sirs and ma'am, for such a wonderful talk. The last of this session, I would like to summarize and give a few takeaways. As we all know that incidence of incidental GBC is 1 to 3%. But nowadays, because threshold for doing lap cholecystectomy is decreasing and acceptability is increasing, so incidence is increasing. So if any patient comes to us with IGBC, then we should evaluate in divide in 3 forms, like pre-op, intra-op and post-op. So pre-op, first of all, we should see that it's a true incidental GBC. We should check or review the all records. Like in history, is there any history like is any suspicious history, or in radiological examination ultrasound that is missed by the primary surgeon, the wall was thickened or any mass was mentioned or not. Intraoperatively, we have also see that the surgery was elective or emergency. It was done laparoscopic or lap converted to open or open. In surgery also, like during surgery, is there any contacted GB or densely adder omentum? These are findings or not. And there is any bile spillage there. And also check in OT notes or talk to the primary surgeon, is there he has used the retrieval bag or not, if he used, and what port he has used for retrieval of the specimen. And again, after removal the specimen, have you cut the specimen and check for any suspicious lesion like any ulcer, nodule or polyp or irregular thickening of the JB wall. And after that he sent the specimen histopathological examination or not. After the histopathological examination, we should check for the T stage, because it defines the further management. And in other than that, we also check for the differentiation of the tumor, is it well differentiated or poorly or moderate differentiated, and there is any lymphovascular invasion or perineal invasion is there or not. And also we should check for the cystic duct margin, is that commented or not. And but last point I would like to add that the time interval is also important when this patient was referred to the HPB or GI surgeon from the index surgery, because if there is more time, then it will also change the prognosis. Thank you. Dr. Rajat, you want to add anything?
So through these two lectures, what we get to know has already been told by Kulbhushan, that it is the pre-operatively, the operative technique. So we have to consult the operating surgeon. I think this is one of the difficult thing to communicate to the person and about the technique. So I think we can, if we can develop a standard reporting system, the points which can affect the prognosis. So if they can be made in a standard reporting technique, so that all those points are mentioned and we can assess it whether it's more chances of advanced disease. Similarly, in pathology also we got through all these T stages, the grading, the margins. So if we can have a standard protocol, just like we have gone through that gallbladder scoring, where they combined the T staging and the other parameters and developed a low risk, high risk score. So if we combine the pre-operative, intraoperative and develop a score and accordingly decide, then it will be a more objective way to get to know whether it's an advanced disease or early. So further planning of the treatment can be done if a better scoring system can be developed. Thank you.
Yeah, so I think again the team which is going to address this question has to keep in mind that all this information will be difficult or virtually impossible to get retrospectively. So what we need to do is to make a small, practically usable pro forma for general surgeons, that if you are doing a lab colli, this is what must be recorded for every case. Unless it is done for every case, that information would not be available in the case where it is found to be incidental CAGB. And second is for the pathologist, that if you find an incidental gallbladder cancer, this is all minimum you must report. And in addition, we should also add that the specimen, the blocks and the slides must be preserved for a possible review at the higher center where the patient goes for further management. So, yes.
Does it make any difference in term of prognosis and management, whether you tell it or you say that it's incidental or non-incidental gallbladder? Like you said, na, if it is it true incidental or if it is not true incidental, does it make any difference in management and prognosis? Like Anu said, you must check that is it really true incidental or not by previous imaging.
Prognosis is good in
Not truly incidental and it was missed. The chances are high that we have transgressed tumor plane, there has been breach of radicality, and therefore chances of bile spill or bone site contamination is high, and that fundamentally changes the prognosis.
So you, definitely, is there a study like this?
Yes, I quoted the study where they have
Incidental versus yeah.
Incidental and non-incidental gallbladder cancers, they are different.
Okay, thank you.
Actually, on the last day, we are going to address this issue. I have requested Dr. Mahesh Goyal, who's again an expert from Tata Memorial Hospital on gallbladder cancer, that philosophical issue that are these two biologically different diseases. So I'm sure we are going to hear more on that from him.
speakers. So now we are moving to the last session of the day. That is open house session, anything and everything about GBC. And to deliver this open house session, to conduct this open house session, I would like to call upon the dais our moderator, Dr. Anu Bihari ma'am. Dr. Anu Bihari ma'am is a senior professor in the Department of Surgical Gastroenterology at SGPGI Lucknow. And we have a panelist for the session, Dr. Ankur Punia. Dr. Ankur Punia is Associate Professor in the Department of Medical Oncology at Mahatma Gandhi Medical College. Dr. J.M. Mehta sir. Dr. J.M. Mehta sir is a Senior Consultant and Head of the Department of the General and Minimal Invasive Surgery at Narayana Hospital, Jaipur. Dr. Sanjay Sharma sir. Sanjay Sharma sir is the Professor in the Department of Surgical Oncology at Mahatma Gandhi Medical College, Jaipur. Dr. Nijavan sir, we don't have another panelist.
5 minutes early, so he may be on the way.
Okay. Yeah. So might be Dr. Nijavan will join the meeting because we are 5 minutes early. So, sir, all of you are supposed to sit this way. Ma'am will moderate the session. Yeah.
We are 5 minutes early, so it's okay, you start.
So Dr. Kapoor said this is an open house, like anything and everything about GBC. And when I asked him about the format, he said, no, truly open house. So, so the panel, so we have the good luck of having a surgeon, medical oncologist, surgical oncologist. So any question from anyone in the audience on any aspect of gallbladder cancer. And if today we have been discussing incidental gallbladder cancer, so if any questions have remained unanswered, or we want to reiterate, or we want to confirm. So, or maybe I can start the ball rolling with a few questions. We, like in the last presentation, we said we want to know a lot of things about the index cholecystectomy, bile spill, there is higher risk of peritoneal contamination. So, yes, we have this information. So how does this change your management in day-to-day in terms of how you stage this patient, how you approach this patient for management?
We have already discussed in our lectures that basically we should have information of T level, that what is the T1, T2 or T3 or T4 level. Then lymph node involvement. The lymph node involvement, especially whether it is hepatoduodenal ligament is involved or it is beyond that. Some people are, especially Japanese, are taking out the celiac and aortic lymph nodes. But most of the studies, they take as a metastatic disease. So the information must be there. The third thing is liver involvement. How much is the liver involvement? Whether it is a micrometastasis or whether it is a beyond needs hepatic resection. So all these information is needed for extended cholecystectomy, and where the surgery is our first choice, we need these information. Other information which we have already talked about, that if there is any spillage of, we have talked that spillage is there, perforation is there, or bile, cystic duct involvement is there. So all these information will change our treatment, or if there is a distant metastasis, which is bilateral involvement of the liver, diaphragm or lungs. So in that case, it will change. So all these index, what you have already discussed, it will immensely change our line of treatment in these cases.
My point specifically in the context of IGBC was that if there has been a tumor breach, if there has been bile spill, the procedure was done laparoscopically, does your management in terms of staging or management differ, and in what way? Like
yes, ma'am, that is very important to know that how the previous surgeon has performed the surgery. We need to, if possible, we need to talk to him, and as the previously discussed, we need to review the slides, and we need to see the operative procedures, because it is completely going to change the management. Suppose there is some bile spillage is there. So bile spillage means it's almost peritoneal carcinomatosis has occurred. So it will be staged in a different way and treated in a different way. If previous surgeon has extracted the gallbladder without the gallbladder bag through the port, so again, though some surgeons say that port site excision is better, but studies have suggested that port site excision does not improve the survival. So overall, these things change the stage how the previous surgeon has.
I agree totally. So my point was that does the sequence change? Say for example, there is a patient without bile spill, there is a patient with spill, patient in whom the gallbladder was extracted without any bag, we know that for sure. So when we are looking at this patient in like staging and further management, like will some say the sequence of investigation be different? Say for example, would we do PET scans more often in these patients? Would we do a staging laparoscopy, re-staging laparoscopy in these patients more often?
See,
compared to another person who has not had these, and it's the same stage, same T stage.
In same T stage, whether peritoneal metastasis has occurred or at immediate PET scan won't be able to give much of the information at the same T stage. But still, we will I don't think so there will be any difference in the investigation or our treatment point of view will be different. But in making up the staging purpose, I think whole things has to be done.
No spill versus perforation and spill. How would you change the treatment for this?
So in PT1A, we need not to do much of the things if there is no spillage and the extraction has been done fine. There is nothing like that. Similarly, in PT1B also, PET scan. With spill, is the stage will change.
Management will change.
The management, it will be treated as a upstage disease. So it is not possible to go for R0 resection in that stage.
And I think what the point that Dr. Sikoi is trying to make is that normally for T1A, nothing else is required. This is intact gallbladder extracted very well. Vis-a-vis T1A, so from the T stage it doesn't require anything else, but now bile has spilled, which we take as a very important prognosticator of peritoneal dissemination. What do we do different in this patient?
Specifically, would you give
Adjuvant.
Bile spillage, as already discussed, is a high risk factor because as such for T1A we won't give any adjuvant treatment, just surgeries. Yes sir, so if it's a bile spillage and T1A, then we might consider for a adjuvant treatment. We don't know whether it might benefit the patient, but still it's a high, because it's considered they have a higher chance of a recurrence. Adjuvant chemotherapy can be considered, but not proven per se in this particular subgroup.
Dr. J, you were trying to make some point.
There has been a lot of questions about lap versus open. Now suppose I say that there is a patient, say one patient who has undergone a laparoscopic cholecystectomy having a T1B disease, another patient having a open cholecystectomy underwent a T1B disease. Will your management change in either of the two? We have been having this point since morning, whether it is lap or whether it is open.
Well,
so just for that sake,
the various studies have shown that long-term results and clearance of extended cholecystectomy are not different whether you are doing a open or a laparoscopic cholecystectomy, right? But there are some controversy in some literature that open cholecystectomy, but it depends on the experience of a surgeon. Now second thing, if it has been done a open cholecystectomy for first surgery for cholecystectomy, then it is better to do a open cholecystectomy for extended cholecystectomy. But if it has been done a radical laparoscopic cholecystectomy, then you can go better with a laparoscopic extended cholecystectomy.
I think if the gallbladder is not perforated, if the gallbladder has been handled well, if it has been extracted in a bag, I don't think it will make a difference whether it is laparoscopic or open.
So primarily, if every care is there, laparoscopic or open does not make any difference.
Yeah, but because we have
Until
taken laparoscopic this thing as a surrogate marker of higher, that way, also and a higher risk of gallbladder perforation, but the fundamental thing is not the surgery.
If that is the primary discussion, actually there were a long sequence of questions. I wanted to just end with one. But now the second one comes is, if you have done a lab chole, patient is having a tumor, now we are extracting without a bag or with a bag, but then will the other ports also have a significance? Will you like to remove the other ports also? Third thing, since there is already a gas which is in the abdomen, will it lead to more of peritoneal dissemination? If there is bile spill, it will lead to a peritoneal dissemination at the local site, or you will consider it to be a disseminated disease elsewhere also. Will it get more benefit for adjuvant therapy, which he has already addressed? And now, with the bile spill, what is the best investigation that you can do to assess whether there is a local recurrence? Because subsequently we will go for extended chole in this group of patients if he comes referred to you. So these are, there have been a lot of thought-boggling things which has been going on. So maybe you can answer one by one.
So regarding you are particularly asking for T1A lesion only, no? T1B. T1B lesions, even the PET scan has got in study from Tata that has got 100% negative predictive value. If it does not show any uptake, we can, though lymph node removal has to be done, so liver dissection can be avoided in those cases with a negative PET scan. And regarding the port site excision, the study from MSKCC single study maker has said that there on the patients in which port excision was done, there was no difference in overall survival at this compared to the same T stage. Rather, they were having more chances of 15% more chances of incisional hernia on that.
My question arises from the previous discussion that T1, obviously incidental GBC deals with T1 stage mainly, A or B. So if T1, preferably we should take, because we should be very clear in this session that preferably we should take by laparoscopy, preferably by open. Like that message should go that whether if we are taking it by lap, what are the rules to be followed which are nearly outlined in the past, like the gallbladder should not be ruptured, should be handled delicately, should be removed in endobag. Suppose if bile spills, then what measures intra-op we can take to reduce the spread of that bile? And I am not sure what literature says about the bile cytology in such cases, whether it's positive or not. So these are the points to ponder in T1 stage with laparoscopic cholecystectomy.
Sorry, before the panel takes this question about this, that most incidental gallbladder cancers are T1A or B. If you see the large series, T2 is actually the most common, and a lot of T3s also actually. So it's not that all of them are T1A, please.
So in patients with T1 lesions with bile spillage, what the thing is to be done? Nothing. We have to wait for the things and.
I'm asking about intra-op also.
But I think because we are talking of incidental gallbladder cancer, the surgeon doesn't know that he or she is dealing with gallbladder cancer. So it would be bile spill. They would do suction. They would irrigate. They would do the usual things for. I mean, what they usually do.
Right. But when we operate on polyps and all, we need to be careful actually about this.
The need to be careful is definitely.
And we need to do as routinely go for wash, and if histology comes out to be positive, then nothing more. And we have to treat whether to go for adjuvant treatment or not. We will.
I mean, at least I think about the PET scan as you have mentioned, but not all groups do routine staging laparoscopy for re-resection for IGBC. It's not a routine, but I think if bile spill is there, even if PET scan is not picking up the peritoneal metastasis, and especially if some significant time has elapsed, I would definitely do a staging lab, even during the re-resection, to pick up the peritoneal metastasis.
So I feel that bile spill should not change the plan of management. If it is T1B or beyond, even if there was bile spill, unless any of the investigations show distant disease, re-operation should be done, but the patient has to be told that the prognosis will not be as good as it is in a patient who did not have a bile spill during the index cholecystectomy.
And maybe the threshold for adjuvant therapy
Yes.
would be lower. I mean,
both for investigation and adjuvant therapy. And second, the question which Dr. Sikora asked, if it is T1A, bile spill, the only difference would be what Ankur said. In fact, I would say it more strongly, that I would probably advise this patient to have adjuvant chemotherapy for whatever it is worth. Because we know that the disease cells have spilled in the peritoneal cavity, for which surgery is not the answer. So the only answer is adjuvant chemotherapy. But for T1B and beyond disease, and this is a question which many students are not sure what to say, or many surgeons are not sure what to advise to the patient, we must come out with clearly that bile spill alone should not contraindicate re-resection if there is no other contraindication.
Yes, that's right what sir is saying, that because it is difficult to within 4 or to 8 weeks to see any peritoneal deposits that can be picked up by any PET scan or diagnostic laparoscopy after bile spillage. So it may, in a later course of time, it may develop. Yes, sir.
Can I do a question? Can I do a question?
I'm sorry.
Can
Yes,
I do a
please.
question?
Yeah, please.
Sorry. First of all, I would like to congratulate, because you analyze all the aspects. This is fantastic. Congratulations. Simple question. If you have a bile spillage, you can use hyperthermic chemotherapy, like a Schuker-Becker procedure.
See, intraperitoneal chemotherapy. There has not been any evidence of having an intraperitoneal peritoneal chemotherapy at present. You are talking of the HIPEC. So it has not been any evidence what can be done on a trial basis if bile spillage is been done.
So actually, we have done a study in AIMS for HIPEC, not exactly in incidental CAGB,
right,
but in GBC. But unfortunately, the results are that, as we always say, that GBC is more of a systemic disease. We haven't seen any change in the appearance of distant metastasis as far as HIPEC is concerned. So HIPEC hasn't really replicated the same that usually does in other malignancies. Per se, HIPEC is not a very good modality. Even if there is a bile spill, then all the more the tumor cells have already spilled into the peritoneal cavity. So further poorer results must be there.
I don't think there are studies for like prophylactic kind of HIPEC, that if spill has happened, then I'm not aware.
We have done a study with one of our residents.
For incidental?
For GBC.
For
so when we were doing extended cholecystectomies, we were giving HIPEC. There were no distant metastasis, did not have any peritoneal metastasis. But unfortunately, when we compared both the groups, there was no significant difference as far as the peritoneal metastasis coming or disease recurrence, systemic disease recurrence was there.
It's probably a representation of surgeons still trying to do local things for something which is
that
systemic.
Kings and queens and prince and princesses time.
So, I mean, what I feel on this is, I agree that when there is bile spill, the risk is high, this is the opportunity to treat, we should do adjuvant therapy. But I don't agree with what Dr. Kapoor said, that even if there is a spill, you should go in and operate. I think that patient should get neoadjuvant therapy. That patient should get a time between the re-exploration to see how it manifests, whether it manifests with peritoneal disease or no. And if you give neoadjuvant therapy, adequate time, and if there is no local disease, then one can consider if you still feel that re-resection is an option in that. So, on one stage, if you want to do adjuvant, why not a neoadjuvant with
Yeah. In fact, sir, I personally also feel that for all these markers of high likelihood of residual disease, we should be doing at least some trial. In one arm we have upfront surgery, in other we have neoadjuvant chemo or chemo RT, and then surgery. I think from Tata Memorial, they have recently in 2023, like where they have lessons learned. There's this thing where it's their overall experience, but in between they have talked about IGBC and the locally advanced, where they give 3 cycles, chemotherapy, then do surgery, and then again give chemotherapy. So I think we can extrapolate to the IGBC.
No, actually, we haven't published our own data, but when I left, Dr. Jitendra had already done a study where actually more than 200 patients were there of IGBC. And the only results that were there was adjuvant does help, re-resection does help, only in few stages, especially T1B, T2, because the Omega study, somebody quoted an Omega study. Unfortunately, Omega study is saying that even T2 does not require re-resection.
See, the thing is, T2 is not T2 is a spectrum.
Yeah.
You can have T2N0, you can have T2N plus, and you can have T2 minus the pathological factors, you can have T2 with those pathological factors, and several other unknown biological factors. So T2 is not one thing. So that is why that probably reflects in a very variable, even within the T stage.
But
and lymph node involvement.
Why we shouldn't be quoting Omega studies, because that is more of surgeon preferences rather than objective data. If you go, I myself actually I'm part of Omega collaborator, but still I personally feel that T1B and above do require resection.
If not for anything, but for
LVI,
adequate staging.
Yeah. The staging part, sir, I would still feel that it will not be staged properly because if there was a tumor in the resection bed which was not picked up by PET scan and was then picked up in the histopathology, probably the stage is slightly different than when there was no tumor in the whatever resection we did, 2 centimeter or 4B5, whatever is the patient surgeon preference. So both ways the stage differs, and lymphadenectomy is actually more important than the liver part. The Koreans, I spent some time in Korea with the Dr. Han's group, probably tomorrow sir will be there. So there they are going to publish a data about T1B, whether they don't do the wedge part but do the lymphadenectomy for them. Similarly for T2 also they are comparing between doing the liver resection and lymphadenectomy versus only lymphadenectomy, and they have data they might publish in the near future. So there are differences, and as you said, probably we also need to study more on what exactly is to be done in these kind of issues.
I think there is some data from Tata also. Means having T1B PET negative patients, only lymphadenectomy.
Only lymphadenectomy.
No liver.
They are also starting to.
No
so
liver
basically
resection.
the same discussion is there. They are discussing among themselves.
No
is this
liver
only,
resection needed.
whether the liver resection actually required, and if required, in what patients actually liver resection should be done. So subset is there where actually you will require liver resection, but you have to carefully select these patients. That is
Dr. Nisar.
Ma'am, as part of this staging protocol for incidental gallbladder cancer, contrast enhanced CT scan forms the standard protocol for evaluating incidental gallbladder cancer. When should we add contrast enhanced MRI to the workup?
You mean MRCP or MRI? Both.
MRI.
So MRI, they say that if there is a metastatic, if there is a metastasis, to detect the metastasis, if there is a doubt on CT scan or the things are not clear, then we can go for MRI. Then they are more contributed to each other. So basically, they do better for the metastasis.
On contrast enhanced CT scan, if we already have a suspicion of, or if we have any lesion suggestive of metastasis, we can simply go forward with the FNA and confirm or refute it. Then is there any additional role of contrast enhanced MRI?
See, the biliary duct involvements and all, they are better seen on MRI, but contrast enhanced CT scan is, phase CT scan is much better than.
Because early in the presentation, I don't remember that gentleman's name, he was insisting that he would prefer contrast enhanced MRI as compared to the CT scan.
But if CT scan has shown metastasis,
no, otherwise also they were insisting that no, CMRI should be preferred as compared to the CCT. Yes.
Just wanted to know, is there any role of intraperitoneal wash and cytology during second surgery in a patient who had bile spill? So we can,
sorry, intraperitoneal
like in
wash.
ovary we do it.
Well,
So
intraperitoneal wash, it is done, it will add to the diagnosis, but it is not 100% foolproof that you will detect the smaller metastasis. So it can, with laparoscopy, if you put some saline and do the cytology of that fluid, that will help in the micrometastasis.
and my question to medical oncologist also, if it is positive, suppose in second surgery I have done intraperitoneal wash and it's positive, should we proceed for the resection, RZ resection, or should we stop and give the neoadjuvant or adjuvant, whatever you call?
Peritoneal cytology comes positive, then it's basically peritoneal disease.
Yes.
The patient becomes palliative irrespective what kind of resection we do. I don't think there is a benefit of going for surgery in such cases.
So ideally it should be added in as a part of our procedure in second surgery? Question to the house.
So, see, though the peritoneal washing has not been, there is no more data on that, but still that can be there if previously bile spillage has been done.
Yeah,
it is difficult to pick up
scenario.
so early the malignant cells at this stage, because that is done at an interval of 4 weeks or within 8 weeks only.
So we are doing second surgery at the interval of 4 to 8 weeks only.
Right.
So that's why I'm asking.
So if it is positive, surely we need to.
So I think it should be included in as a part of this thing, second surgery. That you should always do peritoneal wash and check for the cytology. That's
But I
what
think we'll probably have to do a prospective study to see the exact sensitivity and specificity to be able to say that.
Ma'am, if there is a bile spill during the index cholecystectomy, so is there any role of normal saline and distilled water if we wash the peritoneal cavity? It will reduce the risk of peritoneal carcinomatosis or not?
So there has no been data because it is previously it is an incidental. We don't know whether there is and bile spillage occur. Peritoneal washing, whether it reduces or not reduces, there has been no much of the data, and there has been we can do that. That is different thing. At present, there is no data on that. Routinely, we are doing that. No?
You are doing routinely? At the time of resurgery?
No.
For CAGB?
Normal gallbladder, ma'am.
Oh, giving a wash, yeah. That.
Actually, I want to know, I am read from somewhere like distilled water is much better than normal saline. So what your comment, like is it true or like still in?
I don't find, because routinely I have seen only the use of normal saline during surgeries. Use of distilled water, I don't see if any.
I think Kapoor sir will.
Yeah, actually I used to do it not in cholecystectomy, but if you are dealing with a malignant disease and there is spill, then rather than washing it with saline, because saline is only mechanical washing, whereas distilled water will cause autolysis of whatever cells are there because of water getting into the cells. So that was the hypothesis. You can use either distilled water or hypertonic saline. Distilled water is easily available in the theater because there are so many ampoules of distilled water lying there.
So I think so we should also be noting down points for future trials or studies that arise from these discussions, because we really don't have exact answers. We really don't, especially from our area.
Another pointer regarding the bile spill, one thing which should be mentioned at least in the OT notes, or which we should say that it should be done, is whether the spill is controlled versus an uncontrolled spill. There was a group which actually looked at this, and they showed that in uncontrolled spill, the distant metastases were significantly more compared to a controlled spill. Controlled spill, I'm saying in cases where you either open the cystic duct to do a IOC, or you intentionally decompress the gallbladder when you're not able to hold the gallbladder. Just a pointer.
Yes, there are many studies that bile spillage during doing cholangiogram has got less chances of recurrences than gross bile spillage.
Yeah, just making a point that it should be noted down in the OT note, or at least it should come in our consensus that it should be noted.
gallbladder, it's a usual technique to put in an aspiration needle and aspirate. Suppose that patient turns out to have malignancy in histopathology, so should that be done or?
So
That is exactly the point that I was making, that there was a study which looked at this, whether this intentional decompression leads to an increased incidence of metastatic disease, and they found out in their, I think the numbers were lesser, but less obviously, but they did find that when it was an unintentional, uncontrolled spill, then the incidence of metastatic disease was more compared to intentional decompression. That's what they found.
So
Dr. Ajay, you said there were more questions to come.
You are asking whether to hold the gallbladder and go for decomp. In incidental gallbladder GBC, we are doing surgery as per a normal benign disease. So I think if we find some sonographic finding or we suspect, then only, otherwise we should not, we can routinely, for a benign disease, we can go for it in a controlled fashion. Yes, yes, it's a tense.
Okay, first one, circumferential thick wall gallbladder. You want to do a anticipatory extended cholecystectomy, meaning to say you want to remove the wedge of the liver. What is the size of the wedge that you want to remove? 1 centimeter, 2 centimeter, 3 centimeter. I think Dr. Anu has a publication, so maybe you can directly.
No, today I am asking the questions.
Answer I know, so I want somebody else to answer that.
We need the answer of someone who was not in favor of this.
I think, sir,
Sir, you
can comment on that because that is important.
In fact, there is a counter question from me. In extended chole, how do we know 2 centimeter? Why not 3? Why not 1? Why not 0.5? Why is it 2? So I think it's very arbitrary. There is only one publication from Japan where they did multiple serial sections of the liver, and they showed that micrometastases are usually confined to 2 centimeter. That also I dispute. What is the anatomical basis that micrometastases have to be confined to a certain distance? If the tumor has gone into the bloodstream, it would go anywhere. So my point is, initially when we described AEC, we said 2 centimeter because the standard for EC also was 2 centimeter. But my question is that even 2 centimeter is not sacrosanct. Even 1 centimeter may be good enough. In fact, there is a very recent publication where they have shown that a smaller wedge gives rise to less morbidity. So that is why I am going to say that AEC, if you are doing in a low suspicion case, you take maybe even 5 millimeter wedge of the liver. Idea is to stay clear of the tumor if the tumor is there in the GB wall. That is the basis of AEC. So I think I am going to redefine the definition of AEC from 2 centimeter wedge to a small wedge. We may or may not say how many millimeters.
So maybe this is this thing for another study where we look at all our extended cholecystectomy specimens and the liver wedge and see in how many did we find the micrometastasis and up to what distance. Like
more the
There is not to take care of the micrometastasis. In gallbladder cancer, if you are saying there is a discrete metastasis, whether it is micro or macro, it is a metastasis.
Yeah.
Wedge is to keep the margin clear, to have an R0 resection margin. That, whether it is like 1 millimeter as in colorectal metastasis, or whether it is 5 millimeter or it is 1 centimeter, nobody knows.
No, so I'm just from the study that you were quoting that the 2 centimeter came from this thing that usually it is not beyond.
No, I'm not sure whether it came from that or whether it said that 2 centimeter is good, because you read the German cancer registry data on incidental gallbladder cancer, they say if it is T2, they recommend a 3 centimeter wedge.
Sir, if we do the AEC and if you remove the 5 mm only wedge and it comes positive, then again we have to 2 centimeter liver wedge or just lymph node resection?
That is what I am saying. For a standard EC also, why 2 centimeter? Why not 5 millimeter? Who says? Margin has come positive, yes. Margin positive, but that is why selection of cases for AEC has to be good. AEC would be done when you have a suspicion preoperatively. So that means you must have done a CT or an MRI. That should show whether there is liver infiltration or not. If there is liver infiltration, treat it as like gallbladder cancer, do a standard EC, whether you believe in 2 centimeter, 3 centimeter, 4B and 5, whatever your policy. AEC would be done when the suspicion is low, when there is no liver infiltration. So if you take 5 millimeter wedge, why should it be positive?
I would extend that term. I think I want to tell sir earlier also, our intention is only to go beyond the cystic plate. Intention is not to go into the liver. We are not going in the liver if we have high suspicion. We're just removing the cystic plate en masse with gallbladder so that we don't breach that area which is just adjoining to it, because there is no serous over there. Now next thing is, suppose you have a gallbladder mass and you think you want to give him new adjoint. So which is a better investigation, FNAC or a biopsy?
Biopsy.
They don't do it without ISC.
Preoperative.
We have a pathology. Dr. FNAC or biopsy?
No, but for preoperatively, you have a GB mass.
Yeah.
You are asking for a true cut biopsy?
I'm asking, you have to give a new adjuvant, so what is better? Are you enough with FNAC or you definitely want a biopsy?
What changes between FNAC and biopsy that will change your decision about neoadjuvant?
That's what I want to ask pathologist.
Biopsy means I am taking it as a FNB.
Correct.
So you are taking either FNSC or FNB from the same procedure, and it will give us more tissue, more cells to, we will be able to confirm better if it is malignancy or not.
Suppose you get a positive FNAC.
Then will also it will serve the purpose.
That is so. Then now if you want to do some IHC or something into that.
See, from the FNAC also we can make the cell block. That is not a
Yeah,
issue.
but,
The
I
FNAC also we can do sequencing. So that is not an issue. But FNAC, the sample should be adequate. So either FNA or FNB or FNAC both will serve the purpose, but for the more tissue, FNB will be preferable if you are taking.
So this question had come from one of the slides which was shown that we have to take a transhepatic biopsy and blah blah blah. Something was shown. So at that time it struck to me that I think FNAC is better rather than biopsy. Then it came to me, is it the biopsy that is required for IHC? And so the message is that FNA will give you equal IHC. You can do IHC with FNA slides also. I think I am correct if you are getting it positive. You can make a cell block out of that.
But in the neoadjuvant setting, are we looking at anything other than the presence of malignancy, like as of today?
Is it adeno? Is it squamous? Is it something else?
That is a
Like
type of malignancy.
As that on an FNAC they will be able to
they
say.
will be able to comment.
Yeah, that's what I'm saying.
Talking about the type of malignancy, 95% it is
Mm.
always
Adeno.
Even if we see few squamoid differentiation, we see that in poorly differentiated gallbladder adenocarcinoma. So we never diagnose on the FNA or limited sample material. It is a primary squamous cell carcinoma. So it should be taken as adeno with some squamous differentiation.
So from pathologists, coming back to the surgeons again. So how many of you do a Taj Mahal resection for a carcinoma gallbladder?
Taj
I have
Mahal
not done.
resection is not needed in this. It is only, you mean to say extended liver resection and bile duct
I have not
resection?
done.
Anybody doing? Dr. Sadiq wants to say something, I think.
Central resection.
So it's segment 4B5. Normally we have been doing for 3 to 4 centimeters, which has come down to 2 centimeters. Taj Mahal, which was at one point in time was very much propagated, is no more done. Now coming back to the incidental carcinoma gallbladder, you get a biopsy of which has been taken by patient. Normally we expect it to be after 7 days. The patient comes after 1.5 months and he says that he has biopsy which is CAG. How will you take it?
After 1.5 months he comes. We will review and we will investigate the patient for further. We will ask whether all the things is to be done.
So if he comes after 1 week you will not do, but if he comes after 1.5
No,
months you will do.
No, we will do.
The same patient is coming, one patient is coming after 7 days with a biopsy, one patient is coming. Will the time factor change your plan of management? And maybe the extension of the question is, for how long can you go ahead with the surgery after how long period? Maybe after
No,
patient
it is
comes
not
up-
that. The studies have shown that 4 to 8 weeks is a good time to do the surgery. But still, after 8 weeks, slight there is decrease in survival. But if patient comes after 8 weeks, we need to do all the things which we are going to do at 4 weeks. And we have to give the benefit of surgery to that patient also. Though survival rates may be slight less, but we need to do that.
So basically what you're saying is that the need to stage the patient at whatever time the
At
patient
whatever
comes
time
to
the
us
patient has come.
remains, and
Yes.
then do the management accordingly.
Accordingly.
That will stay for earlier
Of course.
also. If the
So
patient
if
comes-
the biology is playing a role when you stage, it would be.
Yes.
But you have to do the same thing in a patient who actually comes at 6 months also. Supposing the patient comes after 6 months, do all your workup, you do your PET scan, you do your staging reference. If you don't find a residual disease, obviously he has got a better biology. He actually warrants a proper management in that case. You can't say that he has come after 6 months.
So I'll come to that also now in a minute. So now you have a patient. So the message is the patient whenever he comes, he needs a complete evaluation, and if the patient can be benefited by surgery, he should get in for surgery. But if you get delayed patient without any metastasis, without any nodal disease, and PET negative, this patient is going to behave better. So he is in your course of treatment. Rather, he will be in a better surgical move. Second thing, suppose this same patient has a papillary carcinoma, incidental papillary carcinoma, and versus. So will that change your plan of management or evaluation?
The evaluation will be the same. The evaluation and the management will be the same. Evaluation will be the same.
Maybe anybody, sir. Kapoor sir, yeah, I know.
So papillary carcinomas are known to be more frequently multifocal, multicentric. They also tend to break the point which I think Sumera you made that, or Dr. Pooja made, that in the specimen bottle you should look for fragments because a polypoidal lesion can fragment. So they are more likely to have multicentric, multifocal, intraductal CBD deposit, and that is why some groups, especially in Japan, because their papillary carcinoma, which usually occurs without gallstones, is more common, they routinely advocate a CBD excision, although they don't do it in every case. But in papillary carcinoma, they say that CBD excision should be done. But my objection to that is that if it is going to be multicentric or multifocal, what about the intrahepatic bile ducts? You are not taking care of them. So that's a debatable thing. But the other is that in papillary carcinoma, probably your threshold to give adjuvant therapy would be lower. So even if there is no other indication like T or N stage, but if it is a papillary tumor, probably you should give adjuvant chemotherapy.
Regarding this question regarding the delayed presentation, there's a group in UK which actually does a delayed staging of these patients. I think they stage their patients at around 3 months.
3 months to
post
choose them.
their presentation, and they have shown that they've avoided unnecessary surgeries is what their conclusion. I don't remember the numbers.
But that group has shown that the patient who the survival in the patients means that the some patients presented with the upstage.
No, basically what you're doing is you're giving a biological selection.
You are seeing the
selecting
tumor
patients with
biology,
good
whether that remains.
favorable biologies.
But still, some patients have in that group. Some patients have come in upstage disease.
But some of the recommendations are actually not attuned to what exactly gallbladder cancer is, especially with the T1B and T2 disease, where if you say that we're not going to resect the patients and it will be better, I guess in our scenario that cannot be extrapolated to Indian scenario per se, especially with the tendency here.
A case scenario, if there's a young patient who presents with gallbladder cancer involving the entire right lobe and segment 4 with no distant mets on PET. So, and segment 2 and 3 is free, no vascular invasion, is adds a possibility for patients with gallbladder cancer or should be avoided?
The patient is a known case of gallbladder cancer.
Gallbladder cancer with involvement of the entire right lobes and segment 4. Segment 2 and 3 is free. There is no vascular invasion, no distant metastasis on a PET scan. Young patient.
So you mean to say whether to go for surgery or not go for?
Yes.
So
But volume would be low if it is only
right.
segment 2 and 3.
The extensive resections in gallbladder, getting an arterial resection surely improves the survival, but the volume of disease and extensive liver resection is not going to help much of that case in that.
But are you sorry? Yes.
Give my perspective on it. So obviously this is quite an advanced disease. We don't know the biology. I would rather do a CA19-9, see how levels are. I may do a PET CT in this patient to see for metastatic disease. And if all that is negative, I would still give neoadjuvant therapy for this to see the response to treatment. So I won't think of going for an ALPS in this patient because the likelihood of cure in this is very low. So I would rather look at the biology unfolding in front of me than going in for surgery straight away.
Yeah, I agree. In fact, some of these tumors, actually, a much smaller tumor but with extensive nodal metastasis may have a more aggressive biology, and neoadjuvant would allow you to see whether this patient actually falls in a good biology where you can offer surgery later.
So our medical oncologist had a concern that suppose if we give neoadjuvant, then and if she doesn't develop a metastasis even after the neoadjuvant, and then we consider ALPS, so the remaining liver will grow or the chemo effect will be there on the liver.
Yeah, I think that is a very valid concern, and I don't think we have enough data to answer that question.
Saurabh, this Anita Balakrishnan paper, did I get you correct that they are saying even T2 no reoperation? No. I'll have to read it again. But T2, there is no debate, there is no controversy, reoperation has to be done. No, T1B is okay. So, and T2, the only debate now is the peritoneal and hepatic side. T2A and T2B, and there are some Korean studies also which show that if it is T2A, you need not do the liver wedge, you only do lymphadenectomy, although personally I don't agree with it. But T2 for reoperation, there is no debate. I will read that again, and if she has written that, we must write to her that this is. You didn't highlight that. Yes. Okay. So we'll have to read it again. Now the point which Ajay was asking, I would extend it further. Incidental gallbladder cancer, for whatever reason, patient did not receive reoperation and did not undergo chemotherapy. It was T1B or T2, even T2, and the patient comes after 1 year. You do a PET scan, there is no disease. What would you do?
We will wait for that because the tumor after 1 year also the patient has not developed. I think if it is a T1B disease, nothing is to be done. Even at T2 stage after 1 year, no disease, PET scan shows nothing. I don't think so there is need of re-exploration in this patient.
Yeah, because as an extension to that, Dr. Mahesh Goyal's group, Tata Memorial, they have shown that in T1B, if the PET is negative, I think somebody said that they don't do wedge, but I think they say no reoperation.
No reoperation.
So T1B, if the PET is negative, they are saying observe the patient.
For staging purpose, lymph node has to be, for staging purpose, lymph node dissection, still it is there that we can go for avoid liver resection, but for staging purpose, lymph node dissection has to be needed in
I
that.
personally don't agree with that. We will have to wait and see what happened to these patients over a period of time, but that is what they have written. No, once the diagnosis of incidental CAGP is made, I think most of us for doing a PET scan would wait for the surgical changes to settle. So I suppose you would like to give at least a couple of weeks time before you, otherwise the surgical changes may look like residual disease. But in that paper they have said that in T1B disease, if PET is negative, no reoperation,
just follow up.
Sir, in Tata Memorial, I don't think any patient with T1B would be coming at day 7. All the referral centers would get patients in the delayed this thing, so that probably would not be.
So, we are talking of we have to do and there is cure, but there is a good body of literature which is collecting. It says irrespective of T stage, if there is residual disease, it portends poor prognosis.
Yes.
So you are not going for cure. You are going to surgery to find out whether this patient is good biology or bad biology.
Why not do that with neoadjuvant?
Or with other methods of. So that's what this study by Tata Memorial with PET scan said L PET positive, that is a local PET, no positive, and there is a difference in early stages that no positive in PT2 may have some residual disease in the lymph node, but never in the liver. So that's why if there is no disease, they would not suggest doing it in that scenario. So I don't know whether the reoperation is for cure or for staging.
So I keep on saying this always, because right from the time this thing on re-exploration came from Memorial Sloan Kettering, Duffy et al. I always they did for their 10 years results. They are the most aggressive surgeons in the US for gallbladder cancer, and what they find is best results are when there is no disease, means you are taking out normal tissue. So that's what we are saying. So you.
That is going to get benefit if there is no residual disease present, if your nodes are negative, if you have a node positive disease, even if it is T2, if there is node positive disease, this patient is going to fare bad.
So if you have a benign CAGB, that's what you are saying.
Yeah, even if you are doing extensive resection, you do whatever lymph node clearance, you may do whatever liver resection, they are going to fare badly. Only thing that is going to help CAGB patient is he is having an early disease. That's all.
Ma'am, that's what I'm saying. For referral centers, usually no patient comes within the first week. But if we are own, yeah, that is for that.
Ma'am, regarding the reoperation of these patients, like the patient who has incidental CGB, in the literature, approximately 4 or 5 studies I have seen, because I have collected the data with the Kapoor sir regarding this, and only one study, which was a prospective study, which was saying that delaying the treatment in these patients, which is beneficial because they have basically knows the biology of the disease. The person who is having aggressive disease will get disease within 3 months. So that's why they have told that we should delay the surgery in these patients. So they can select the group of patients, and we can go, if the patient is selected, they have metastatic disease, they can be ruled out, and other patients they can subjected for the surgery. And one or other 2 or 3 studies, then there are retrospective studies. One of the SGPGI studies, they have suggested 4-week duration. Within 4 weeks they should go. One study from another group, they suggest 12 weeks, and one in between, around 6 to 8 weeks. So we have three groups: early, within 4 weeks, 6 to 8 weeks, and 12 weeks. But the only prospective studies they are suggesting we should delay the surgery in cases of incidental CG.
There is one thing which we have to understand. For all malignancies, the neoadjuvant principle remains the same, what you are saying. The principle is, if the behavior of the disease is benign, if it is not very aggressive, you are going to save. So the surgeons tend to get the lesser number of surgeries into their basket, and only those which have a good survival. So that is the basic principle of delaying anything. That is same principle for neoadjuvant, same principle for CAGB. If you delay somebody who is going to have metastasis, that's why you are getting a PET scan immediately after that. If he has mets, so you don't operate that. So delaying is as good as that. But if the same patient had only a primary disease at the same site, and if you resect it, he may have survival. He may get a.
Sir, I don't agree with Ajay sir. Sir, means you are saying that whether a T1 lesion we operate, it is having, there is no further disease, the patient will have good survival. Even we are increasing the survival, overall survival to the patient who are having T2 or like that by clearance, by doing staging or clearing the disease. So saying that they can be put in the same basket, whether the patient has got a survival of 2 years or 5 years, it is not fine.
I'm not saying that. I'm not saying that. What I am saying is, you get a small proportion of the patients in your surgical basket who will have a good long-term survival. What we are telling is a group of patients who will have a survival of 10 months vis-a-vis 12 months or 13 months. So that 3 months additional advantage you are telling. I am telling the group of patients who will have a better long-term survival. Those, if you do operate later and if they don't have metastasis, definitely they are the ones who are going to survive better as compared to any other.
One thing more, sir. In case of incidental CGB, we are getting patient outside, so usually we don't know the exact history like bile spillage, which we were discussing previously. I think maybe these patients who had a bile spillage, they can get selected with waiting for some period, because the patient who had a bile leak, probably they will develop peritoneal mets within few periods of time.
Dr. Anand, because it is very difficult to get this history, and even the lab quali has been done at a periphery level, at a big, I don't think so they are using a endovax also. So in incidental carcinoma, if we get that history, giving a patient treatment benefit, I think that is a more appropriate than asking the patient to wait for that on this.
This recent evidence which is coming that delay the treatment of incidental gallbladder cancer to 4 weeks, 8 weeks, I think there is a report 12 weeks also. How can you wait for 12 weeks in a patient with known malignancy, possibly early curable malignancy, and give no treatment? Will it be justified? Are there medico-legal implications? While you are waiting, should you give neoadjuvant treatment? Those are the issues which need to be, I think, debated, because in any other malignancy, would we tell the patient that no, we would like to wait for 12 weeks to see the biology of the tumor without doing anything?
So these are all retrospective studies actually. Patient
making this recommendation in the end.
That is the poor part about it. So the thing is that you can't equate two apples and oranges kind of a thing. If someone was a CA prostate supposedly, you could say a watchful waiting is a very good option, and I have personal experience. My father-in-law has, and 3 years down the line, same stage. But a patient malignancy, which we always know has such a poor prognosis, despite all the aggressive treatment that we can use, adjuvant, neoadjuvant, surgery, everything, and then to delay them for 12 years just for the sake of selecting the better outcomes is actually a poor way of treating patients, and not ethically advisable.
But maybe doing them early and not getting the same result.
No, not the surgery part. I am saying giving them treatment. If not a surgery, which is an invasive thing, then probably a chemotherapy if the patient is able to tolerate that. If a couple of cycles of chemotherapy and patient is tolerating and he is actually responding to that, then maybe you can, so kind of a perioperative therapy. You give a perioperative, give 2 cycles, 3 cycles chemo, see if the patient is behaving well, not actually progressing, and then do the surgery. Maybe that kind of a progress can be done. But to wait for 3 months in a patient who we have diagnosed his malignancy, probably we won't be able to justify. That's what my.
So 5 more minutes if there are any other questions or comments.
For these patients, I think this is the ideal time to do a different kind of thing for these patients rather than just wait for 12 weeks. So I am a medical oncologist, so I'll say why not give them chemotherapy and see. Recently, Tata has published this data regarding they use a lot of neoadjuvant chemotherapy in biliary tract cancer. And they have, I think, they have compared 250 patients, they have received neoadjuvant compared versus who have received adjuvant. And their overall survival was same. They were not selected based on this criteria, there was incidental, but they have taken locally advanced or advanced gallbladder. So whether they have used adjuvant or neoadjuvant, the survival was same. But we might be the same thing. We might be able to give some treatment. We know that all patients will not get benefit from that chemotherapy. Around a 20-25% of subgroup, response to chemotherapy might have that benefit. So we might be able to give benefit to a subgroup of patients, but not to all.
According to the MSKC, there's a study of neoadjuvant therapy. They say it is better for the micrometastasis or aggressive tumors. But slow growing tumor, the neoadjuvant therapy has not been very helpful in their study. So if there is an aggressive tumor and it is not advanced, whether it is locally advanced, then we can try this neoadjuvant therapy according to their study.
One small query regarding the neoadjuvant, I'm diverging from the incidental part. So to give neoadjuvant, how do we define whom to give neoadjuvant? What is the inclusion? What are the patients you're going to include? because locally advanced can be a lot of things. Locally advanced can be a local organ involvement, locally advanced can be a vessel involvement. So we have to clearly define these criteria. I did a very small study, about 7 patients. I had a trial when I was for 2 years in Himachal. 7 to 8 patients only. 4 of them responded really well, but most of them had local organ involvements. Only one was in which vessel involvement was there. And this was actually an offshoot when I had read about the first paper of Tata, which was about 38 patients initially. There also it is diverse. So we have to first define who will actually benefit with the new adjuvant also, whether it is the vascular, the local involvement. We haven't defined that.
I
Maybe
think
that is one
Tata-
area we have to think about.
Tata, they say like T3, T4,
Yeah.
N1. They've taken as local regional disease or locally advanced disease.
But the
at
most
least in
of the
depth.
patients who are actually under sickle, ma'am, are actually those who are vessel involvements. Because once right hepatic artery is involved, larger chunk of liver is involved, you're not operating. So only thing you're left with either portal vein embolization or give new adjuvant. And we have seen neither portal vein with us, even in AIMS New Delhi, hardly any patient of portal vein embolization eventually leads to the operating table.
I think neck tumors in any case are very different from those in the fundus and
that
the,
is what I'm saying. So you have to define a clear subset of patients which actually are going to benefit with the new adjuvant approach also. So not just taking all diverse patients and then seeing, because 178, the second was 178, now 13,000 something.
1,300 patients.
1,300 patients has been published. So, but that is a diverse group.
Yeah, because that's retrospective, and therefore again the need for.
So we haven't defined
prospective
what we
studies.
are looking for. We haven't defined what is our target population or the target, and we have to first define that and then go ahead with whatever.
So Tata is, I think, doing a study, Polka GB study, in which they are giving a neoadjuvant. They're comparing actually neoadjuvant chemo versus neoadjuvant chemo RT in patients who are potentially resectable. I don't know the exact criteria.
So
they have 6-7 criteria
again,
in that.
One of our residents already did this study long back, and we actually abandoned this study because chemo RT versus chemo, we did not find any advantage. And because it's very difficult to give RT at a place where GB is, a lot of complications patients do not tolerate, and we did not have any successful.
In the neoadjuvant setting, maybe more benefit, but
maybe.
Adjuvant, it's actually very, very difficult, but maybe in neoadjuvant. That's why they are doing in neoadjuvant.
We did in neoadjuvant only, small subset, pilot study, 20 patients each. Poor results. For us, at least it was poor results. Maybe they have better results, we are not sure.
They have defined some subsets, I don't know exactly, but for patients who had some features resectable, they have not taken. They have taken sort of potentially resectable patients only in that study.
I think we have had a very avid discussion, and so now I think it's time to shut up the guys. Thank you.
Thank you, the panelists. Thank you very much. I must say that when Anu was introduced, it was that she was a professor of surgical gastroenterology at SGPGI Lucknow, but that probably was incomplete. She is one of the few people in India who have made major contributions to gallbladder cancer. She knows a lot about gallbladder cancer, and in all the publications which have emerged from SGPGI AMS, she has played a very, very important role. So with that, I think we come to the end of today's session. Just two announcements. Today, for all the faculty and the accompanying persons, there is a dinner again at the same place, Pride Amber. And tomorrow, the chairperson, emeritus and chairperson of the university, I have sent the invitation to all of you, has invited all the faculty of our conference, as well as there is another conference which is going to be held tomorrow and day after, a Medical Science Academy conference. So the joint banquet dinner, where the senior administration of the university will be present to welcome you. So please keep your evening free for tomorrow also, all the faculty and the accompanying persons. Thank you very much. And we have a cup of tea outside. I think.
Those who are staying there at Pride Amber Villa, we have the facility to transport from here to the Amber Pride Villa. A bus is there. So after a cup of tea, we can go there. Hai na? Hai, sir. Hai. Thank you very much.